Hi, everybody. Good morning and welcome to our Clinical Pediatric TB Intensive webcast. Again, I apologize for starting a few minutes late. Hopefully, everybody is able to view the presentation on the screen. This webcast will be recorded and available for viewing later. I will also upload the presentation handouts to the chat pod along with the sign-in sheet for those. And the sign-in sheet is only if you're viewing as a group. If you're viewing individually on your own, you do not need to complete the sign-in sheet and turn that in, only if you're viewing as a group. So before we get started with our first presentation, I just want to give you an overview of Heartland National TB Center and the services that we provide. So Heartland National TB Center is one of 4 TB centers of excellence for training, education, and medical consultation funded by the Centers for Disease Control and Prevention. We are located in San Antonio, Texas, and cover 10 states plus 1 high incidence metro area, which is the city of Houston. We are also responsible for providing service to the U.S. territories. Our mission at Heartland is to build capacity with our partners through expert medical consultation, cutting-edge trainings, and product development. Dr. Seaworth, Dr. Armitage, and our other medical consultants are experts in TB, MDR-TB, pediatric TB, and TB comorbidities, including TB HIV and TB in patients with medical health issues. Consultation services can be acquired by phone or email. You can reach our warm line at 1-800-TEX-LUNG, or you can visit our website. Heartland conducts several trainings throughout the year. Our core courses include Introduction to TB Nurse Case Management, Online TB Nurse Case Management, and TB Intensive, and are held 2 to 3 times a year in San Antonio, Texas. Other courses are developed and implemented in collaboration with the host state. Heartland also hosts webinars covering a variety of topics. So following are just a few of our upcoming courses for 2021. For more information and to register, please visit our website. We also host clinical TB mini fellowships targeted to clinicians and nurses. These fellowships are 5-day-long courses targeted to the needs of the attending clinicians and nurses. The courses consist of presentations, rounds with physicians at the TB hospital, and a clinic visit to the TB City Chest Clinic in San Antonio, Texas. For additional information, please visit our website or call 1-800-TEX-LUNG. Heartland offers a variety of products which you can order or download directly from our website, and this also includes the HNTC newsletter TBeat. Please be sure to visit our newly designed website where you can find information on upcoming and archive trainings. You can apply for our mini fellowships. You can get information about our consultation services, access and order our products, as well as find Heartland staff contact information. You can now follow us on Facebook. So I invite you to stop by, give us a like, and share with others. So I just want to go over a few things about continuing education for this webcast. At the end of the webcast, you will be provided with a link to complete an evaluation. In order to receive CEs for this webcast, you must complete the online evaluation by this Friday, June 4th, 2021. This is an important thing to note. When you get to the end of the evaluation, there are a set of CE instructions. Please be sure to copy and paste that into a Word document or print it out or save it as a PDF. Once you exit the survey or the evaluation, you will not be able to get back in and have access to those CE instructions. The CE instructions tell you step by step how to get CEs for the course. It also includes a course code and a course access code, which you will need to get your CEs. This webcast provides 7.25 hours of CMEs for physicians and 7.25 hours for nurses. Also, lastly, we will have time for Q&A at the end of each presentation. Please use the Q&A pod to submit your questions. The Q&A pod is found to the bottom middle of your screen. And with that, we'll go ahead and get started with our first presenter, Dr. Lisa Armitage. Dr. Armitage is board certified in infectious disease, internal medicine, internal medicine. She obtained her medical degree from the University of Texas Medical School at Houston to include her PhD in molecular pathology. Dr. Armitage has spent several years in the field of TB and serves as the Assistant Medical Director for Heartland National TB Center in San Antonio, Texas. Please welcome Dr. Armitage.
Hi, good morning to everyone. And Delphina, can you see my PowerPoint?
Yes, I can.
Okay. I've got Rashonda standing on standby. Good morning to everybody. Welcome to our PDTV intensive. As those of you who actually know me know this is really early for me, but let's get going. So I wanted to start off talking a little bit about the epidemiology of pediatric tuberculosis. So I went to, when I was looking for information on basically global pediatric TB burden, one of the first things, UNICEF does a lot of the data for children, and specifically for children and women. But the first thing that pops up on the tuberculosis page, and this is dated as of October 2019, tuberculosis is now the leading cause of death from infectious diseases for children of all ages globally. So it is the single highest cause of death from a single organism for adults. Now we've added children to that. So looking at the global TB burden, this is just kind of our overall numbers. And this is really a very recent thing. The information, it just was a push for people like Jeff Stark, who you'll hear speaking later, pressing to really get a feel for what the actual numbers are. And so we're starting off at about an estimate of 7.5 million children every year that are this is ages 0 to 14 that are infected with TB each year. So among all ages, we're estimating 10 million cases of TB, and of those, 1 million will be children. So children 0 to 14 developed about a little over half, were less than 5 years of age. So very important, our youngest and most vulnerable are the ones that are the most affected. Out of the 1.6 million deaths, there were about 233,000 children dying of TB in the year 2017. This is the most recent data that we have, and COVID kind of put the brakes on most of the data that we're getting, but 80% of the children that died are less than 5. So again, the most vulnerable population is our less than 5. And those of us in the US know that's the group that we are the most aggressive in our targeting. But 96% of deaths are children who did not access TB treatment. So treatment does work, and it works well in children. And you'll hear that as we're talking a little bit later on in the talks that you'll hear. But of those 39,000, were about 17% died, or children that were living with HIV. So the case detection gap, the younger the child, the harder it is to actually detect the cases that are before the child is dying. But also these are based on estimates. We know that TB is missed in almost 70% of children that are less than 5 years of age. This gets a little bit better as children get older, and we start noticing that they're not themselves, lymphadenopathy, different presentations start to show themselves. So between 5 and 14, you get up to 60%, but that's still, you're missing almost half, of the children. And this is only slightly worse than overall misdiagnoses of TB in all age ranges is 35%. For those of us who work in TB, we know how long it takes and how hard it is for people to actually recognize that individuals have disease. And you see that worse, in our smallest children. So overall, about 55% of the estimated children with TB are never even reported to the national TB program. Children don't pay taxes, is what we've always said in pediatrics. They don't work a job, they don't impact the workforce. So a lot of times they just go underreported. So TB can be the cause or a comorbidity and a common cause of childhood illnesses. So globally in 2017, 75% of children, importantly enough, that actually were eligible to household contact. So now you have a child who's in the house with someone who has active disease. They have access to preventative therapy, but only about 75% of them actually accessed it. So we're missing the children in case detection, but we're also missing opportunities to prevent disease. HIV and TB, it's well known. We know this in adults. It's no different in children, and yet children, we're built in a lot of it's like the 3 I's. So you're trying to find people who have HIV infection. You're also trying to screen them for TB, and then you're trying to treat them with preventative treatments. And of the children even though we know this and we practice this very carefully in the adult population, and we have seen tuberculosis, especially in the U.S., drop significantly with treating individuals who have TB infection before they progress to active disease. You don't see this aggression practiced with children. So globally, children who have HIV don't have access to medications, antiretroviral medications, the way that we have pushed for adults. And so we have an estimated 25,000 children who have MDR. Very rare in children, thank goodness, but it's usually the less than 15-year age range. And a lot of these children are infected in the home. So again, the less than 5-year-old population is going to be the ones that are most affected. But even though we're detecting MDR TB in children, we're not, less than 10% of them that are diagnosed actually had access to treatment. So I'm going to go back one slide. The important point to this is a lot of the information that we have for treating children is extrapolated from adult data. So when we have brand new drugs that are tested in adults, pediatric formulations are a problem. Knowing the correct dose to give a child is a problem. They metabolize different. Children are not small adults. They are children. So bringing it closer to what our U.S. numbers look like. So know that the definition of pediatric tuberculosis is TB disease in a person less than 15 years old. That cracks me up. I always just say, okay, so if they're 15 and older, we're putting them in the adult category. So you're going to give your 15-year-old the keys to your car and your debit card. I'm thinking not. So for us pediatricians, we go to age 17, but for the purposes of reporting, then it's individuals that are less than 15. So in 2019, our most recent data that we have from the CDC, there were 8,916 TB cases reported among all age groups, and of those, 4.1% were children at 367 cases. And looking how that breaks down, 0 to 4 has a slight predominance over in the group overall. So 215 versus 152 of children who are 0 to 4 years of age. So looking at the U.S. states with the most pediatric TB cases, Texas rang up last year. And interesting, 2 years ago, I gave this talk, and California had 57 cases, and Texas had, I think it was 49 or something. But we had a big jump in the number of pediatric cases in Texas. I'm not sure what that is. Either we're detecting them better down here, or we've just had an increase in numbers. But in every instance where the number of pediatric cases rises, that's always a harbinger for bad things, because you see the numbers increase in children first, and then you see the general. Children represent ongoing transmission in a community. So when the numbers increase in children, that's usually ringing the bell that you're about to see the numbers increase. So we had, you look next at California. Despite the fact that California has almost twice as many overall cases of TB, we had greater number of pediatric cases in Texas, and then followed by Florida and Georgia, and then Illinois, and that just tracks with the larger number of cases in the U.S. states, and the pediatric cases are following behind those. But again, you notice a slight predominance in the children less than 5. So looking at overall, again, pediatric cases are only 4%. So you see the two kind of purple bars down at the bottom representing smaller numbers. And you see overall that the numbers have decreased significantly in the U.S. since 1993, but the pediatric cases are looking pretty similar overall in number. And then when you look at the rates are much lower in pediatric populations, again, lower in the 5 to 15 year age range than the 0 to 4. So when you break those out, just the pediatric numbers, interesting things start popping out. The highest number overall is in the 1 to 4 year age range. So the less than 1, while the disease tends to be more devastating, the numbers actually are higher in the 1 to 4 year age range. And this is just a pie graph that shows essentially the same thing. 43% of cases of all of the pediatric cases in 2019 were in ages 1 to 4. 16%, so in the less than 1, and then interestingly, about a fourth of them, the second highest group is the 10 to 14 year age range. And you'll see when you start dividing out the numbers between U.S. born and non-U.S. born children, you'll see how that kind of how that pans out. So again, higher rates in the less than 1 and 1 to 4 year age range children. And another slide, when you look at we know that TB has kind of a predominance toward males. So you see when you divide out your number of cases, you always have a slight male predominance in the absolute number of cases. And if you look at the top, the overall numbers, this was in 2019 of the 8,900 cases I showed you earlier that we had in 2019, 5,300 were male and 3,500 were female. Well, you don't start seeing that divide out until you get in the higher age ranges. So 0 to 4, 50-50, 5 to 14, again, 50-50, and then 15 to 24, now you're starting to see a predominance toward males. And then in the next two age groups, there's a 50, well, almost not quite 60-40, but then when you get to the older age groups, you see that there's a hard shift in males. So really, you see more of it in older individuals than you see in children. That doesn't kind of apply to us. It's almost a 50-50 split, male and female. When you look at cases of U.S. born versus non-U.S. born, so this is the exact opposite of what we see in adults, because the highest case numbers are in U.S. born children versus non-U.S. born children. And this is just a graph showing the rates. So when you look at the overall rates, actually the rates are higher in non-U.S. born children than they are in U.S. born children. But back one slide, the case numbers are higher in U.S. born children. So when you divide out children based on their parents, whether their parents are U.S. born or whether their parents are non-U.S. born, you see that U.S. born children whose non-U.S. born parents or guardians tend to have the higher rates. And I think I always look at this slide and I think about, well, Huntsville, Texas is not considered a foreign country, but that's where my dad was from. So we would get hauled up there and we would, whatever was going on up there is what we were kind of rolling into. And then my mom was from a small town up near Waco, and the same thing. So I think what you see in that graphic is people either like to have their children visit where they were raised, or they have individuals from that place come to visit, but you have an increased chance of, opportunity for exposure without the coverage of BCG. So again, just a pie graph showing 60% of cases of pediatric cases of TB, where the parent, the birth, place of the parents were known, non-U.S. born parents, and to U.S. born children. was about 60% of the cases, and about 30% were from U.S. born parents and children born to U.S. born parents and guardians. So the cases among U.S. children divided by age, this is where, because this is the larger number that you see, again, the 1 to 4 year age range pops out as being the one that you see most prevalently. And then when you look, though, at non-U.S. born children, it tends to skew a little bit more toward children who are older and likely had more exposure in their home country before immigrating. So U.S. born pediatric TB cases by race and ethnicity is it's a disproportionate number in the Hispanic population. If you look at Asian and Black non-Hispanic, those are very similar, smallest being whites, and then the absolute smallest being American Indian and Alaska Native. And then looking at non-U.S. born children, the rates are almost equally between Asian, Hispanic, and then Black non-Hispanic. So TB cases by site of disease. Overwhelmingly, it's still pulmonary. You still see pulmonary disease primarily. That's the point of entry, and that's where you see disease set up. Extrapulmonary only, less prevalent. And let's go to the next slide. And we're going to divide those out by age. So if you look at starting with the less than 1 on the left at the top, and then going to ages 1 to 4, and then below the less than 1, not sure if you can see my pointer, but the 5 to 9, and then ages 10 to 14, what you start noticing is that the extrapulmonary starts to increase with the increasing age group. So primarily a disease, pulmonary disease in children less than 1, and then as children get older, you start seeing more representation of other sites. This is pretty much the same data, but looking at exactly what the sites are. So again, the smallest children, about 75% of them, 76% actually, are pulmonary only. But look at the yellow, little mustard colored pie here, slice is 11.2, that's meningeal disease. You see a much higher representation in the smallest children. And if you watch that same pie as we progress in the age ranges, you will see that drops off by half by the time you get to the 1 to 4 age range. And you see more of an increase in lymphatic disease. Bone disease and like miliary, and other, these are all relatively small in the children in this age group. They get a little bit higher as the children get older, but again, that little mustard colored pie, you notice, gets considerably smaller as a child gets older and their immune system is better able to contain. Then you see that you've got the still primarily a pulmonary disease, but much higher increase in lymphatic disease in the older ages or age ranges. But here we're getting to the 10 to 14 and that other. There was not more information about what the other sites are, but I think that would be really interesting to know. I think you start seeing probably more Pott's disease, more bone disease, and this bone and joint here is actually 2.8%, but what the other was, maybe GI. I always look at that pie and try to guess at what that is. So the number of U.S. pediatric TB cases with drug resistance, we had drug resistance more so before we had directly observed therapy. You saw that a lot more in the 90s, and that's kind of slowly washed out. You still see a pretty good amount of INH only resistance, but when you look to the scale on the left, these are absolute numbers, so we probably have a maximum of maybe 10 cases in 2017 of INH-resistant disease, and it may have been only 7 or 8 in children. And you see MDR disease just very low prevalence. So how did children come to the attention of healthcare providers, basically? Where are they coming from? And if you look at the largest group, contact investigation. If we're not out there finding children, there's a good chance that they likely won't be found. This is followed second by TB symptoms. This is the blue bars. So we're actively getting out there and hunting them down is the number one way to get a hold of them. And then presentation with TB symptoms. And then an abnormal chest x-ray is usually the reason a child will eventually be evaluated. We see the immigrant exam is a very small part. Also, incidental laboratory findings. I'm not sure. You have to be pretty focused on asking for an AFB. So I don't know if that's an accidental box checked, but or they check the box not expecting to find it. But targeted testing is a small number of children that we find every year. So case verification, this is overwhelming in clinical cases. Our diagnostics are still not what they need to be. So it's a clinical call. You have a child who's in the house with someone who has active TB disease, who is infectious, and you find that the child has clinical or radiographic findings that suggest active disease. So we call that. I know you have Dr. Smith coming, speaking behind me, but I always laugh with the pediatricians because our motto is he who pokes the fewest holes and gets the right answer wins. So once you have an adult and you have a child who has, a syndrome suggestive, there's no reason to go into interrogating the child's parts. You just get a bug out of the adult and you can go from there. So you'll still see there's not a lot of culture confirmed cases. Those are one of the smaller ones down at the bottom. And then just the provider decision that this is active disease. But you look at NATs and smear, and they're wedged in this tiny little place between clinical case and culture. So there's a tiny little bit of information that we get from that, but overwhelmingly, this is a clinical call. So this was a paper that was really interesting. They looked at the risk and timing of TB among close contact with persons with infectious tuberculosis. And they looked at 158 contacts that were diagnosed with TB. So these were people who were found in the household when they went into the home of someone who had active disease, and they were doing contact screening in the home. And so if you look at the chart on the left at the bottom, so the overall number was 158 contacts that were diagnosed with active TB disease, and they divided them out by their age bands. And of course, the highest age band when you went into the house was 0 to 5. And the words co-prevalent and incident. So co-prevalent means that when they came in to do the screening around an active case, this age group already had active disease. And that was over a third, represented in the 0 to 5 age group. And not so much in the older children, but then incident, these are the ones that on the second round of screening ended up being diagnosed with disease. And so when you look at, the contacts that were free of disease, or the proportion that were free of disease, they're all essentially the same over time. But when you look at the 0 to 5 group, this group progressed to active disease within 6 months. There was a drop here, and the question was what happened. Just over on the right, this is U.S. and Canada kind of pooled data. 158 of 4,490 contacts developed active disease. So this is 4%, which I want to point out that the U.S. data, we've always been taught that 10% of individuals will have TB infection and 1% will have active disease. Actually looks like it's a little higher than that. But why, when you're detecting these children, are like the ones in the incident group, why is it that these are progressing to active disease? Well, everyone followed a standard policy for screening, but not all of them for prevention of progression to active disease. So all of the children who were detected, which if you go in and detect them, the point is to get them treated for active disease, for latent disease, so they don't progress. Clearly that did not happen. But the take home for this is important, number one, to get into the house, because already you will see a third of the children who are going to have disease will have it already. But another fourth could have progressed and could have been rescued from having active disease ever. So I'm going to end a little bit early, but the take-home point, pediatric TB cases, unlike adult TB cases, are more likely to be U.S. born than non-U.S. born and represented in our U.S. cases. Contact investigations have been and still are important in the detection of pediatric TB, especially in very small children. And pediatric TB is greatly undercounted globally, and need to remember that we're still not where we need to be with understanding how big the problem is. And then failure to address TB in children happens on many levels. So still, as we progress through the day, you'll hear a lot of the, a lot of the places that we're falling short a little bit, but you'll also hear some of the things that we're making some progress in. I'm going to stop sharing and go over to Delphina and see if we have any questions.
If you have any questions for Dr. Armitage, please use the Q&A pod. You can also type in your questions in the chat pod as well if you cannot access the Q&A pod. But at the moment, Dr. Armitage, it doesn't look like we have any questions coming in.
Okay.
And as I'm sorry to interrupt, Dr. Armitage, the presentation handouts are missing Dr. Armitage and Dr. John's presentations. However, they will all be available after the webcast.
I am notoriously naughty about getting my slides in ahead of time. I do apologize for that, but they will be coming. You know what they're looking?
Unable to access the Q&A pod.
Yeah, so the question is, do I know why they're, if they're looking into why the cases in Texas increased? I know that we had a presentation from the epidemiologist, and they were trying to sort out, number one, how we're doing our diagnoses. So are we finding more cases that we were not finding before? Or is there actually an increase? So I don't think, the last I heard, they had not had an answer, but yes, they are looking, the epidemiologists, I understand, are looking into why that was such a big increase in our numbers. And do we have a parent's permission? Do I need to have a parent's permission to test a child? Yes. My understanding, pretty much anytime you're going to check someone's child for something, you do need permission to evaluate a child from the parent. It's the same as any of the pediatric offices. If you take your own kids, you have to sign permission for them to. I think if they bring the child into the clinic, that is some level of assent that you are bringing your child in for evaluation. But you cannot bring the child in without the parent and do an evaluation. You do it. So I guess the question of why there was an increase, could it be from late diagnosis of adults or delayed contact investigations? All of the above. Anytime that you have a child in an environment where they potentially could be infected, and especially small children they're far more likely to be in the house with an infectious case with an infectious adult. They don't go to school frequently. They go to daycare. That would probably be a little bit more protective, but the longer it takes for you to get the adult diagnosed, then you have a child who tends to be closer to the adult. The 1 to 4 age range, that's just that range where they're just kind of close underfoot. And a little bit broader interaction scope. Children less than 1 year of age tend to be with one primary caregiver, and you may not see as much transmission unless the primary caregiver is the one that has the disease. So yes, a delay in diagnosis of adults can lead to that. Delay in contact investigations will probably increase the number of cases of active disease in children you find when you get into the environment. Of all the possible strategies to find TB cases among children, which 3 would you give priority to? I love that question. So let me read it again. Of all of the possible strategies to find TB cases among children, which 3 would you give priority to? Number 1 is careful screening around infectious adults. One trick that I learned from the contact investigators, he loves to tell this story. He went to the house and he asked, "Do you have any small children that visit you?" And no small children. There are no small children that live here. And it's always how you ask the question. Because if you ask if there are any small children that live here, no. So he asked the second time, and then he asked, "Is this your toy?" And it's like, "No, that's my wife's niece." So always the careful asking of the questions. People tend to minimize, and understanding if there's any sign that there's a child anywhere near an infectious adult, that would be my number 1 if I had to pick one, because those are the money shots. That's the one where we're getting the screening from. And so let me see. Second, I'd say go back to first, but I would say if I was second one, screening probably children entering the U.S. Make sure that our immigrant screening is very careful. Children coming out of places where the rates are really high, that would be my second, and it's always the screening. And then I would say children coming to the ER, if they have a second visit to the emergency room for vomiting, I would put that higher on the list of concerns. It's always the TB meningitis cases. When we do get the child is diagnosed, they've usually had more than one visit to the emergency room. It's hard because you're going to see 99 cases of partially treated something that aren't going to be TB disease, but still, I would say if you would talk to your emergency room folks, if they're getting a second round of a child coming in with fever and vomiting, and especially if they're not growing, that would be my second approach. And should the U.S. consider BCG vaccination for high-risk kids, like kids of parents from high-risk burden countries? Would it even be helpful? We had a rash of meningitis cases of children born in the U.S. and then they being raised in Mexico. There apparently, I don't know if this is still the case, but there was a shortage of BCG, so Mexico would not vaccinate a child if that was not born in Mexico. And so I actually tried to work out something with some pediatricians here. They had patients that were going back to, one to India, one to Vietnam, another to China, and they were trying to get their children vaccinated before they took them back home. And it is nearly impossible to get BCG here in the U.S. I don't think that for U.S. and born individuals for short travels overseas, no. But if you are going to you're going to, like my parents, you just drop us off during the summer with our grandparents. And if you are going to a high-risk country, then yes, I think BCG vaccination would be good. We are right at 9 p.m. and I know that Dr. Smith's coming up behind me, so I'm going to stop there. I think that was our last. One more question. Is there a reason we don't give BCG to newborns in the U.S.? Our incidence isn't high enough, and I'll let that be my last question.
All right, thank you, Dr. Armitage. So Dr. Armitage will be online for a while. If you'd like to continue with questions, you can answer questions in the Q&A pod. I'm going to go ahead and introduce our next speaker, Dr. Kim Connolly-Smith. Dr. Smith is a pediatric TB expert. She is currently the director at UT Children's Tuberculosis Clinic, Children's Memorial Hermann and Lyndon B. Johnson Hospitals. Dr. Smith also serves as a pediatric medical consultant for Heartland National TB Center. Please welcome Dr. Smith. So Dr. Smith, you'll be sharing your screen, correct?
Yes, I will. I just had to turn on my slides and let me share my screen. Here we go. So can you see that, Delphina?
Yes, now you can put it in.
There we go.
There we go, perfect.
Okay, great. Thank you so much for inviting me, and I'm excited to see so many people interested in learning about tuberculosis in children. And Dr. Armitage, what a great introduction to the problem of tuberculosis in children. I'm coming from Houston to talk with you today about exposure in children. This is an outline of what we're going to cover in the time I have to talk, and there'll be plenty of time for questions at the end. Going to define exposure, review the stages of tuberculosis, talk about the risk of progression to disease, the timetable of tuberculosis in kids, the very importance of contact investigation, as Lisa just made such a great presentation on that. I'm going to spend some time on a number of different case scenarios. And if you have your cell phone, get it out, because we're going to do some audience participation with Poll Everywhere and see how that works. But talking about newborns, daycare, school-age kids, and drug-resistant exposure, and follow-up testing and treatment, and lastly, just summarizing with the prevention of tuberculosis in children. So most people realize that tuberculosis is spread during contact from a contagious adult or teenager who has pulmonary tuberculosis, and coughing the droplet nuclei in the air that have infected bacteria in it. Those people that spend a lot of time in the home or in the environment around contagious people are at risk for breathing in the bacteria and becoming infected with tuberculosis. And children certainly are vulnerable if they're in a close contact with a contagious person. So when we talk about contagious people, we're usually talking about adults or teenagers. We'll discuss a little bit more later why children certainly under 10, are usually not considered contagious. Most of the transmission occurs in people living in the same household or people who have at least 4 or more hours of close contact indoors. Now, this doesn't have to be all at the same time. It could be a healthcare provider if the patient's not in appropriate isolation, if the healthcare provider is not wearing appropriate protective equipment and they're in and out of the patient's room over a matter of days, or during a hospitalization without realizing they're being exposed. So you can get those hours cumulatively over time, as well as a one-time exposure. Environmental factors are also important and contribute, including more crowded, poorly ventilated conditions lend to a higher transmission rate. And tuberculosis is rarely, if ever, transmitted in an outdoor environment. There's just not a high enough concentration of the bacteria. So contagious people with tuberculosis include adults or teens with pulmonary disease. The people that have smear positive, AFB smear positive on their sputums, coughing, and cavitary tuberculosis are usually considered the most contagious cases that we're talking about. Rarely we see endobronchial TB or tuberculosis of the larynx. These are rare, but they're also contagious, even through talking. Who's not contagious? This includes people with latent infection. They cannot spread TB to other people. And people with extrapulmonary disease without pulmonary involvement, so lymph node disease and other forms of extrapulmonary disease are not considered contagious. And then we get to the children. So kids, some people draw the line at 12, some people draw the line at 10. But certainly children under 10 years of age are usually not contagious. There are a few exceptions. But the reason most children are not contagious in this age group is they have a low bacterial load, or sometimes described as paucibacillary disease. Most of them are in what we call primary tuberculosis disease, not the cavitary reactivation disease that you see in adults. And in fact, if we go and collect sputums, bronchoalveolar lavage, or gastric aspirates from children, 98% of the time, the AFB smears are going to be negative. So this is not a sensitive test at all in children because of their low number of bacteria. Because of children being smaller, they have a weaker coughing force, so they're not able to get those germs out into the air very well. And cavitary disease is rarely seen in children that are not teenagers. I have seen it in a few infants, and it is in the literature described sometimes in infants, and some of those cases will have AFB smear positive disease. And these are cases when the infant has a very overwhelming case of tuberculosis and it causes cavitation, but this is not seen very often. We've had a few cases of children as young as 10 or 9 that had extremely severe pulmonary disease with cavitation, and they were AFB smear positive. But this is really the exception to the rule. I tell my residents, when they come and rotate with me, they're concerned about coming to TB clinic. And I tell them I've been doing this for 32 years and my skin test is still negative. Looking at the different stages of tuberculosis, we're mostly going to be focusing on exposure, which is defined as contact with an adult or teen with pulmonary disease. And when we do report the suspected patient with tuberculosis, there should be a contact investigation, and you mostly want to look at household contacts first. It surprises many people to learn that TB is not as contagious as a lot of infections that we deal with, and on average, about 20 to 30% of patients that live in the household will be skin test positive. And once the skin test turns positive, the patient is either infected or has disease, depending on the outcome of their chest x-ray. I've seen households where everybody was positive, and I've seen households with only the person that has the case of TB disease being positive. Once they've developed latent infection, if they're not treated, we have data from almost a century going back showing what is the natural progression of infection to disease if people are not treated before we had antibiotics. If you have healthy adults, about 5 to 10% will break down or develop active tuberculosis disease. Obviously, other health conditions can influence this, and we'll talk about that a little bit more. And then over here on the right side of the slide, you can see in children, if they're infected but not treated, the risk really varies by age. And Lisa made a really great point of that in her epidemiology talk, but the risk can go from 5% all the way up to 50%, depending on the age of the child. And I do want people to realize this is something that most general practitioners, including primary care providers, family physicians, internal medicine physicians, and even pediatricians are not aware of. Those of you who work in public health and work in prevention and treatment of tuberculosis are much more likely to be familiar with this risk than your average physician. It's just really not taught unless you're in the TB field. This graph looks at the risk of progression to disease with no treatment, depending on the age of infection or medical condition. And here we have this young age group that we were talking about earlier, the children from birth to 12 months of age. If they're infected in this age, there's a 50% risk that they will progress to active tuberculosis. And if you remember the pie charts from the epidemiology talk, about 10% of those may have TB meningitis. We also see disseminated and miliary TB in this age. It can also be a rapid progression, and that's why the early contact investigation is so, so important. Once they hit a year and they're between 1 to 4 years of age, the risk is about 24%. So actually quite high in this age group as well. And then for some reason, the little kids that are school age, between 5 and 11 years of age, the risk is about 5%. We see the risk bump back up when they're teenagers, and you're going to have a talk this afternoon about TB in adolescence. There's many theories about why this is. My theory is the stress of being an adolescent may affect the immune response, but some people also think it may be hormonal. We've already talked about healthy adults have about a 5 to 10% risk over their whole lifetime. And then in the last 20 years or so, we've realized that patients with diabetes, either children or adults, have an increased risk as well. Something about diabetes affects the immune response, and there's a 30% risk of development of disease. Most doctors of all training are familiar with the very high risk of progression to disease in immunosuppressed patients, including HIV infected patients, people on high dose steroids, and then certainly the TNF alpha blockers are an incredibly high risk of progression to disease. And so those patients are routinely screened and treated before starting immunosuppressive agents. But for our purposes today, we're going to mainly be talking about these younger kids and why we treat them a little bit differently. This is a timetable for tuberculosis. It's an old slide, but I really like it because it illustrates looking at day 0, meaning the day the patient was infected, going out months, all the way up to 36 months. And looking first on the bottom row, you see hypersensitivity. So this would be your reaction to the tuberculin skin test or to the blood test for tuberculosis. And there's a window period in here between about 2 to 10 weeks where the skin test or the blood test, the immune response is developing, and the patient may have a negative, initially negative skin test or IGRA test. And then the next thing I want to draw your attention to is looking at the row where we had miliary and meningitis TB. And this is the part that keeps me up at night. You can see miliary or TB meningitis within a month of infection. This is a rapidly progressive disease, especially in very vulnerable children, especially in the kids that are under a year. And also, I would even say kids under 2. And then it peaks around the time that you would expect the skin test to become positive. And you see for a period of months after the initial infection is the period of time that we're going to see patients break down with the disseminated disease, including meningitis, the most severe forms of tuberculosis. This is a table looking at the different stages of TB, including exposure, infection, and disease. And we're going to be focusing on exposure today. So in that younger age group, under 4 and under, the initial skin test, if it's negative after they've been in contact with a contagious source case, then you would still go on and do a chest x-ray, a physical exam, and check for symptoms. If all of these are normal, then the child would be classified as exposed to tuberculosis. And the treatment recommendation would be for window chemoprophylaxis with either isoniazid or rifampin, and then follow up the skin testing or IGRA testing 8 to 10 weeks afterwards. If the skin test or IGRA are positive, then the child would still be evaluated, and if everything else is normal, would be considered latent infection. If you have a child with a negative skin test and you go on to get that chest x-ray and it's abnormal, if they've been in contact with a source case, they would actually meet the definition as suspected disease, and they should be treated as such. And you'll have more discussion of that later on today. So I'm going to talk about some kids here, some cases that I've taken care of. So this baby was 2 months old and the mother had tuberculosis disease. So how would you determine the risk of the tuberculosis to the baby? So if you have your phone, go to your text messages and type in the phone number 22333. And then it's not sensitive to case, so you don't have to capitalize it, but then type in K Smith 1, and then you should join our group. And so you can type in whatever you can think of how you would determine the risk to a 2-month-old baby. So we'll see if we get 200 and something responses. Or we may not get any. If not, we'll carry on. There we go. Okay, so the risk to the baby, we're going to want to check on the mother's symptoms, the mother's chest x-ray. We want to say where is the site of the mother's disease. Spell check puts a few crazy things in here. So you really want to know, is the mother contagious? And getting this information is going to be really important. Also seeing if the baby has any symptoms. Very good. So lots of information here. So the mother is AFB positive and she's just starting on treatment. Here's her x-ray. And you can see there's this obnoxious big white arrow here pointing to this huge right upper lobe cavitary lesion in the apices. So she's basically got a big TB abscess in her upper lobe and is coughing bacteria into the environment. So with cavitary pneumonia, AFB smear positive, the mother is absolutely contagious. So the baby has a cough. This is a 2-month-old baby, and their PPD measures 0 millimeters. What do you want to do next? So you can type in things that you're thinking of. So we're going to want to start to get a chest x-ray for the baby. We definitely want to get that. We're going to want, wow. We will also want to do a physical examination. I see someone put on there, we want a lumbar puncture. So we want to figure out, and then some people have put on here window prophylaxis. And these things are going to depend, of course, on the tests that we get. And you may collect gastric aspirates if you're trying to figure out if the baby has disease or not. So here's the baby's chest x-ray. And based on this chest x-ray, what would be your diagnosis and what would be your treatment based on this? I'm going to clear these because I think some of these came from the last one, and now we're open again to people adding in. So here we have, somebody says miliary TB. So this is correct. So this on the left lung, you see this micronodular diffuse infiltrate. On the right side, you have this huge consolidation, maybe a little bit of atelectasis. I think the trachea is slightly deviated. And then the miliary pattern here down in the lower lobe as well. So we definitely have active disease in the baby, even though we had a 0 millimeter skin test. And we have that contact with the mother. So these two factors are enough to make the clinical diagnosis of tuberculosis in the baby. So we want to start the baby on RIPE therapy. And then I see one response pointing out that we want to get a lumbar puncture. This is going to be important because it will change your treatment. in the baby if the baby has meningitis. And on average, about 50% of children who have miliary TB also have meningitis. So you want to check for that as well. So we did diagnose miliary tuberculosis in the baby and also meningitis, slightly elevated white count with a high CSF protein, and then MRI that was consistent with meningitis in this baby. We did start the baby on RIPE therapy. I usually treat for 12 months, although the criteria CDC recommendations are 9 to 12 months. And then prednisone or steroids for the first 2 months are important when you have meningitis. This is the big change you see in having that additional information. This baby actually did quite well and did not have any neurologic sequela because they were caught early as part of a contact investigation. Another patient that I took care of a few years ago here in Houston was a 6-month-old that came in with a 1 to 2 week history of fever, vomiting, and sweating. And like Dr. Armitage was saying in her last talk, my experience also is that many of these children are seen by multiple providers, often treated with antibiotics for suspected ear infections or viral illnesses. And this baby had been seen multiple times and had symptoms for a couple of weeks. This is the baby's x-ray, and the arrow is pointing to a consolidation here in the left lower lobe, but you also see there's a diffuse, hazy infiltrate throughout, which is consistent with miliary tuberculosis. The baby went on to develop respiratory failure, seizures, and ended up intubated in our PICU, had an abnormal neurological exam. The baby was diagnosed with meningitis and miliary TB. This is the baby's MRI, which is consistent with TB meningitis. You see all this white area lighting up with the contrast. This is all leptomeningeal enhancement. We also see enlarged ventricles consistent with hydrocephalus. So this baby was quite sick. When we initially asked the family, was there anyone around the child that had tuberculosis? The answer was no. But digging a little further, the father had been hospitalized 2 months before and had cavitary pneumonia. He was seen in a suburb of Houston in a small hospital, and they did collect sputums. They were concerned about TB, but they were AFB smear negative. He spent a day or two in the hospital, and then he went home on ciprofloxacin for community-acquired pneumonia and was told that he did not have tuberculosis. The culture grew TB 4 weeks later, and the lab then reported this to the health department. Unfortunately, the health department was unable to locate the family because they had been given a bad address, and they really worked hard to try to find this family, but couldn't find them. The long-term complications for the baby included hydrocephalus requiring a ventricular peritoneal shunt, and the baby had developmental delay. So when we contact investigation, once they did find the family, all the family members, included the mother and 3 older siblings that lived in the home, tested positive for tuberculosis. The mother also had an abnormal chest x-ray, although it was not cavitary, and she was treated as TB disease. The older siblings had normal chest x-rays, luckily, and they were treated for latent infection. The baby grew tuberculosis from the tracheal aspirate and also from the spinal fluid. And we don't see that very often because there's not very many bacteria in the spinal fluid, but we were able to collect a lot of CSF and had a positive culture. Baby was treated with standard RIPE therapy for 12 months, including steroids for 2 months. So how could this have been prevented? So here you can respond on your phone. regarding this 6-month-old infant with miliary TB and TB meningitis, a father who had had cavitary pneumonia 2 months before. So father could have had a skin test or an IGRA. I think I see really something very key here. The father should have been reported when the physicians in the ER first suspected possible tuberculosis. And really trying to find the family. When I first figured out this story, I did call the health department and I was like, why did you miss this patient? And they were awesome. They had found the father's mother, so the grandmother of the baby. They had done all kinds of work to try to figure out where this family was. They had been really, really working hard at it. Turns out the dad had just gotten out of prison, had schizophrenia, and the mother also had mental health issues. So it was a really challenging family. And they were actually relieved when we called them and said, you know, we have the child here in the hospital. They were able to find the family at that point. So they had done their due diligence. I think really where the ball was dropped was in the beginning when they saw that cavitary disease. So this is really why contact investigation is so important. And I really want to applaud all of you who work in contact investigation and TB prevention. And time is of the essence, especially when we're talking about young children. So TB should be reported as soon as it's considered as a possible or likely diagnosis. Now, obviously, we're not going to report every case of pneumonia because, pneumonia, community-acquired pneumonia is more common than tuberculosis. But if you see a cavitary pneumonia, or you have a patient who has chronic symptoms with cough and fever that's been going on for a while, it's certainly worth getting testing and checking the skin test perhaps, or an IGRA, and reporting these cases or suspected cases early so that contact investigation can be done. The health department should visit the home within a week. And the reason we have this short time frame is that we really want to prevent these cases of disease. We want to look for other people in the home or in the environment that may have tuberculosis as well. You're trying to detect and find people that have infections so you can treat them and prevent future cases. And really in the young children, we are trying to find those that are exposed to tuberculosis and hopefully be able to put them on window prophylaxis. We want to screen all household and close contacts with a skin test or IGRA test. And with the skin test, in situations where you have contact with an infectious person with tuberculosis, 5 millimeters or greater is considered positive. If that initial reaction is positive, then you want to go ahead and get a chest x-ray and also screen for symptoms. For children 4 and under, the American Academy of Pediatrics and Centers for Disease Control recommend the following. Even if the skin test or blood test are negative, we want to screen history for symptoms of disease. So is the child irritable, or does the child have swollen lymph glands? Is the child limping or in pain? You want to do a careful physical exam looking for TB disease, mainly concentrating on the pulmonary exam and the lymphatics, and also the neurologic exam. And then a 2-view x-ray is important even if the child has no symptoms. This always surprises me that 50% of children with active tuberculosis may have no symptoms at all. And the only reason that we find them is because we're doing contact investigation. So unlike adults, kids can be asymptomatic even with severe disease. Again, I want to emphasize that most pediatricians, most primary care physicians, unless they're in infectious disease or tuberculosis, really may not be aware of this recommendation for going ahead and getting an x-ray even when the child has a negative skin test. So if you're working in public health and involved in these contact investigations, if you run into providers who are saying, oh, we don't need to do an x-ray, we don't need to start treatment, please call your medical director or Heartland or some other infectious disease expert to get the support and help you need to make sure these children get the treatment that they need and prevent these severe cases of TB disease. So the window period is the 8 to 10 weeks after infection that it can take for the skin test or the IGRA to convert. And the goal of this window prophylaxis is to prevent progression to disease during the window period. Remember, the timeline for TB can be as short as 1 month following infection. And we're trying to prevent that progression to tuberculosis during that time. Repeating the skin test 8 to 10 weeks later, and then treating for latent infection if the patient has it, or if the follow-up skin test or blood test is negative and the patient is immunocompetent, then you can stop the treatment as long as the exposure is not ongoing. We'll talk about that a little bit later. So who needs window prophylaxis? Those younger children and 4 and under, even with a normal x-ray, even with a normal exam, even with no symptoms. And really, they should be evaluated as soon as possible after exposure. We've had certainly an explosion of new referrals lately, and I'm not sure if it's because, I think it's because of the large number of immigrants that we see in Texas. And I will do anything I can to get those kids in to be seen within a week or 2 at the longest. I don't want them waiting to the next opening on my schedule. Also, with patients who are immunocompromised, a lot of experts recommend a full treatment after exposure, even with a negative skin test or IGRA, because the concern is that the risk is too high and they may not be able to mount an immune response. And then follow-up testing after the window period to rule out infection. If the exposure is ongoing, then we want to extend the window period 8 to 10 weeks after the last exposure. If you have a child who has been physically separated from the person who has suspected TB disease, say it's an uncle or a babysitter or a teacher or something like that, and the child is no longer around that person, you can count the window period starting from their last physical contact. On the other hand, if it's a person that they live with, you're going to have to count your window period starting from the time when the AFB smears are negative, because we do consider most people will stop being contagious after they start treatment, maybe 2 to 4 weeks into therapy. But many of us have seen patients continue to be smear positive, sometimes for months. And if the child's still living with that person, it's a parent or a grandparent, and they can't be separated, then I've had kids on a window prophylaxis for as long as 4 months. And by then they've basically completed treatment if they're on rifampin. And of course, if they turn out in the follow-up to be deemed infected, we would treat them, and you can count the period of time they've already been on medication. It's also really important to follow up on the drug susceptibilities for the adult source and adjust treatment if needed. I have seen children treated with 9 months of isoniazid, and no one ever bothered to notice that the parent had INH resistant TB. So basically we had to start all over. Okay, a few more cases. Exposure in newborns, and I get calls about this frequently. This is an illustration, really old, but I like the way it sort of illustrates the possible ways a newborn may get tuberculosis. So probably the rarest would be congenital tuberculosis. I've only had one case in my 35 years of practice. And last time I checked with Dr. Stark and Dr. Cruz, I think they've had at least 2 cases where the TB has spread from the mother. Most of the time when we find tuberculosis in a pregnant woman, she has reactivation TB in her lungs, and it doesn't disseminate. But if she has miliary TB or disseminated disease or disease of the genitourinary tract, or I've seen it, my case was a case of a mother who had primary TB. So she had pneumonia, and we all know the first time you get tuberculosis, there is lymphohematogenous spread, and it did spread to the baby and infected the mother's uterus as well. But this is rare. More commonly, what we see is after the baby's born, someone with pulmonary disease, either the mother or another household member or other contact that has pulmonary disease and infects the baby through the airborne inoculation. So when you have a mother who has either disease or latent TB infection during pregnancy, the big question is the mother contagious? This is going to determine how we treat the mother and the baby. So if mother is not contagious, let's say she has latent TB infection, or she's already been on treatment for some time and has smear negative, then the baby does not need treatment, does not need window prophylaxis, and it's okay for the baby to breastfeed. If the mother is contagious, let's say she's newly diagnosed, has not started treatment, or you have another household member with contagious tuberculosis, we would recommend window prophylaxis for the baby. The question about breastfeeding comes up. Most TB experts I know in pediatrics feel like if the baby's on prophylaxis and the mother or the other TB case are on treatment, that the benefits of breastfeeding outweigh the risk. Okay, so we're going to go through a few scenarios here for newborns, including a mother with latent infection, newly diagnosed disease, a mother that's been treated, and then a drug-resistant case. So here's a mother with a positive skin test at 15 millimeters of induration. Here's a little blow up of her chest x-ray showing some calcified granulomas, but otherwise the rest of the x-ray was normal. Mother is not on treatment. What is her diagnosis? So she has TB infection with evidence of past disease from these calcified granulomas, but is not currently active. Do the mother or the baby need isolation? Are they contagious? No, they're not contagious. Mother has latent infection and cannot spread TB to others. May the baby breastfeed and stay in the room with the mother? And my answer would be yes, because the mother's not contagious. And we get this a lot in our hospital. Okay, mother has TB disease. And how do you determine the risk to the baby? So the mother has AFB smear positive, and she's just starting treatment. This is her chest x-ray, and she has a left lower lobe infiltrate and a right upper lobe two cavitary lesions here. Is this mother contagious? And what does the baby need in this situation? So we want to evaluate, the mother is contagious because she's smear positive and has cavitary disease. We want to evaluate the baby with a 2-view chest x-ray and a physical exam and rule out congenital tuberculosis. We would recommend starting window prophylaxis once we've ruled out disease in the baby. If the mother and the baby both are on therapy, the baby may breastfeed. Some experts recommend the mother wear a mask and that the baby sleep in a separate room to reduce the exposure. And then TB mastitis is rare, but in that case, the mother should not breastfeed. If the mother has multi-drug resistant tuberculosis, or you're considering this as a likely diagnosis, in this situation, most experts would recommend separating the mother and the baby and consulting a TB expert. Okay, what about a mother with treated pulmonary TB who has a newborn? We want to check the drug susceptibilities on the mother, including the smears, and if she's been on therapy and adherent to therapy with directly observed therapy. Most adults on treatment will become AFB smear negative within 2 to 4 weeks, although it can take months in some cases. Once she's had negative smears for 3 consecutive sputums, she's considered no longer contagious. If the mother is on appropriate therapy and no longer contagious, the baby does not need prophylaxis and may breastfeed. Okay, daycare exposure. So this was an actual case that I took care of early in my career. Happened at the institution where I work, where they had a daycare facility for employees. Many of the parents were physicians. And there was a teacher's assistant who had a cough for 6 weeks. It was during the winter. She thought she had the flu. And when she got evaluated, she had cavitary pulmonary disease and was AFB smear positive. There were 135 children under the age of 4 and under, and there were adult staff members who were also exposed. When the health department went out to do the contact investigation, they had hoped to focus on the children who'd been in the classroom with the teacher's assistant, but as it turned out, she was afloat and she went from class to class. And also the group, the kids came together as group for group activities. So in this situation, who needs TB testing, who needs chest x-rays, and who needs treatment? So the health department and I partnered together. Basically everyone that had contact with the adult with pulmonary disease needed to be tested. And for chest x-rays, all the children 4 and under, even if the skin test was negative, and any contacts with a positive skin test, adults needed chest x-rays as well. And then who needs treatment? Any children that were 4 and under who were exposed, we recommended window prophylaxis. And then all contacts that were diagnosed with latent TB infection needed treatment as well. So the partnership, we went on site and the health department provided a mobile van. We were able to get x-rays. Some of the families chose to get their x-rays through their pediatrician. I reviewed all the x-rays. We did, I got together some volunteer residents and nurse practitioners. The parents filled out medical history forms, and we did station physical examinations there at the daycare center. The health department provided window prophylaxis that was given by directly observed preventive therapy by the daycare staff members, and the health department returned and did skin testing 8 to 10 weeks after the last exposure. At baseline in the beginning, we had 1 adult and 3 children who were positive. Now the source case had been sick for 6 weeks, so these could have been people that she had already infected, or they could have been people that had previously been infected. And then at follow-up, 4 adults converted the skin test and 3 children, but there were no additional cases of disease besides the teacher assistant. In older children in the 5 to 10 age group, window prophylaxis is generally not indicated unless the child is immunosuppressed, because children in this age group are at lower risk for progression to TB disease. And also if they're having symptoms, they're going to be able to tell you. We do follow up the skin testing after exposure and treat for infection once it's been diagnosed, and you do want to get your chest x-ray and physical exam to rule out disease if the skin test turns positive. And then in the teenage group, testing for close contacts, it becomes a little more complicated because younger kids mostly are around their parents and relatives, maybe some classrooms, but in teenagers, they have multiple classrooms, lots of friends and outside activities. And so the health department may start off with a contact investigation concentrating on the classroom the child may be in, but often the word gets out and it ends up that we end up testing the whole school. You can do skin testing or IGRA testing, and then follow up once the window period is over. If not treated, remember, teens have about a 15% risk of progression to disease. Disseminated disease is less common, although we do see cavitary disease sometimes in teenagers. So oftentimes in these kind of contact investigations, we will find additional cases of tuberculosis in these school outbreaks. Window prophylaxis is in general not indicated unless the patient has immunosuppression, but we definitely would recommend treatment for infection to prevent further cases in those identified. Now, drug-resistant TB, of course, is a nightmare. If it's INH monoresistant exposure, we can use rifampin for window prophylaxis. If it's MDR with INH and rifampin resistance, there is actually no consistent consensus guidelines on this, but many experts do use window prophylaxis, usually a fluoroquinolone alone or in combination with a second-line drug mentioned here. Basically, I call a friend, meaning Heartland. So in summary, for pediatric TB exposure, the window period is an 8 to 10 week period when the skin test may be undetectable. Young children are at higher risk for progression to disease, especially infants and children under 4. Disseminated TB disease such as miliary and TB meningitis may develop as soon as 1 month after infection, and disseminated TB is more common in infants and children under 2. And this is one of the reasons why window prophylaxis isn't so important and contact investigation as soon as possible to try to prevent this. So how do we prevent tuberculosis in children? We do recommend screening questionnaire for risk factors. And in most cases, this is going to be children who are either foreign born or have traveled to high-risk countries. But as Dr. Armitage showed, this is pretty low yield. Contact investigation is really the most important way that we find cases in children. Window prophylaxis, hopefully early on, will prevent TB progression. And then really latent TB infection, treatment of this is very important in preventing new cases. And you're going to have a talk about that this afternoon. And that's all I have. So I am happy now to answer questions in the show.
So Dr. Smith, it looks like there's a question in the chat box and in the Q&A pod. The Q&A pod question, let's see, was submitted first. It says, can you speak? Okay.
So it said, the question is, can you speak more about the treatment options for window prophylaxis? I've always relied on isoniazid for window period, but I'm curious about recommendations for using rifampin. That's a great question. I used to always use isoniazid, but I have switched in the last probably 15 years over to rifampin, and now that it is considered equivalent, if not superior, in treating latent TB infection. It's very well tolerated by children. And there's a shorter course. If it does turn out the child has latent TB infection, we can treat for 4 months with daily therapy rather than the longer course with isoniazid. So I usually do start, unless there's a contraindication, start my patients on rifampin for window prophylaxis. Here's another question. I have some doctors treat 7 to 10-year-olds for window prophylaxis. Is this okay or should it be discouraged? That's also a good question. I think I don't generally treat kids that are over 4 with window prophylaxis, but it's not unreasonable. If there is a close contact who's highly contagious, children do tolerate the medication very well. It's not a standard recommendation, but you're really just being on the safe side just in case the kid's infected. Remembering though, the progression to disease in this age group, the risk is only 5%, so it's low, and there's much lower risk of dissemination. So my choice is usually to wait and see what the follow-up skin test shows. Next question. Shouldn't the woman with nodules had sputum collected to be sure it wasn't active, especially due to the risk to the infant? We collect sputum from any abnormality. You cannot rule out TB with the chest x-ray alone. That's a really great question too. So yes, if you have some abnormalities on the chest x-ray, most of the time if we have calcified granulomas, it's considered not active. But if the person certainly has symptoms, I've even seen people with a normal chest x-ray that have classic cough, coughing up blood and weight loss and night sweats, and we collect sputums or we get a CT scan and find active TB. So this would be a very helpful thing to do to get sputums. Other questions? Let me see, is there anything in the chat?
There is one, Dr. Smith, from Lori Eidelbach.
Okay, so I see in your presentation that window treatment should be initiated on exposed children equal to or less than 4 years old. I always thought it was less than 5 years old. Okay, have the guidelines changed? This is actually a great question, Lori, and I know some of my slides were inconsistent on this, but you heard Dr. Armitage say less than 5. And I've seen sometimes in the CDC literature, it'll say less than 4, but less than or equal to 4 would be usually the age. So we would include 4-year-olds in this group. The risk, though, is the most high in kids that are between birth and 2. Very, very high risk.
Hi, Kim, this is Lisa. Can I add one thing?
Yes.
Because, Lori brings up a good point. It's that you see less than 5, you see 4 and under, so I always say when the 5th candle goes on the birthday cake, that's the point at which I say they can be screened with the adult. So yes. That's the easiest way that I can, the easiest way that I can think of to describe it is once they get candle number 5, they have 5 candles on the cake, then you can screen them with the adult population. That's about the easiest way I can think of to say it. That's good. And I wanted to, there was one question from Joel Massey, and I answered it in the chat box, but he actually put it. I answered it in the Q&A, but this was kind of more relevant to your talk, so I wanted to add his in there. So it says, for Dr. Kim Connolly Smith, I had a child contact to an infectious case, grandfather, who screened negative on initial TST and T-spot, but the parents were reluctant to initiate preventative DOPT. The primary pediatric provider ordered the screening chest x-ray with noted hilar interstitial thickening, but the pediatric provider called it viral illness because of a concurrent rhinitis. The child subsequently became symptomatic and was diagnosed with pulmonary TB prior to the second round of testing. Any tips to help build confidence among parents that the DOPT is worthwhile?
That's a great question. I have a couple of cases right now that I'm following that have a similar story. And you can see perihilar, peribronchial findings on x-rays when children have viral illnesses. And sometimes even when we do x-rays in adult, maybe the first x-ray, you're just not quite sure if it's active TB or not. I usually watch those kids like a hawk and hold off on starting treatment if the kid's asymptomatic and looks good, and maybe have them. I have a kid right now that we asked to come back in a few days or a week to get another chest x-ray. If they're a little bit older, you can even wait a longer. But in the really young kids, I'm more nervous. If you're really concerned and don't feel like you can wait, a chest CT can be ordered, or sometimes we'll just go ahead and start therapy on the child. But perihilar peribronchial infiltrates is very consistent with a viral infection, but as we all know, the hilaradenopath in children is what we're worried about with TB disease. Talking with parents, we usually, my assistant Elsa is great at sort of explaining to them why it's really important that we get them evaluated and get them on treatment. And she starts off non-threatening, but as they maybe miss an appointment or don't get that follow-up chest x-ray, we start explaining things like TB meningitis and brain damage and death. And then that sometimes gets their attention. If that doesn't work, I get the health department, who's probably already involved since there's a adult source case, to help us. And in this one child who I had some questionable, had a questionable infiltrate on the chest x-ray that we were going to repeat the x-ray. The mother still hasn't brought them in. I'm going to, in some cases we might resort to calling CPS if we have to, but I haven't had to do that. I've usually been able to get people to come in or get the health department to help me get them in to get evaluated. I also see a question from Catherine. Is there a difference between using the IGRA or the skin test? Are these screening tests equal? And I believe this afternoon in diagnosing and treating latent TB infection, Dr. Cruz is going to talk about that in much more detail. But this is a little, depends on which guidelines you look at, but the American Academy of Pediatrics has approved the IGRA test for children 2 and over. Some experts even believe in even younger children, the IGRA is accurate. I prefer the IGRA in patients who are BCG vaccinated. If your child is born in the United States and they're not BCG vaccinated, either test are pretty much equivalent. The skin test, of course, requires a return visit and a skilled person to interpret the results. So these are all considerations. I think the health department prefers, when they're going out to the large high school investigations, the IGRAs are easier because you don't have to get the follow-up for the reading of the skin test. But it is more expensive. But both tests are good. They're pretty much equivalent. There is some question in the really young children under 2 about the sensitivity in some studies. Some other studies have shown the sensitivity to be fairly equivalent. So we'll leave that to Dr. Cruz to sort out for us this afternoon. Any other questions?
Dr. Smith, I think there was one more question in the Q&A box.
Oh, okay, I see it here. A 3-year-old and a 5-year-old siblings with household exposure. How do you explain to the parents prophylaxis for 3-year-old, but not for the older sibling? That's a great question. In that situation, I would tell the parents sort of why we're really worried about the 3-year-old and how the 5-year-old has a better, stronger immune system. and kind of gauge on how worried the parents are. So the 3-year-old would definitely be in the group we would recommend window prophylaxis. But if the parents are more worried about disease than they are about the antibiotics, you could certainly offer prophylaxis to both children. If they're more scared about the antibiotics, then most of them would understand why the 3-year-old is more vulnerable, has been my experience. And then I see one more question. 1-month-old household contact. 7 of 8 household members positive on the first round. Baby completes 4 months of rifampin. How do you proceed with testing? How reliable is the skin test in 6 months? So that's a great question too. There's, I don't know that there's a lot of good hard data on this, but there's a lot of anecdotal data saying that the skin test is unreliable in children 6 months and under. I would agree in this case with treating the child for full 4 months of rifampin and consider them treated. And it almost, I'm not even sure I would repeat the skin test because the child's completed therapy. I would give them a certificate saying they've been treated for latent TB infection. You could do a skin test at that point just to document, but I would tell the parents I would expect it to be positive. And you could do that at 6 months or later. All right, I think I'm going to stop here because we have my friend and a wonderful speaker, Dr. Susan John, up next. And so I'm going to sign out and I'll be around later if there's other questions. Thank you.
I'm going to introduce our next speaker, Susan John. Dr. John is a specialist in the diagnostic imaging of pediatric patients to include the radiography, fluoroscopy, ultrasound, CT, MRI, and nuclear imaging. She is a professor of radiology and pediatrics and is the current chair of the Department of Diagnostic and Interventional Imaging at the University of Texas Medical School at Houston. Dr. John received her medical degree from the University of Texas Medical Branch in Galveston, Texas, and is a member of the Texas Medical Association and recipient of the John S. Dunn Distinguished Chair in Radiology. Please welcome Dr. John.
Thank you very much. I'm so happy to be here today. So I'm going to discuss with you today the radiologic investigation of TB in children, which can sometimes be quite challenging. I have no financial disclosures. And so we're really going to talk this morning about some of the imaging findings that you'll see on various types of imaging and how you can use those findings to help differentiate TB from other conditions that may appear similar. And we'll also talk somewhat about how to use advanced imaging like CT and MRI to help you in special cases. So, of course, in primary TB, which is what we're dealing with in children primarily, any system can be involved. And therefore, we often find ourselves needing to use various types of imaging to be able to fully evaluate the extent of the disease in any given patient. But of course, the chest is the place where we usually start. It's the most common place that we look for tuberculosis in children. And the imaging findings on any type of imaging that you do really reflect the progression of the infection that we know. In the lung, that's going to be the initial primary focus within the lung that then drains to the regional lymph nodes and then can spread beyond that either through interbronchial spread or to adjacent pleural and pericardial spaces or widely by hematogenous dissemination. So in terms of the lungs, we're going to look at chest X-rays, obviously, because that primary focus of infection is not the primary finding that we're going to look for. That usually is an airspace opacity, but it can be very variable in size, and it's often quite small, and frequently is very transient or may be hidden by other structures in the chest. So it isn't the most common thing that we really look for on a chest X-ray. You can have a little bit of a pleural reaction, but usually pleural reaction isn't a profound finding either. So if you're looking for a gone focus, you're really looking for just a tiny opacity. And here you can see the opacity in the chest. In this patient is really very faint, ill-defined, could easily be mistaken for a small area of atelectasis, which is a very common finding in young children. Wow. My mouse is moving me forward and backward quickly here. So, but airspace disease can also be much more profound. So you can have a consolidation that very much looks like a standard bacterial pneumonia. And it can be more progressive, particularly in those cases where you have primary progressive disease. So lung disease with TB can be very variable. So what we really look for to help us have a more a confident suspicion of primary TB is lymphadenopathy. It really is the hallmark of TB on the chest X-ray. And you'll see it in the majority of cases, but not early on. Usually it'll take 1, 2, 3 months for you to really be able to see the lymphadenopathy on the chest X-ray. We tend to see that more commonly in young children than we do in older children. And I'll have to tell you that even expert radiologists sometimes don't totally agree about X-rays on whether there's actually lymphadenopathy present or not, which can cause you some challenges if you're trying to treat the patient. And the reason that is true is that it's really kind of hard to see the areas where lymph nodes occur in the chest. And so getting 2 views of the chest is really important. I'd like to convince you that don't always confine yourself to just 1 view of the chest. And you're going to be looking primarily on a chest X-ray at the hilar regions, particularly the right hilum and the paratracheal region, which are the places that you'll tend to see it most common. So where are these locations on a chest X-ray? This is a more normal chest X-ray, just to show you that the hilar regions are here in the center of the chest. That's also a place where blood vessels come out. And so it sometimes can be challenging to determine whether you're dealing with just prominent blood vessels or you've actually got little masses there like lymph nodes. And then the paratracheal region on the right is also a pretty common place for us to see lymph nodes in the chest X-ray. So if you're trying to decide whether that's just blood vessels or whether you've actually got lymph nodes there, look for this concavity between the vessels, because the hilar vessels will come out and you'll get kind of a clear area there with a V shape to it. That will tell you, no, those are just branching vessels. That is not a mass. And that's going to be pretty important when you try to compare that to a case like this, where you see there's a lot of stuff going on there in the hilar region. Is that lymphadenopathy? Are those just prominent vessels? And so you really need to evaluate whether you've got any convexity there. So in this patient, you've got hilar that looks slightly different. On the right, you can see that you've really got convexity there. You've got a mass-like appearance in the hilar region, compared to the other side where you have more concavity, where the vessels are branching out. So on the right side here, we have lymphadenopathy. On the left side, we have normal prominent vessels. Also, we use the lateral view. As I said, the lateral views can be very helpful because sometimes you're not quite sure whether there's convexity or not there. Beware of the right pulmonary artery, which comes out and causes kind of a rounded opacity in the front area of the lung hilum. Don't mistake that for a lymph node. But if you look below the right pulmonary artery here in this patient, you can see a rounded opacity, and that's really the subcarinal region of the chest. And that's a very common place to see lymphadenopathy with TB. Also, posterior to the lung hilum is another place where we don't have it in this patient, but that's a common place to see it. So you can use your lateral view to really be supportive of any findings that you see on the frontal view of the chest. So here's just a comparison. Here on the lateral view, on the normal side, you see a clear area in the infrahilar space, whereas on the abnormal side with lymphadenopathy, you see a rounded convex mass-like appearance due to subcarinal lymphadenopathy. This is another patient, and young children, of course, have thymus glands, so that can also cause you a problem on your frontal views. So you sort of faintly see a hint of some convexity on the PA view, and when you look on the lateral view, the arrow is showing you there's some retrohilar lymphadenopathy in the chest that shouldn't be there. Another problem you can run into is if you don't have well-positioned film. So it's always important that the film is done very straight. This patient just rotated a little bit to the left. You can see the ribs are asymmetrical, and you don't really see much in the hilar region until you straighten that patient out. And then the convexity that is related to the left hilar lymphadenopathy. So we don't do nearly as well with the left lung hilum because there's often mediastinal structures that project out over it. And so it's much harder to see the lymph nodes, even though that's also a pretty common place for lymphadenopathy in primary TB. So we know that CT helps us a lot, definitely will improve your detection. And although many times we can miss lymph nodes on a chest x-ray, we don't use CT routinely. So mostly we use CT when we are highly suspicious of it, and yet we have suspicious findings or questionable findings on your x-ray, or in particularly high-risk groups where it's really extremely important for you to know whether lymph nodes are there or not. And in those cases, CT is going to help you. You need to always use IV contrast when you do it, because there are many structures in the mediastinum that you can't distinguish from lymph nodes unless you enhance them with IV contrast. I find these days everybody that orders a chest CT orders it as a high resolution CT. And high resolution CTs are great for looking at the lung parenchyma, but you don't need that to look at the mediastinum. And really you can't do high resolution CTs very well on young children because they can't hold still, they can't hold their breath. So it's not really necessary to have a high resolution CT, but IV contrast is important. This is an example of a chest CT that's done without IV contrast, and you can see that you can't tell where the heart or the vessels or the lung disease really starts and stops. So have to use IV contrast. What about MRI? Everybody is wanting to avoid the radiation with CT these days, and MRI does have some benefits. You can see mediastinal lymph nodes very well, especially if they're larger than 7 millimeters. You can sometimes see pulmonary nodules or lung consolidations, and it's certainly very good for pleural effusions. But MRI has some problems. One, it's an expensive modality. It's just not available everywhere. Young children, you're going to have to sedate them or use anesthesia. And really, MRI is not great for lung disease. It does very well with the mediastinum, but it doesn't really do all that well with the lung. So we really, unless we have a really strong reason, don't tend to use MRI very often. So we're looking at CT, and the sites really you're going to look for lymph nodes are almost anywhere, but the most common sites are the subcarinal region and the hilar region. Hilar lymphadenopathy on CT is often, in fact, most often is bilateral. And in fact, most patients will have some lymph nodes at multiple sites. And so we'll really be able to identify those much more clearly with CT. So where do you look on CT? Well, the axial images are the most commonly used. Beware of the thymus gland, which you can see there marked with the T in the anterior mediastinum. That's a normal structure in children, although you can have lymphadenopathy in the anterior mediastinum. So you have to look for enhancing nodules that might be separate from the thymus gland. But other places to look are the subcarinal region, where the branching of the right and left mainstem bronchus comes apart. Look in the hilar region, either on the right or the left, and in the paratracheal region. Notice the enhancement pattern of all of these lymph nodes, which is fairly typical for lymph nodes due to primary tuberculosis. Size of lymph nodes is not very well established what an abnormal lymph node is, but in general, we say that if a lymph node is greater than 1 centimeter in size, then it has a better chance of being abnormal. And these lymph nodes can tend to enlarge over a period of time, even up to a year after exposure. So they may be very variable in size. This appearance with a low density center with sort of an ill-defined enhancing rim is quite characteristic for TB, although it's not pathognomonic. You can see that with early necrosis in lymph nodes for other reasons. But if you don't see that, then you wonder whether it really is TB. And then calcifications, of course, are quite common and are an important finding. But calcifications aren't all that easy to see on a chest x-ray. We'll see it up to 20% of the time on a CT, but they can be much more difficult to see in the hilar and the mediastinal region on x-ray. Generally, it takes a while for the calcifications to occur within those areas of caseation. It may take as long as 4 years to actually get calcified nodes. So you're not going to tend to see calcifications in young infants. But the calcium does occur earlier in young children than it does when you have it occur in older patients. This is a patient that had an area of atelectasis in the lung, and the calcifications were really not clearly visible because other things look dense on chest x-ray. The vessels themselves can actually look somewhat dense when you look at them on end. So CT was really helpful here because we could use a bone window. If you use a bone algorithm, then those calcifications are going to really pop out, and you can see all these multiple small calcifications within the right hilar and paratracheal nodes that weren't really clearly visible on the chest x-ray. Also, thymus gland can hide paratracheal or mediastinal or hilar lymphadenopathy. This was a young child. See a bulge there? Is that the thymus gland or is that a lymph node? And CT really much more clearly showed that there was an enlarged retrocaval paratracheal node in this child with some peripheral enhancement and maybe even some small calcifications. Lymphadenopathy can cause complications in primary TB, primarily can compromise the airway, and that can happen in a couple of ways. It can be the lymph nodes themselves that can cause extrinsic compression on the airway, and if it's incomplete obstruction, it will allow air to go into the lung but not get out of the lung, so you get an obstructive emphysema type of a picture. If the obstruction is complete, then you're going to gradually get a progressive collapse of the lung or atelectasis. And this tends to occur more often on the left than the right, probably because of the orientation of the airway on the left. You can also get intrinsic causes of airway obstruction, either because of bronchial wall granulomas or because of the caseous material that's been extruded into the lumen of the bronchus. Atelectasis can be mild or profound. In this case, you can see a little vague area that kind of looks like that primary gone complex or focus that I showed you initially, but you can see here that there's some bulging of the oblique fissure toward this density that tells you that there's some volume loss here. So this is just a mild degree of atelectasis in this child with TB. You can see some prominent nodes there on the left on the lateral view. This is another patient that had rather prominent bilateral hilar lymphadenopathy initially, didn't have much to see in the lungs until about a month later when the child came back with some respiratory distress and had atelectasis in the left lower lobe that went on a week later to become complete atelectasis of the left lung. So the compromise of the airway can be something that can be progressive over time. And so don't be surprised if you see that simply related to airway compromise by the disease. This is another example where the compression of the airway was partial. You can see the left lung is very radiolucent compared to the right lung and is a little bit larger. And you've got kind of a bulge here in the left hilum, that's left hilar lymphadenopathy. And if you look close, you can see that the airway is partially compressed here and narrowed. And this tends to occur more commonly in young children because, of course, their airway is smaller. And so it's much more easily compromised. Post-primary TB, the type that we tend to see more often in adults, is not seen very often in young children these days. So if you're going to see it, mostly we see it in adolescents or maybe in immunocompromised patients. It, of course, tends to occur in the upper parts of the lung, either the apical and posterior portions of the upper lobes or the apical segments of the lower lobes. And this can go on to lead to cavities and fibrosis, much like you would see in any adult that has post-primary TB. The cavities often are very thick-walled and ugly looking and may be associated with a lot of nodular and fibrotic disease as well. But cavities can occur in younger children in cases of progressive primary disease, where you have a consolidated area of the lung that then can go on and develop radiolucencies internally that can eventually become cavities. Cavities, generally we'll consider it to be a cavity if it has a thick wall, because the other thing that can happen is you can also get nematoceles within a resolving primary focus within the lung. Nematoceles are simply little areas with small airway obstruction that get a focal area of obstructive emphysema in a alveolar group, say. And so they tend to have very thin walls as compared to cavities, and they're transient. They will eventually go away. So it's a much different prognosis if you have nematoceles than cavities. This was a child who had an unusual case of congenital TB that had very bad lung disease early on. The child actually was discharged with a chest x-ray that looked like this. And I was pretty sure that these were going to be cavities and that this child was going to have ugly appearing lungs forever. But to my surprise, 6 months later, when this child came back for follow-up, all of those cystic areas had collapsed and had gone. So nematoceles are not a rare finding. And then with wide dissemination, certainly within the lung, we have your typical miliary type of TB. The milia are the size of millet seeds. Therefore, they are typically less than 2 millimeters of size. But in children, sometimes you can have larger nodules or even sort of multifocal patchy disease that's also due to hematogenous spread. Miliary disease tends to be bilateral and usually is evenly distributed throughout the lungs, and it's not a segmental or focal type of a process. And so you'll get the lungs diffusely carpeted with these very small nodules throughout the lungs. And so here you can see the telltale calcified granuloma, which lets you know this is not an early case, but actually developed miliary disease a little bit later once the lymph nodes were able to calcify. Miliary nodules can be hard to see on chest x-ray. And so if you're suspecting them, CT is going to be a helpful study to acquire. And they will show up as tiny peripheral nodules that occur along the lung parenchyma. This is just a child that has slightly larger nodules, just to show you that they may not all look like millet seeds, and they can be somewhat variable in size in some patients. And in this child, they're very small nodules, but they're so numerous that they actually are compromising the airspace, and they make it look very much like this child has pulmonary edema. And it's very difficult to resolve the fact that these are all just hundreds of tiny nodules within the lungs. So once again, if you have a suspicion that you've got miliary disease, then use CT liberally. And here you can see, this is what has been considered to be a fairly classic picture. It's this tree and bud pattern where you have a central lobular nodule with some thickening of the bronchi branching out from it. And this is really a feature of endobronchial spread of disease. And you can see it in this child who was immunocompromised because of a malignancy. Progressive primary TB can give you many different changes. They often will have much atelectasis, but they can actually get consolidated areas in the lung. They can get areas of fibrosis, lymphadenopathy that can be quite persistent, and they can also get cavitation and eventually end up with some bronchiectasis. So you can see in this child on the chest X-ray, you wouldn't be quite sure whether you're simply dealing with atelectasis because the mediastinum looks sort of shifted there. But with the contrast enhanced CT, you can resolve a lot of lung disease. You can see some nodularity to it. You can even see some suggestion of some mediastinal nodes with the peripheral enhancement by using CT. Pleural and pericardial disease is uncommon. Pleural effusions are not rare. We do see them sometimes, and they can occur either because the lymphatics are obstructed by the granulomatous, or you can get a hypersensitivity reaction that can cause more of a transudate type of a pleural effusion. It doesn't do much good to tap these effusions because the cultures generally don't show you much. So that's not very profitable in many cases. Pericardial effusions are really pretty uncommon. We don't see them often enough, and they're often related to direct extension of the disease from the mediastinal lymph nodes, although occasionally they can occur due to hematogenous spread. And this can be a delayed finding in many cases. Here you can see a very large left pleural effusion that's obvious on your chest X-ray. And sometimes this is a surprise. You'll have a child who's not very symptomatic and comes in for a chest X-ray for some relatively minor symptoms, and then you find a rather remarkable pleural effusion. These effusions are usually self-limiting, and so you don't always have to treat them and do VATS procedures or other types of aggressive tactics, especially if they're not particularly causing any problems for the child. But if you have lung disease associated with a pleural effusion, then on your chest X-ray, it can be much more difficult to tell what you're dealing with. So in those cases, ultrasound is a great way to distinguish fluid from solid places in the lung. And of course, CT can really give you a nice roadmap for what's really going on. So in the central nervous system, it's a less common place for it to occur, but when it occurs, it's a big problem for children. And often this occurs in younger children, children under 2 years of age. The vast majority of the children are going to have an abnormal chest X-ray, so it's worthwhile. If you think that you've got tuberculous meningitis or TB of the brain, to get a chest X-ray. And most often, this is going to be related to hematogenous spread, although occasionally, if you have skull involvement with TB or TB in the middle ear, it can extend directly into the brain. And you can have many different manifestations within the central nervous system. You can have focal brain disease, you can have meningitis, and then dreaded complications are things like infarction and hydrocephalus that can happen pretty early on, actually, with tuberculous meningitis. In terms of localized disease within the brain, the most common thing we see are small focal lesions that we call tuberculomas. They generally are small round lesions, and they may appear as solid enhancing lesions, or they may show ring enhancement, which is pretty typical. And you can see these, they look pretty much the same on either CT or MRI, but whatever you do, you'll probably want to use IV contrast because these lesions are not very clearly visible if you don't use contrast material. They tend to be small, and they don't usually have calcifications within them. So on non-contrast CT scan is not going to really help you with them. Tuberculous meningitis is a more diffuse form of the disease, and you can use CT or MRI for making the diagnosis. Meningitis in general is not really a CT diagnosis, but with TB, because of the profound inflammatory response that it causes to the meningeal surfaces and spaces, we do actually a little bit better in making the diagnosis. And even on a non-contrast CT, you can see some findings. You can actually see some increased density in the basal cisterns because of this dense exudate that tends to be associated with TB meningitis. But in general, you'll want to use IV contrast once again. You'll want to see that enhancement, and it looks pretty much the same on both CT and MRI. On this non-contrast head CT, you can see that around the circle of Willis, it actually looks denser than it does in the white matter of the brain. And that's the opposite of what you would expect to see on a non-contrast CT, where the circle of Willis really is not very dense at all. But when you give IV contrast, you can see the very profound enhancement that surrounds the basal cisterns and the vessels in the central portion of the brain. And your more garden variety forms of meningitis aren't really associated with this degree of contrast enhancement generally. Same is true on MRI. And MRI without IV contrast, you actually don't tend to see a whole lot with tuberculous meningitis. So it's really important to give gadolinium if you're going to use MRI. And here on this, on the right side, this contrast enhanced scan, you can once again see the very profound enhancement, and you can see the double track sign where you have the vessel that's black in the middle showing a flow void within the vessel surrounded by this profound enhancement at the base of the brain. That's very characteristic of tuberculous meningitis. Contrast will also help you if you have meningitic changes within the spinal canal, and you often have a nodularity to it, which isn't typical for other types of meningitis. So if you see some small nodules, either in the meninges in the brain or in the spinal canal, it's suggestive of TB. And then infarcts, of course, also produce abnormal areas of enhancement or just simple T2 bright lesions within the brain. And they tend, as opposed to the tuberculomas, they tend to be more ill-defined or angular shaped, whereas the tuberculomas tend to be more round or ring-shaped type lesions. Moving to the abdomen, we don't see abdominal disease as often in children as in adults, but it can involve just about any organ and any space within the abdomen. So you will not do very well with plain films. So you're definitely going to want to get some kind of advanced imaging if you suspect abdominal TB. Once again, mostly we're looking for lymph nodes. We're looking for lymphadenopathy, and it tends to occur in the periaortic, mesenteric, and periportal regions most commonly, but these are also common regions for other types of lymphadenopathy. It commonly will calcify in the abdomen over time, and so you may see characteristic calcifications within the nodes. This was a 12-year-old who came in with some suspicious clinical findings of night sweats and weight loss and had back pain. Chest x-ray was not very specific. We did see a right pleural effusion on the chest x-ray, but no other findings that really would have been clues that this was TB. But in the abdomen, you could see these multiple round lymph nodes that are very large and have very profound peripheral enhancement. So once again, that rim enhancement pattern is quite characteristic of TB, and it was very helpful in suggesting the diagnosis in this particular patient. When TB involves the solid organs, often it's going to be the liver or the spleen, and you tend to either get small microabscesses or little granulomas. These lesions tend to be very small. And so if you're good, and ultrasound's pretty good for making the diagnosis, but you're going to want to use a very high frequency transducer. So if you're looking for these lesions in the liver or spleen with ultrasound, please convey to your radiologist that you're looking for them so that they'll use a megahertz frequency of ultrasound transducer that will allow you to see these. You don't get much depth of penetration, but you get much better resolution with high frequency ultrasound. And you'll see these very hypoechoic round nodules scattered within the organ. These are not specific. You can see this with Bartonella. You can see it with other types of granulomatous disease, but in the proper setting, they're diagnostic. TB peritonitis is really pretty rare. I have seen very few cases of this. When it does occur, it's really an adhesive form of peritonitis, so it really causes a lot of profound fibrotic disease in the peritoneal space, and it'll cause a lot of matting of bowel. And sometimes it can worry you that you're dealing with a malignancy rather than tuberculous disease. It can look very much like peritoneal carcinomatosis. So it's quite unusual. Skeletal TB in children is uncommon, but we do see it from time to time. Once again, mostly it's going to be hematogenious in origin, and often you don't ever find where the primary site of the disease really was when you have skeletal TB. And once again, the progression of disease is what we know it to be. You get granulomas that become caseating. They cause trabecular destruction within the center of the bone, goes on to cause more cortical destruction in the bone, and eventually can give you some periosteal reaction and maybe even some soft tissue involvement adjacent to the bone. The most common site that we think of in the skeleton that's involved with TB will be the spine. And mostly this consists of vertebral body abscesses that often are involving multiple contiguous vertebral bodies. So the vast majority of the time, it won't be just one location. It'll extend across 2 or 3 or more vertebral bodies. And the disease can then spread into the subligamentous areas and even into the adjacent soft tissues. And so you'll tend to get these profound exudative collections that cause a mass effect that you can actually see sometimes on chest x-ray if you look closely for them. Most often it doesn't involve the posterior elements. It'll mostly be the vertebral bodies that are involved. So here's a chest x-ray in a child with fairly advanced disease. And you can see the mass effect in the paraspinal region on either side of the spine associated with densely calcified lymph nodes. And on the lateral view, you can see that there's been a lot of destruction of the vertebral bodies here that's actually causing a marked kyphotic deformity. So this can be very debilitating and deforming when it occurs. Fortunately, not a very common thing in this country, but we have seen some cases. The second most common site in the skeleton is going to be your joints. And it's mostly the large joints, particularly in the lower extremities, that tend to develop TB arthritis. And the finding is mostly just joint fluid, and we don't really do well in telling you that this joint fluid is due to TB versus anything else that causes joint fluid. But certainly ultrasound is a good way to look for joint fluid, particularly at the hips, where you don't really have other x-ray findings that can tell you have joint fluid. So look for joint effusions if you're suspecting a tuberculous arthritis. Bony involvement, actual osteomyelitis of TB is pretty uncommon. Mostly it's just going to be a solitary lesion. We don't tend to see multifocal TB within the bones in children. And often they won't have any chest x-ray evidence that there's disease. Once again, the primary site is usually fairly occult once you have skeletal involvement. And you can see it in a variety of places. Traditionally, we look in the hands, the skull, the metaphyseal regions of the long bones, which are also a common site for other types of osteomyelitis, and even the ribs can be involved. You see two real types of patterns of TB in the bones. There's a cystic form that's really the most common form that'll give you this osteolytic lesion that often is quite expansile. Doesn't often have a lot of sclerosis around it. It can look very much like histiocytosis and other things that give you osteolytic lesions without sclerosis. And then there's an infiltrative form that gives you more of a moth-eaten pattern, a more aggressive type of a pattern that can look like other types of osteomyelitis. It can even resemble primary bone malignancies like Ewing sarcoma and can be very worrisome. Spina ventosa is a term given to the dactylitis, or the involvement of the short tubular bones of the hands and feet that we sometimes see in young children. It'll give you expansile osteolytic lesions in those bones that is fairly characteristic. This was a child that was suspected of having TB or was diagnosed with TB and didn't really have a lot of findings on the chest x-ray, except for some bulging here posterior to the sternum. So some bones are just not really very well evaluated on x-rays, particularly on chest x-rays. So a CT was very helpful here, because you can see that we found this destructive lesion within the sternum that extended both anterior to the sternum and also into the retrosternal space, which was that bulge that we saw in the chest x-ray. So CT or MRI are going to be very helpful for making diagnosis of these types of bony involvement. And then the skull is a well-known site for TB, although not common. Mostly occurs in children and young patients. Most of the time you'll be able to see the destructive lesion even on a skull film. So radiographs can be helpful to you. Often the disease will once again spread into the subgaleal space, and you'll be able to palpate that as a lump on the skull. But remember that if you have extension exterior to the skull, you can also have extension interior to the skull. So it's really important to get a CT or an MRI if you see these lesions, to evaluate for any intracranial component that might have occurred. So overall, I think you can see that TB has very variable appearance and sometimes non-specific, but there are some very important clues. Certainly lymphadenopathy is still our key, and looking in those locations that are really common for it can really help you to suggest the diagnosis, and using CT to help you see that rim enhancement type of a pattern can also be very helpful. So I think mostly you're going to want to use CT or MRI when you already have suggestive radiographs, or when you have confusing findings on your radiographs, or when you have TB that might have gone to locations like the brain or the skeleton or the abdomen, where you really can't evaluate them in other ways. So I'm happy to answer any questions that anyone might have, if we have a few minutes.
Hi, yes, thank you, Dr. John. So please type in your questions in the Q&A pod.
See if I can get to the Q&A pod.
I think you have to stop sharing.
I'll stop sharing. Yeah, that'll probably help.
Okay.
Me. Okay, now I can. Okay.
So again, please, if you have any questions for Dr. John, please type them into the Q&A pod. And again, just to clarify, all of the presentation handouts and a recording of this webcast will be made available after the webcast, probably in the next few days, on the archive page, which can be found at heartlandntbc.org under the training tab. But we will also send all participants who joined us today a notification to let them know when these have been posted.
Well, I think most of the questions come up about TB when you've actually got a patient, right? You got a patient with a confusing chest x-ray and you want to know what to do. So feel free to reach out to me at any time. I'm going to make my my email address, and Dr. Smith knows how to find me. So
all right.
Any questions you might have about any individual patient anytime.
Oh, Dr. John, there is a question in the Q&A. It says, when we see atelectasis on a chest x-ray, how long should we expect it to resolve if it is not extrinsic compression?
Well, that's really variable, you know, and depends somewhat on if you're dealing with, you're dealing with a granuloma that's not going to go away quickly, or if it's just some plugging of the bronchus due to some exudate that's, or some caseating material that's gotten into the bronchus. So it's pretty variable. I would say I wouldn't worry about it too much unless you see it becoming progressive. And clearly, if you are like the patient that went on to progress to an entire atelectasis of the lung, somebody's going to do a bronchoscopy on that patient and try to fix it. Otherwise, I think you can follow it, and most of the time it'll resolve very quickly. But if you have very profound obstruction, it's not going to resolve without some help, probably.
All right. It doesn't look like there are any other questions. Oh, there is one. I'm sorry. How long will you treat TB on the spine? A child of 1 year, 6 months, not severe on the X-ray.
Oh, well, that's a question for somebody who actually does the treating. So I can't answer that for you. I don't know if Kim is on here or any of.
Yeah, I'm on. I can speak to that. For bone and joint disease, the recommendation is the same as it is for meningitis, usually 9 to 12 months of therapy. So that would be our recommendation.
Yeah, this is Lisa Armitage. I echo Kim's. The question of, if it's that a lot of disease, would you shorten the treatment? I would say no. Getting the drug into the bone to kill all the organisms takes some time. So I agree with Dr. Smith. You may be with minimal disease. You may be looking more at the 9-month range of things, and having an experienced radiologist that can tell you a little bit about what is happening, what the lesion is doing, how the lesion is responding, is such a huge value to being able to make that decision. But I would not shorten the treatment beyond the recommended 9 to 12 months.
Yeah, and MRI is really going to be your primary tool to follow these with, even though it's challenging in a young child to do that. You're going to do a much better job in evaluating extent of disease and seeing how it resolves and seeing any complications that might potentially be impending if you use MRI.
There's another question. Are there specific protocols to reduce radiation exposure with CT in children? Do we need to specify that on a radiology request, or is it automatic?
Well, that's a very good question. It's a very loaded question. Yes, there are definitely protocols, and most children's hospitals, in fact, I would say all children's hospitals now have protocols in place to use the lowest possible radiation dose when you're doing CT in children. And it's based on patient size. And the CT vendors have gotten much better also in creating equipment that produces a much lower dose for imaging children. The problem becomes many children are imaged in places that are not children's hospitals. They're places where children aren't done very often. And that's where we run into some difficulty, because the technologists, even the doctors, are not as attuned to what you need to do to decrease the dose. So I think if you're sending a child to a facility that doesn't do very many children, then it's probably a good idea to ask them what they do to reduce the dose for children. I think it's important to be assertive about that. It should be automatic, but it often isn't. And so I think out in the community, it's a good idea to investigate that for yourself.
Let's see, and there's actually 2 more questions. A chest X-ray with a small amount of atelectasis could be a finding of many different diagnoses. With a positive TST or IGRA, would you recommend further imaging?
Well, that's a good question. If you see atelectasis and you don't see lymphadenopathy, then I'm going to have a pretty low index of suspicion. But as I said, lymph nodes aren't always that easy to see. So if you have any question at all about whether any lymph nodes are present, certainly having positive testing, then that makes you much more suspicious that you might be missing something in the mediastinum. In my experience here, we still don't use CT very often for children with TB. And Kim, maybe you want to comment on that about how you decide when you're going to use it.
Yeah, that's a tough one. I was taught by my mentor, Dr. Stark, who's coming up next, that if you can't see it on the plain imaging, it's probably not disease. But I use CT more when we're having a hard time making a decision, like you've mentioned, or in a case where maybe you're thinking about TB meningitis and you want to look more carefully to see if there's any hyaluradenopathy in the chest that's not visible on a plain imaging that might support your diagnosis. Obviously in the abdominal cases, which we don't see very often, but that's the only way we're going to be able to evaluate for lymph nodes. But for atelectasis, what I've done, depending on the child, is maybe repeat the imaging in a week or two and see if it resolves or gets worse without treatment if the child's not very young. Some of the other, Dr. Armitage or Dr. Stark may have some other comments on that.
Hi, this is Jeff. I'll make a couple comments. Can you hear me okay, Kim?
Yes, we can hear you.
Great, okay. So this is difficult. Our decision rules for treating people for TB infection versus TB disease are really based on plain chest x-ray. And we know CT is much more sensitive. So we know there's some kids with normal chest x-rays that we can see lymph nodes on the CT that we can't see. But we also know from 50 years of experience and millions of people, that when we treat those kids for TB infection, they do just fine. And the way I sort of describe it, and then we'll get to this a little bit more in my talk, is we're using the chest x-ray in a way to try to estimate the body burden of organisms. And that's what drives our therapy, whether we treat people for TB infection or TB disease. So, when I'm just evaluating a child for TB infection, I really argue against the use of CT scan. I don't think it helps. When you have a child who comes in sick, however, and you're not sure what the diagnosis is, that's when CT scan can be really helpful, as Kim was alluding to, because if you do see nodes or something as the cause, in this case, of the atelectasis or whatever else, it can help sort of point you in the right direction, as opposed to other conditions or infections that could cause similar chest x-ray findings as well. So I find CT to the chest most useful when I don't know that a child has TB, and not so useful when I'm trying to tell the difference between TB infection and TB disease and how that should dictate my therapy. I hope that's a clear explanation.
And there's one more question. This might go to Dr. John and Dr. Smith, Dr. Armitage, or Dr. Stark. Are there ever any radiographic findings that lead the differential diagnosis more toward M. bovis instead of M. tuberculosis?
Yeah, that's a good question. I don't have a lot of experience with other types of mycobacterial infections, but my guess is I would think that it would be pretty hard to distinguish on a chest x-ray, that you wouldn't have any real distinctive features. They're all mycobacteria. Am I right about that, Kim?
Yeah, this is Lisa Armitage. I haven't, in the handful of cases that we've had in children and also in adults, we haven't seen a big difference in what you see in the chest x-ray. Is generally just the fact that there's so much disease kind of focused in the abdomen. That tends to be it. Ultrasound showing, or even CT scans showing a lot of lymphadenopathy in the belly is what I tend to see, but radiographic findings regarding the chest imaging.
Yeah, the problem is it's so uncommon, it's hard to compare, but remember the mechanism of infection is completely different. there has been airborne transmission of M. bovis documented, but it's frankly rare. Most of the time it's from ingestion of infected milk products of some kind. So as Lisa said, it's predominantly abdominal. Now, whether we see lymph nodes in kids that have bovis, and mostly we see lymph nodes up in the neck. And so I think you're probably more likely to see adenopathy as opposed to pulmonary findings with bovis. But we also see that with TB also. So it's really much more of an epidemiologic and then ultimately culture diagnosis than it is a radiographic distinction.
All right, thank you. And this seems like those are the only questions we have right now. So thank you so much, Dr. John, for that excellent presentation and for your time.
Thank you for inviting me.
Our next speaker is Dr. Jeffrey Stark. Dr. Stark is an internationally recognized expert in the management of childhood tuberculosis and mycobacterial infections. He has participated in the writing of numerous clinical guidelines for the City of Houston, State of Texas, the CDC, the American Thoracic Society, the International Union Against TB and Lung Disease, and the World Health Organization. Please welcome Dr. Stark.
Hi, everybody. Good morning. And Delphine, I just want to make sure my screen sharing is working okay.
It is, yes.
Cool. Okay. Well, thank you very much for having me this morning. I always love doing these talks, and I'm honored to be asked, and especially with everybody else who's talking, who I so admire. So thank you for including me. The title of this talk is about advocacy. We are going to talk about advocacy at the end, but what we're really going to talk about is sort of a potpourri of things, and touch on some of the things that other folks are talking about also, but kind of from the point of view of a clinician. And when I've given this talk before, I've given it to a lot of international audiences. And so that's why I have up here on the title, what can a low burden TB setting contribute to global childhood TB care and prevention? The answer is a lot. And the major reason is that we don't have the noise, so to speak, that a very high prevalence place like South Africa has, where there's so much transmission going on, it's sort of hard to tell what's going on. But because our TB is relatively isolated and occurs in sort of small clusters, we can actually see what's going on, and particularly how that affects children in terms of the likelihood of getting infected, are children ever contagious, all kinds of questions that are actually very difficult to answer in high burden settings, but lend themselves to being looked at low burden settings. So we're going to touch on a whole bunch of those things. And some of these things will kind of bring some of these talks together a little bit too, I hope. So, and by the way, I forgot the slide here. I have no disclosures to say, no conflicts of interest at all. So how do we diagnose TB in adults? Well, diagnosing TB in adults is pretty simple, frankly, because it's mostly a microbiological diagnosis. Sputum microscopy is positive in 60 to 70% of patients, expert in 75 to 85%, culture in 85 to 95%. So the basis of counting adult TB cases in TB is really microbiologic. It's detection of the organism. Having said that, it's still estimated that about a third of the cases that occur every year in the world are not actually reported by government TB programs to the WHO. There's a whole lot of reasons for that. Some of it is the ones that are not microbiologically confirmed, but there's other reasons as well. Only about 10% of the cases in adults are extrapulmonary disease. So it's really dominated by thoracic pulmonary disease. Now, in contradistinction in children, we have a very hard time with the microbiologic confirmation. I don't think it's fair to say we have such a hard time diagnosing tuberculosis. We do have a hard time confirming it microbiologically, which also means we have a very difficult time confirming drug susceptibility results because we don't get the organism very often from the kids. So microscopy is positive less than 10% of the time. Expert somewhere around 15% of the time. And of course, some of these things depend on patient selection, exactly who you're testing these things on. And culture somewhere between 20 and 50% of the time, averaging probably 30% of the time. So 2/3 of the cases, we cannot confirm microbiologically. The problem is for many years, the sole basis of reporting TB cases in children to WHO has been microbiologic confirmation, which meant that the vast majority of children were never reported. So in adults, about 1/3 of the cases never got reported. In children, it was closer to 2/3 and maybe even higher than that in some places. And that's why for such a long time, we really didn't know, had no good estimates about how many kids in the world were actually being affected by tuberculosis as well. Remember that a lot of the young kids, of course, don't even produce sputum, so it's really difficult to confirm. And up to 30% of the cases in some places can be extrapulmonary as well. And that's even more difficult to diagnose with biological confirmation. It's hard to isolate the organism from TB in tissues sometimes. So we have all kinds of problems and challenges, and really trying to, first of all, diagnose TB and then confirm it, and then around the world actually reporting it so we know what's actually going on. And I'm talking a little bit about the global aspects of childhood TB because I think it's really important. And we don't exist, obviously, in a vacuum. And we know that many of our cases, of course, have links to other countries because of either the children themselves or the person that they got it from. So understanding and contributing to the global tuberculosis is really important for us as well. So here's some of the aspects of TB control. But I'm really trying to get away from the phrase TB control. I'm really trying to get away from sort of militaristic. I don't talk about contact investigations anymore. I talk about contact tracing. And I haven't figured out a good equivalent yet for TB control, but maybe we can come up with something. So as I said, we eliminate the background noise. So we see TB as a collection of outbreaks as opposed to something that's sort of endemic in our society. The value of contact tracing, of course, we've really come to understand. Frankly, the rest of the world now is just starting to understand the value of contact tracing. We also know the value of reverse contact tracing, or what we call associate investigation. Contact investigation is you find the contagious person first, and then you trace the people who that person has shared the air with to try to determine who else has infection or disease. Associate is when you find one of the infected people, and then you work backwards to try to find out who they actually got the infection from. So that's an important thing for pediatrics. When we have children who sort of unexpectedly turn out to have TB infection, then the question becomes, well, where'd they get it from? And unlike adults who've been alive for decades and could have been infected anytime during that period of time, if you have a 2-year-old with TB or TB infection, well, there aren't that many contacts. And so quite often we work backwards, and I'll show you some data about this in a minute, where we actually can find other infected people and perhaps even the person who had contagious tuberculosis. We can identify less common modes and locations of transmission. Where is the transmission actually occurring? You know, we've done studies in Houston. I can actually tell you specific bars and restaurants where tuberculosis has been transmitted in the past. Again, we can see that because of the low burden of disease community-wide. We can see the effectiveness of chemotherapy and how well it works for TB infection in addition to TB disease. And we can sort of determine the infectiousness and answer the question, are children with tuberculosis contagious or not? So what have been our strategies in the United States to try to deal with childhood tuberculosis? Well, it's changed tremendously over the years as the burden has changed, as the population has changed, and as our knowledge, frankly, has grown about what the best strategies are. Now, we never used BCG vaccine. I was very fortunate to inherit the library of a woman named Margaret Smith, who was very prominent in childhood tuberculosis back in the 50s and 60s in particular. And there's a series of letters in there back and forth among the TB experts in the United States debating whether or not we should adopt the use of a BCG vaccine, as much of the rest of the world did. And the decision was made to not do that because people in this country were convinced of the value of the tuberculin skin test. And they knew that giving widespread BCG vaccine would make the value of the skin test go away because so many people, not everybody, but so many people developed positive skin tests from the vaccine. So the strategy for most of the world was, let's see what we can get out of the vaccine. The strategy in the United States was, well, once we find a case, let's try to figure out who else has the infection and the disease, and then treat those people to sort of stop it in its tracks. And both of those strategies have advantages, and both of them have significant flaws. The biggest flaw of what we do in the United States being the need for personnel and the need for timely investigations, because children can develop tuberculosis very quickly. When I first started in TB back in the early 1980s in Houston, when health department budgets were terrible and HIV was just starting, the average amount of time, you're not going to believe this, but the average amount of time between when a child was identified as a contact of a case and when that child was actually evaluated and tested by the health department was more than 6 months. And the incubation period, if you will, for many forms of TB, including the most serious ones like meningitis and miliary TB, is a matter of just a few months. So we were literally having TB cases develop right under our noses because we weren't able to carry out the strategy that we had set for ourselves, namely contact tracing and appropriate evaluation. We saw a slow, steady decline, about 5% per year in the incidence of tuberculosis cases until the mid-1980s, when it, of course, recurred with a vengeance. And there were several reasons for that. Everybody talks about HIV infection, and that was important, but it was more than just HIV infection. The amount of resources for tuberculosis had gone down tremendously as it was perceived as being a dying disease. The amount of research that was going on, the NIH budget for tuberculosis in the 1980s was zero, no money at all, zero. So lack of interest, all kinds of things. But then HIV, of course, refocused the need for better tuberculosis interventions. In kids, we developed the strategy of universal periodic testing. And there were the HEAF test and the patch test and all kinds of things. And then finally, we had the time test or the multi-puncture tests. And then, of course, we decided, no, none of those tests are as accurate as the skin test, even with all its problems. So we're going to just go to TB skin testing. And all these screenings began in the late 1950s after isoniazid became known as an effective treatment for TB infection. So it was worth it to find people with TB infection because we could then do something about it. And pretty much continued into the early 1990s. But then we realized, well, you know, TB really occurs in pockets in the United States. The TB skin test has a lot of false positives, particularly in children. And it can be either due to BCG vaccination or to the presence of non-tuberculous mycobacteria in the environment. So testing all these low-risk kids produces a whole lot of false positive results that we don't have the time, money, or inclination to want to deal with, and we're treating these kids for nothing. So what we need to do is screen for risk factors. And there were a bunch of studies that were done in different environments. They were done in huge HMOs, in public health clinics, and practices. And they pretty much showed that you could, in fact, develop a set of very simple, easy questions, which really mostly boiled down to, were you born in or have you extensively traveled in a high prevalence country? Or has anybody in your family had TB disease or TB infection? And if the answer to those questions was no, then, those questions probably represented about 95% of the attributable risk of tuberculosis infection in children in the United States. And so we developed this screening for risk and testing for risk. So it used to be the screening test was the tuberculin skin test. Now the screening test is a questionnaire, and then the confirmatory test is either the TB skin test or increasingly the IGRIS, which in my opinion are much better tests than the TB skin test. We, of course, for a long time have promoted the heavy use of INH treatment for TB exposure and I put on here LTBI, and let me say right now, the 2021 Red Book from the American Academy of Pediatrics and a freestanding statement from the AAP, we are dropping the word latent. We will no longer be using the word latent when we're describing tuberculosis infection. We've always thought it was a bad word because really infection is not latent, but it's particularly not latent in children, especially those children that have been recently infected. It's also a very confusing word to parents. And I find TB infection and TB disease very simple. TB infection means you have the germ inside your body, but it's not yet causing any mischief, causing you to be sick. And the purpose of the treatment is to kill the germ to prevent you from getting this tuberculosis disease. I mean, what could be simpler than that, frankly? And it also translates into other languages. The word latent doesn't translate well into many other languages. So we just tried to simplify talking about TB infection and TB disease. So when I say TB infection, I'm saying the same thing as our adult colleagues say latent tuberculosis infection. And then finally, the specific recording and reporting of childhood TB cases, which is extraordinarily important internationally, but also in the United States. We consider each case of childhood TB to be a sentinel event from a quality point of view. And it should raise the question, could we have done anything to have prevented this child from getting tuberculosis? Not all cases are preventable because the child may present at the same time as the adult or teenager from whom they acquired the infection, but many cases could have been prevented with better treatment or screening or something of the person who had contagious tuberculosis. So this is the graph we all are familiar with, TB cases in the United States, 0 to 14, and this officially goes to 2016, but I put there are 367 cases in 2019. So the number of actual cases of tuberculosis in the United States among children is actually pretty low. Now, Texas has always had a disproportionately high number of these cases, but those are the numbers that we're seeing. Now, I know we are seeing more and more cases now in adolescents, and I feel strongly that adolescents should be part of childhood tuberculosis, not adult tuberculosis. Adolescents have a lot of issues. It's not just about the pathophysiology of their disease, but it's also about all kinds of things from missing school to mental health needs and so forth that, to be perfectly honest, are just not as well addressed in adult-oriented tuberculosis healthcare programs in general, actually. So the WHO for a long time has done 0 to 14, and they consider 15 and above to be adults. I don't, and I don't think that we should be doing that. Andrea Cruz and I are part of a working group right now for WHO to talk about adolescent TB, and there's strong feeling that these folks should be included within childhood tuberculosis programs, and I certainly agree with that. So why did TB, let me go back, I'm sorry. So as you can see, TB went down in the early 1980s and then came back with a vengeance in the late 80s and early 90s. And this, of course, is when HIV first came as well. But why did it resurge? Well, HIV/AIDS, and it wasn't so much children with HIV/AIDS who developed tuberculosis. It was children who had been exposed to adults who were living with HIV infection who developed tuberculosis and then unfortunately passed it on to the kids. That was the bigger thing. Of course, in places like Africa now, it's actually children living with HIV who also developed TB, but that was a small part of it in the United States. We know about congregate settings, and especially with genotyping of the Mycobacterium tuberculosis organism, we now have some tools to really determine where infection is occurring. And we know about all kinds of different places where TB occurs, these mini clusters, if you will, that represent such a high burden of our disease. Immigration is extraordinarily important. And prior to 2009, children got no screening, in essence, for TB. And even now, screening is problematic. Some years ago, I went with a CDC contingent to Vietnam to review their tuberculosis control program. And they had said proudly that they had never had a single child sent to the United States with tuberculosis disease. Well, I reviewed a bunch of their chest x-rays, and oh my God, they had some incredibly abnormal chest x-rays in there of kids that they had sent untreated to the United States. They said they had done sputums on those kids and they were negative. And therefore, that's why they said they didn't have tuberculosis disease, which of course is a fallacious concept. So I think that the screening for children for TB, even now, is probably not as thorough and maybe accurate as it is for the adult populations as well. So getting to those kids, and the problem is they come to the United States, they often don't have medical homes, the families don't have much in the way of resources. And so getting our hands on those kids, if you will, is difficult. But finally, poor tuberculosis control, even more than adults, children rely absolutely on a well-functioning tuberculosis control system. In Houston, at least half of our cases are picked up through active case finding. And I'm going to show you a study about that in just a couple of minutes. And the kids that are picked up that way are much less sick, have much less extensive disease, and are much easier to treat than the kids who present as ill, sick children who often have extensive disease, more likely to have extrapulmonary disease, and so forth. So keeping TB control budgets, there have actually been studies showing that for children, the #1 public health measure is immunizations. That's not surprising. But on a dollar basis, the #2 is actually tuberculosis control and how important it is that we maintain those resources. So this is a slide most people who do TB lectures have in one form or another, the so-called transitions in TB. And you can think of each box representing an individual person or a group of people. And what we who in TB control do is try to prevent the person or the group from progressing from one box to the next box. So first of all, you have to be susceptible. We know not everybody is susceptible because not everybody who gets exposed gets infected, and not everybody who gets infected develops disease. There's probably some genetic things that are involved. There may be some environmental things as well. So anyway, you have to be susceptible, and then you have to be exposed. You have to share the air with somebody who actually is capable of transmitting Mycobacterium tuberculosis. And if we do that part of it well, we can actually prevent infection. And this is what Kim talked about, Kim Smith, about the whole idea of how we handle exposed children to try to prevent them, maybe even from getting infection, but certainly from developing disease. And then you have the organism established in your body and you become infected. And then we want to try to prevent disease. So notice that I have two separate boxes, diseased and sick. And diseased are kids that are picked up mostly through active case finding, through contact tracing. And these are kids that are often asymptomatic or have not even enough symptoms that they've sought medical care. But when we do their chest x-ray, it's abnormal. And in fact, it can be distinctly abnormal, along with having a positive test of TB infection, either a skin test or an IGRA. And they have usually milder disease, much more easy to treat, much more easy to cure, as opposed to the kids that are found through passive case finding. They're the kids who are sick, who present because they're ill. And ironically, they are much more difficult to diagnose. When you know a child has recently been exposed to a case of TB, that, to say it this way, raises the positive predictive value of everything else. The TB skin test, the IGRA, the chest x-ray, the positive predictive value of all those things goes way up when you know that Johnny has recently been around Uncle Eddie, who was just diagnosed with pulmonary TB. But when the child comes in sick and you don't know that they've recently been exposed to TB, well, there's lots of other things that can cause that illness, other infections, other conditions. And so it's actually more difficult to diagnose, especially since we have a hard time doing it microbiologically. So it's hard to actually confirm it from the child. So much easier when you know that the child has recently been exposed to a case. And then hopefully we go on and appropriately diagnose. And that also includes registering, recording, and reporting. Again, important internationally in particular. And then we treat them and hopefully cure them as well. So think about it. Some of these people make these concepts so complicated, but they're actually simple. There's only two ways a child in a community in the United States can come to have TB infection. Either they acquired it within the community, and that's what contact tracing is for, or they acquired it elsewhere and were brought into the community, and that's screening for risk factors. I mean, that's it. If we did those two things perfectly, there would be no other TB infection, and we'd prevent the huge vast majority of TB disease. And it's only our unwillingness and ability, whatever, to do those things well that leads to children having to have TB disease. I always like to pay tribute to Catherine Sue. Catherine was my mentor. Wonderful, wonderful woman who came to the United States from China and started working in tuberculosis. And she actually came out of retirement when I started to do TB in the early 1980s. And she taught me about TB, but what she really taught me was how to run a clinic and how to do public health. I had a great personal honor many, many years later. The American Thoracic Society has an award, and I call it the award for people who should be famous but aren't. And I was able to nominate Catherine Sue for that award, and she in fact won because of the incredible body of work that she did. She was one of the very first people actually to suggest that isoniazid should be used to treat children with tuberculosis infection to prevent them from developing tuberculosis disease. And she did this incredible study in Houston where she's followed 3,000 kids for more than 30 years and showed that not only did isoniazid work, but the effect was durable. It lasted for a really long time. Catherine also was the first medical advisor for TB control in Houston, Texas, and really helped to develop the whole concept of contact tracing. And this is one of the papers that she wrote a long time ago, 1963, Contact Investigation, a Practical Approach to TB. And so she talked about how this is really a family-centered disease. And many of you who know about WHO know that there was a big splash a few years ago about making TB a patient-centered disease. It really had been more of a sort of TB control-centered disease, and now make it a patient-centered disease. But I've said for a long time, that's not enough. It's a family-centered disease. And if we really are going to get to the kids in particular, we have to think of it as a family being the unit in many societies where TB tends to cluster. And this is one of her very famous studies that showed the basis for how TB control programs in the United States could and should effectively do contact tracing, starting at least with the family. And that was the best way to find children with early TB disease or children with TB infection that were candidates for treatment to prevent them from developing disease. And you can see the very nice graphics here that came from that particular study. So what does family-centered contact tracing do exactly? Well, it identifies recently exposed and infected children. So it's the opportunity to prevent establishment of infection. That's what Kim talked about with exposure. To prevent infection once it happens from progressing to disease. To detect early disease, which is much easier to treat and cure, and then to prevent further dissemination of the infection by people breaking down, particularly teenagers in pediatrics, and developing themselves contagious forms of TB that can then be spread to other people outside the family. And also to prevent hospitalization as well. So it's sort of also economically efficient to do this. It's also the only opportunity to determine drug susceptibility for at least 50 to 70% of children with TB disease, because they're the ones that we cannot establish microbiologically their diagnosis. And it's the only opportunity to determine drug susceptibility for 100% of the children with TB infection, because by definition, we don't get the organism from those kids. So, we know 10% of TB isolates in the United States are isoniazid resistant. The only way we're ever going to know that we need to treat those kids with something other than isoniazid, which frankly we're doing mostly now anyway, but having said that, would be to link those kids to the case that they actually got tuberculosis from. This is a huge problem globally, that children are not being linked to adults who have tuberculosis disease. And we know that at least 500,000 to 600,000 people a year are developing rifampin resistant and or MDR resistant tuberculosis in the world. I'm sorry, not MDR resistant, MDR TB. And those kids, even if they are discovered, are often being treated with ineffective medications. And then now some of them will go on to develop MDR tuberculosis in the future as well. So again, this concept of family-centered contact tracing is so fundamental actually to tuberculosis control. So Saki Ikeda, the first author here, is one of our fellows, and she'll be graduating soon. And she, over the last couple of years, has done a study in Houston called The Epidemiology and Clinical Characteristics of Childhood TB Identified Using Active and Passive Case Finding. Now, this seems like a sort of already accepted concept to us, but I can tell you that internationally it's not. And many high burden areas of the world are just now starting to discover active case finding, contact tracing. And they're not always sure of what they're seeing. And this goes back to Susan John's lecture as well, because the radiographic findings from sort of early tuberculosis are very different from the ones with more established tuberculosis. And if you don't understand what you're seeing, you may not understand exactly the best way to handle and treat it. So as I've been saying, childhood TB can be found via active case finding, discovering a child through contact tracing, or passive case finding, diagnosing a symptomatic child who comes to you for care. As contact tracing is introduced to high burden settings, knowing the characteristics of these two groups is obviously going to be important. So the aim of this study was to compare the characteristics of epidemiological, clinical, microbiologic, and radiographic findings in kids found both actively and passively. And I'm only going to share a few of the findings with you from this. So in terms of demographics, notice that the kids with passive case finding are much older. And I think one of the reasons for that is there's a lot of adolescents in there. And so they're older, whereas the kids that are found through active case finding are more often the younger kids who are living in the household, especially with parents who have tuberculosis, getting infected, and then they're going on to develop disease. If we drop down to the bottom, notice also that more of the active case finding is US born. That makes sense because we're identifying most of those cases in the US, and most of those kids are born in the US. Passive case finding, a little bit more, as kids that were born in high burden countries and then immigrated to the United States and then developed their tuberculosis disease after coming to us. And again, source case now, and this is important, we knew the source case for 82% of active case finding. The reason it's not 100% is some of these kids were found through screening programs of various kinds. They had risk factors, but their source case may have actually been in the country that they came from. So we don't actually know who the source case was because it's in a different locale. Whereas passive case finding, only a quarter of the time were we able to find their source case at the time of diagnosis. Whereas, and notice down below, source case found after the patient, in only 12 instances did we actually know the source case at the time the child presented, Most of the time, the source case was found as a result of associate investigation or reverse contact tracing. That is, we went backwards from the child to find out who they actually got it from. Clinical manifestations, all of these things were much more common in the kids with passive case finding. And I have to admit that radiography is what drove more than symptoms, the definition of TB disease in those found actively as opposed to those found passively. But notice over half the kids with active case finding disease were asymptomatic, and some of those kids had pretty remarkably abnormal chest x-rays. These were not always just a little bit of hyaluradenopathy. Some of these kids had quite a bit of radiographic pneumonia and other manifestations as well. But then notice that virtually all of the kids with active case finding down at the bottom had only intrathoracic disease, whereas almost half the kids with passive case finding also had extrathoracic disease as well. So some really fundamental differences between these two ways of finding TB cases. And Saki's conclusions were that children diagnosed actively were younger and more likely to be US born. Almost all the severe disease and most of the extrathoracic cases were seen only in the passively diagnosed group, Early diagnosis in the active group probably prevented progression to some of these more serious forms of tuberculosis, including miliary disease and TB meningitis as well. The availability of source case culture and drug susceptibility results for actively found patients allowed for more tailored therapy. And let me also mention there's a new study, and I'll mention this again in my next talk, called the SHINE study done in South Africa. I would have loved to have done this study, but we don't see enough disease here to do it. But they actually looked at a 4-month regimen of treating TB for children with what they called minimal or less severe disease. And these are precisely the kids that we pick up in active case finding. So pretty soon we're going to be treating these kids differently. And I think a lot of these kids are going to be getting 4-month and maybe even shorter regimens for TB disease that are found actively, as opposed to the sick kids with extensive disease that we're probably still going to be stuck treating for longer periods of time. So obviously we all need to be aware of these epidemiologic, clinical, and radiographic differences. And I hope these are concepts that really start making their way around the world as well as programs get more resources to do more of this. So I mentioned associate investigation, or so-called reverse contact tracing. And it's the identification and evaluation of the close contacts of children and adolescents who have TB infection or disease. It's sort of a form of targeted testing, if you think about it. And you find the index case, and then you find the source case. The index case in this case is the infected child. The source case is who they got the infection from. The yield of finding cases is low, but the yield of finding other people with infection who are candidates for treatment is actually very, very high. But it's only effective if the child who was discovered first was treated because they had a risk factor. In other words, we don't want to be finding false positive results. Now that we're using IGRAs instead of skin testing, that's helpful because the incidence of false positive results is certainly going down. So these are 5 different studies: San Francisco, 2 from New York, 1 from San Diego and Fort Worth, where they did associate investigations, large number of patients in most of these studies. And you can see that the percentage who were positive on TB skin testing, and these were the index case were children less than 5 with TB infection, 40%, 32, 30, 41, 35. I mean, a third to 40% of these folks that lived with these kids were also positive and were candidates for treatment for tuberculosis infection. The CDC is really making a push now to try to find those millions of people in the United States with TB infection so that they don't go on to develop TB disease. And this is one of the most effective ways to do that. Again, this is family-centered care, but in this case, we're finding the infected child first and then working backwards to get entry to the family so we can intervene. Notice that the number of actual TB cases is really low. And one of the reasons for this is that the major risk factor for these children to get tested in the first place was birth in a foreign country. And so in probably most of these cases, the person they acquired the infection from wasn't in the United States, but was in the country that the children came from. So it wasn't a very effective way of case finding, but it was an extremely effective way of finding infected individuals who then were candidates for treatment of tuberculosis infection. And to remind you about the rates now of TB in the foreign-born, and over 2/3 of our TB now is in foreign-born, and that's true in children as well as adults. And I'm sorry, this is a very messy slide, and it's just to remind me to show you there actually are data. People often ask me, well, how do I know what the rate of TB is in the country that the child came from? And there actually is some data about this, both from the countries, but then these are also the rates of incidence of tuberculosis in immigrants and refugees after arrival in high income countries. And so you can see here, if they've been in the country for less than a year, 1 to 5 years, and greater than 5 years, and the various countries, just to give you a rougher idea, and to show you that there are actually some data where you can relate back to at least some specific countries. And most of these, of course, are the high burden countries from around the world. So what's the effect of immigration on childhood TB? Well, Mark Lobato and Phil Hopewell did a paper a long time ago where they showed in California that children living in a household that had a visitor from a high prevalence country were 2.5 times more likely to have TB infection. And remember, for people to visit legally to the United States, get a visitor's visa, there's no TB testing at all. So we have people come to the United States all the time with TB disease. One of the incidents I remember, kind of tragic, we had a Vietnamese child in Houston with horrible tuberculous meningitis and a very bad outcome. And it turned out that he had a relative out in Seattle, Washington, who had died, and many people attended the funeral, including people who had come over from Vietnam. And it turned out one of those people, unbeknownst to anybody, had pulmonary tuberculosis and infected a bunch of people who attended that funeral, including this particular child who unfortunately presented with tuberculous meningitis. So this is still an issue with visitation. It's a really hard issue to deal with. It's one reason why we're not going to eliminate TB if we don't help all the other countries eliminate TB also. And people from the CDC have done various studies. Winston and Menzies published this one in 2012. There's been some more data since then, but they showed that 31% of the kids, about a third of the kids diagnosed with TB in the US were foreign-born, as opposed to 61%. So it's a smaller percentage than it is for older folks. Why? Because the vast majority of young children who develop TB disease do so rapidly after getting infected. And so they're kids that were born in the United States, but had been exposed to folks who came from other countries and then developed their tuberculosis disease after coming to the United States. Makes perfect sense, actually. Among the US-born children with TB, about 2/3 had some kind of foreign connection, including a foreign-born parent, but only 25% of the US-born kids with TB did not have any kind of international connection at all. Foreign-born children in the US are not treated for TB infection prior to immigration. They're less likely to have health insurance, less likely to have a medical home, and more likely to not be in school. So that makes finding these kids and then getting them tested and treating much, much, much more challenging. Now, I want to say on this too, I have had people who look at this and say, see, we should be screening all the kids for TB infection who have foreign-born parents. And my answer to that is, whoa, not so fast. Because the number of children in the United States with foreign-born parents is huge, tens of millions. And the truth is, most of them are not at high risk for TB infection. So if we add that to our list of screening questions, we'll be making a huge increase in the denominator, that is the number of children that we're targeting for testing, but a small increase in the numerator in the number of kids who will actually test positive. So while these statistics are true for TB disease, they're not necessarily relevant for trying to find children with TB infection and appropriately diagnose and treat them. We can talk more about that during questions if you want to, because that's kind of a complicated concept, I know. Andrea Cruz and I did a study on safety, adherence, and efficacy of twice-weekly therapy. And it's incredibly effective, actually, and it's effective for treating tuberculosis infection as well with isoniazid. Now, our problem is we don't have very much data for rifampin. And in our clinic, we don't tend to use rifampin twice weekly. We do use INH twice weekly when we use it, but we don't use rifampin twice weekly. We use it daily. Of course, our preferred regimen anyway is 12 weekly doses of isoniazid and rifapentine. And now that that's kind of back available to us, we're really, really happy indeed. Adherence for treatment of TB infection, though, is directly related to how many doses you have to take and over what period of time. And again, this is just to emphasize, adherence isn't all or none. And so we have 3 different ways of administering medication. We completely self-administered, where we're lucky if we get 50% adherence, particularly with 9 months of INH. With 4 months of rifampin or 3 months of INH and rifampin, we do better. The other extreme is completely directly observed therapy, either with in-person or video DOT. I love video DOT. And there we get, with 3-HP, our adherence rate is like 95%. But then we do something in the middle, which we call ESAT, where the health department supplies the medications and checks in with the family once a week as sort of a constant reminder. And that's in the middle, where that's about 70 to 75% adherence with our regimen. So it's not just an all or none proposition. There's not just one right answer in terms of treating tuberculosis infection in kids. Are kids ever contagious? I love this slide. Unfortunately, it's not really relevant to TB because nothing you see on this slide is actually the infectious particle, which is the microscopic droplet nucleus. But the question is, are young children with TB ever contagious? Well, if you think about it, it's difficult to answer in the community. If Johnny got TB from Uncle Eddie, well, most of the people that are around Johnny are also the people that are around Uncle Eddie. So it's really difficult to tell, well, did they get the infection from Johnny or did they get the infection from Uncle Eddie? Really hard to tell. So the original studies were done back in the early 1900s in European orphanages. And what they found is if there was a kid in the orphanage who got TB, none of the other kids got TB. But if there was a worker in the orphanage who got TB, lots of the kids would develop tuberculosis. And that was sort of the first inkling that maybe children with tuberculosis aren't all that contagious. Then people looked at schools, and when there have been school outbreaks, they're almost always caused either by adults in the school or adolescents with adult forms of TB, cavitary TB producing SFS, smear positive sputum, et cetera. There have only been 2 really school outbreaks associated with 9-year-old kids, and both of those kids had all the type of disease that adults did. They were unusual. They had cavitary disease, there was AFB sputum positive, and they just happened to be 9 years old. And then children's hospitals, I know at my hospital, Texas Children's, we didn't even have negative pressure isolation rooms for a long time. So we did a couple of studies, and this is a study that Dr. Cruz, again, was the first author. And we looked at all the kids that were admitted to the hospital with possible tuberculosis. And we had no negative pressure rooms. So these were all just regular old hospital rooms. And I have to admit, we were pretty lax really about, compared to what we should have been about some of our precautions as well. We did have 2 negative pressure rooms in the ICU. And the only kids that we put in there were kids that had obvious potentially infectious forms of TB, like cavities, coughing up sputum. But it really cost us to put kids in isolation because it was an intensive care unit as well. And then we did chest x-rays as soon as possible at the hospital's expense on the caregivers of the child. The idea being, if Johnny's in the hospital with TB, he probably got it fairly recently, and it's probably an adult in his environment. So maybe the very person who brought him to the hospital. And we need to make sure we know that because we don't want that person walking around the hospital and infecting other people. So the parents and sometimes one other caregiver, like a grandparent, we would do the chest x-rays on them. And we simply did not allow other visitors to visit while the child was in the hospital. So during the 7-year period, there were 153 kids who were suspected by the treating physician of possibly having TB. And ultimately 59 of them, we really decided really did in fact have tuberculosis, either clinically or microbiologically. 5 children had miliary TB, 1 had cavitary TB, 1 adolescent had extensive apical disease. And of those 7 patients, 5 of them were AFB sputum smear positive. But what we found is the diagnosis, and at the bottom, the diagnosis in the 94 kids that turned out not to have TB, a whole smorgasbord of different things. So there were 254 chest radiographs that were obtained, a median of 1.7 per child. This includes the kids who ultimately didn't have TB. But of the 59 children diagnosed with TB, 17% of the families and 9 out of 110 caregivers actually were confirmed as having previously undiagnosed pulmonary TB. That's a TB case rate of 9,100 per 100,000. That's the highest TB case rate in the world. It dwarfs the TB case rate for any other screening program that's done on any other population of people anywhere in the world. Of those 10 people, the 10 caregivers with TB, 4 were fathers, 3 were mothers, 2 were grandmothers, and 1 was an aunt. And the overall rate of abnormal caregiver chest radiographs was 8% of families and 12 or 15%, I'm sorry, 5% of the caregivers. And that was for all the children suspected of having TB, not the ones who ended up having confirmed TB. So that means the case rate was still 500 per 100,000 overall in all these caregivers. Interestingly, at the same time, we monitored the skin test results of all the caregivers in the hospital employees and the doctors, and not a single one of them converted their tuberculosis skin test. So by doing this, we were able to identify the contagious adults and keep them. What we would do is pretty much get them out of the hospital and walk them over to the tuberculosis clinic at Bentham Hospital so they could immediately go into appropriate diagnosis and treatment. Occasionally, we couldn't do that, and the parent was also in a negative pressure room, but that was actually pretty rare, if you will. So this is a really effective screening program. So what are the lessons we can learn about TB in children from a low burden environment? Well, prevention of TB in children requires a system. It's a system with central coordination and community activity. And if that system doesn't function well, and this is what we're also worried about with COVID, is that these systems have broken down to some extent. Internationally, they've broken down terribly. But even in the United States, where so many workers were borrowed from TB. And by the way, that's another characteristic of TB. People who work in TB have tremendous skills. Think about it, including contact tracing, which is what was needed early on in the COVID epidemic. So tons of people were borrowed from the CDC all the way down to the local health department from TB to help deal with COVID. Our numbers have gone down, and we don't think that they've really gone down. We think we just haven't seen them. And we're really concerned we're going to start to see some sick kids come in because we didn't have the opportunity to prevent their disease. Linking a child to a source case improves the accuracy of diagnosis and the effectiveness of treatment as well. Analysis of childhood TB is a window into the effectiveness of TB control, so-called, children are the yellow canaries. And when I showed you the graph about TB going up in the early 1980s, it actually started going up in children earlier, and it actually went up twice as high in children as it did in adults. And again, they're the yellow canaries. They're the ones that tell you what is going on in the community in terms of TB control, because most of the ones you find out about have recent infection, not infection that occurred 30 years ago. Most childhood TB can be prevented with very little cost, but it requires organization and emphasis. Migrating children at high risk, and migrating children are at high risk, and have difficulty accessing central and community services. And then young kids with TB are rarely contagious to others, which is a good thing, but it also means that internationally they've been neglected because they don't transmit the disease. So here's why childhood TB has been neglected internationally. Inadequate data, difficulty confirming the diagnosis, they're not contagious, so they're a public health dead end. Perception from TB policymakers that treating adults is enough. I was actually told that early in my career. Oh, the way to get rid of childhood TB is to get rid of adult TB. Well, that's true, but how many millions of kids are going to die while you're on the way to doing that? But it was really what was said with a straight face, no longer acceptable. Government programs that failed to address children. 15 years ago, most government TB control programs didn't even have a chapter on childhood TB. And by the way, most of them now do not have a chapter on adolescent tuberculosis. And that's something that we're working on. The lack of family-centered contact tracing, you know how important I think that is. Perceived lack of scientific study and scrutiny, which just isn't true. There's just thousands, tens of thousands of papers written in the last 20 years about childhood tuberculosis. Misplaced faith in the BCG vaccines. They do prevent a proportion of childhood TB and adult TB, but not enough to actually control the disease. We need a better vaccine. Lack of industry support because the marketplace in the high income countries is not very big. And finally, inadequate advocacy by pediatricians. We have to look at ourselves in the mirror, and especially internationally, and say, what have we really done to try to do something about this? I do a lot of advocacy. I enjoy it. I really like this slide. And this is the difference between how you sort of talk as an advocate in blue versus how you talk as an expert to your colleagues in green. You know, in the green, we build the case to a conclusion. Data, 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 data. Boom, this is the answer. Our jargon actually adds clarity and precision when we're talking with colleagues. We try to cover every base, you know, every variable, explain in great detail. Hasty preparation can be discredited, and we try to be objective and unbiased. Those are all really good and important things. But unfortunately, they don't tend to drive public policy. If you're trying to change public policy, you start out by stating your conclusions and then show a little bit of data to support them. Jargon confuses people. Plain, simple, clear language. TB infection, TB disease. You have to limit the messages. What are the two things you want the person or people you're talking to walk away from in your talk? Keep the messages simple. Quick preparation is often needed because during a legislative session, we got to be able to react, you know, really rapidly to what's going on. And then a compelling factual argument. And then what's not on this slide is a really good story. So if you have a couple of facts and then you can tell a good story about a particular person or particular situation, that's the kind of thing that really tends to capture policymakers and lawmakers more than the scientific method that we tend to use when talking to each other. And I'm going to end my talk there and be more than happy to entertain questions for a couple minutes. Unless I put Delphina to sleep. Is anybody out there? I'm not hearing anything.
Hi, Dr. Stark. So yeah, we have a few questions in the Q&A. Let's see. So the first one, how would you respond to people who say that the positives found in contact investigations are due to past risk versus transmission, regardless of the evidence from smears and the presence of cavities, seemingly to avoid the need to expand contact investigation? Seems like we are finding more and more pediatric cases and TB infection during our contact investigations. Do you count all positives as evidence of transmission if there is no evidence of previous tests in contacts, assuming index patient is thought to have some level of infectiousness?
Well, the short answer is, in a low burden setting like the United States, yes, we assume that anybody who's infected has been recently infected. And the younger the person, the more likely that is to be true, of course, because they have less life experience. Is it going to be correct all the time? No. So let me give you an example where it's not perfect. Susie Wooten, who's now at the University of, one of Kim's colleagues at the University of Texas, did a study looking at the genotypes of Mycobacterium tuberculosis in pairs between a child and the person that we thought the child got tuberculosis from, and found that I think it was somewhere in the neighborhood of close to 100 pairs. There were 2 pairs that were discordant. That is, the child clearly had a different organism from the adult that it was thought was the person who transmitted it to them. Now, in all these cases, all these patients had fully drug susceptible TB, so it didn't make any difference in terms of the management of the child. But you can imagine where there's, you know, drug resistant and multi-drug resistant TB, it could make a huge difference if you've identified the correct one. So of course, especially in adults, there may be previous infection, and there's really no way to get around that. There's no way to tell when a person was infected. So for children and adolescents, yes, if there's the presumption of recent infection, unless we have independent data showing that the infection occurred at a previous time. I hope that answers the question that was being asked. Delphina, I'm hearing silence again. Am I missing something?
Sorry, I was muted.
Okay, okay.
23-month-old contact to active PTB patient in household, TST negative, chest x-ray with periobronchial cuffing consistent to bronchiolitis, a viral etiology. Do you start window prophylaxis or wait 2 to 3 weeks and repeat chest x-ray?
Well, so I would definitely start window prophylaxis in that particular child. So The hardest time for us to do all this is in the winter before we were masking, when children get other respiratory viral infections all the time. And, parabronchial cuffing is not TB. Perihilar, I mean, it's not, I feel pretty comfortable, especially if they have symptoms that are consistent with a viral illness. It is true that the one mistake you don't want to make in TB is undertreating TB disease, because that's what, as we'll see in the next talk, that's what leads to development of drug resistance. But it's still a sort of a question of degree. If I have any doubt at all about the child's chest X-ray representing TB, then I'll be much more cautious. But I'll say one more thing. In my experience, which is pretty considerable now, it is very unusual to have a child who's a recent contact of a case who has a negative test of infection, but an abnormal chest X-ray. I'm not going to say that that never happens, but it's actually pretty uncommon that abnormal chest X-ray is due to tuberculosis. So this is why it's also helpful to have somebody who's really comfortable looking at pediatric chest X-rays. The other thing I found, when we see kids at Texas Children's Hospital, we have pediatric radiologists who are very comfortable. But we also see kids who have their X-rays done out in the community and they're interpreted by radiologists who, quite frankly, are not as comfortable with childhood TB. And when they see in the subject line the reason for the chest X-ray is positive skin test or exposure to TB or something, they tend to overread those chest X-rays a little bit. And we see an awful lot of readings like parabronchial this, cuffing that, and so forth. And we look at the X-ray and say, gosh, that X-ray sure looks normal to us. So again, knowing your radiologist and who's seeing the X-rays is also, I think, important.
Another question, Dr. Stark, if you recommend abandoning use of latent, would you also change the acronym from LTBI to TBI in your slides and training efforts? Should we be doing this proactively in our patient education?
Yeah, I didn't do it today. Somebody pointed out to me TBI also means traumatic brain injury. I mean, we have all kinds of things in medicine that the same 2 or 3 or 4 letters actually mean different things. So I don't get all hung up about that. But the answer to the question is yes, I am gradually, to get people used to it, going to get rid of the L. And I mean it in the Red Book. There is no LTBI. It's TBI. It's TB infection. And pediatricians all got together. It was actually unanimous of the Red Book committee that was a change that should be made. So yeah, I'll get rid of the L's in future lectures.
All right, another question. Do you think the division of child to adult TB is related to puberty, as we have a 12-year-old who has infected her classmates? If so, should we look to girls as infectious earlier as they enter puberty earlier, and with decreasing age of puberty, will this change?
That's actually a great question. Adolescent TB has been horribly neglected. And historically, adolescent girls seem to have a little bit higher rate of developing tuberculosis disease. What really happens is that TB disease is high in kids 0 to 1 year of age, and then 1 to 2, and then down here about 5 to 10, and then it starts to go back up again once you and get in that region. So yeah, we definitely are seeing that. I am less interested in age and more interested in the characteristic of the disease. If a 9-year-old comes in with a cavity producing AFP positive sputum, well, that person's I'm going to consider contagious and treat accordingly. And similarly, if a 16-year-old comes in with hyaluronopathy but not much else, I'm not going to consider that person contagious. So it's really the nature of the disease more than the age, which should sort of drive things. If that person wouldn't mind typing, I'd love to know what kind of disease that 12-year-old had.
I'm sorry, another question. How do you encourage, advocate LTBI screening and treatment in community clinics serving at-risk population, foreign-born frequent travelers to high TB countries, if the concentration of testing risk assessment is done only in adults during wellness visit?
Unless I'm missing something, the obvious answer is it shouldn't be done only in adults, it should be done in kids. And we have questionnaires to screen out kids that are considered at risk. As I said, it really boils down to 4 questions, which you can turn into 2 questions if you want to. Were you born and extensively traveled to a high prevalence country, or anybody in the family have TB infection or TB disease? And that really will pick up the vast majority of the kids. So if the person who typed the question is implying children aren't being screened, then the answer is they should be screened. And if I'm missing something in there, I apologize.
She added to her comment, she had positive sputum cavity TB.
Well, I'm sorry, now I'm not understanding the question.
Yeah, can you?
That was for the patient that was 12 who transmitted the disease.
She was, yeah, exactly. So that person had characteristics of adult type tuberculosis. So yes, you always have to consider a person like that to be potentially contagious. And indeed, this person was. It's just that it's not as common in kids that age, but it definitely can occur. I saw a question there, Delphina, about why are children less contagious than adults? And let me go ahead and answer that if that's okay.
Sure.
So it's an interesting question. It kind of goes all the way down the cascade. Children have less extensive disease. They don't have cavities, so the actual burden of organisms in their lungs is much lower. And remember, what sputum is when the contents of the cavity actually communicate with one of the bronchial trees. And so kids just flat out don't do that. So they don't tend to produce sputum. And because they have a lower burden of organisms, even when they do produce sputum, the concentration of the mycobacteria tend to be much smaller. And then finally, children have a much lower tussive cough force. So they are not as able to generate the small droplet nuclei that adults can that are actually the contagious particles. So all the way down that sort of cascade, children are less likely than adults. And that's physiologically the reason why children with TB are usually not, young children usually not contagious.
All right, there's two more questions. The first one, is it safe to say that a US-born child of first-generation foreign-born parents or even US-born children with significant contact with foreign-born relatives has similar risk as a foreign-born child?
No, they don't have similar risk. Well, first of all, for the individual, it's impossible to say. But if we assume that the foreign-born child had exposure to a broader range of adults in the country of origin, then their risk would be higher than just what the other scenario with family members and so forth. And again, even among foreign-born people in the United States, of course, the incidence, the risk of TB is much lower than it is in the countries that they came from. So no, the foreign-born child probably has a higher risk. Now, that's not to say there may not be pockets in the United States where they are of equal risk because there are enough people in that pocket to sustain transmission. But in general, you would expect the foreign-born child. Plus, those foreign-born kids often had more time in the country of origin, so they had more opportunity to get infected. And again, I hope I'm addressing the question.
The next question, if a child has been treated for TB infection but gets re-exposed more than once, but chest x-ray remains normal, how do you know if you need to retreat or not?
That is a fantastic question. And I'm going to tell you, I have no idea. There is no data about that, no really meaningful data. I do know that one thing I tell parents is, we have to explain to them that at the end of treatment, their skin test and probably their IGRA will remain positive forever. And I try to explain that as a good thing. And here's how I explain it. I say, look, before your child was exposed to TB, the body's immune system had no idea what it was. So when you did a skin test or got an IGRA, there was no reaction because your body didn't know it. But once you got the infection, not only do they now know what it is, but your memory B cells will remember it forever. And so they'll always test positive. That probably also means if you do get re-exposed, you have the response of your immune system to be much more rapid and therefore much more likely to get rid of the organism quickly. So I do think having had the infection and getting treated probably does act, at least to some degree, like a vaccine. Now, exactly how effective that is, of course, there have been people who have developed tuberculosis twice, but the truth is that's pretty rare, and it's mostly in people whose immune systems have really been knocked down by something. So I guess it's more of a concept right now than I can show you all kinds of data. if you think about it, there's no way to do that study. We don't have the right markers, we don't have the right tools to actually study that question and come up with what is exactly the right answer, besides the fact that you'd have to, have probably tens of thousands of people in the study.
Let's see, there's another question in the chat box. Why are children with TB disease less infectious than adults with TB disease?
I think that's the question I just answered about the sort of cascade of all the things being different in children in terms of the number of organisms and producing sputum and the tussive force and all that. So I think that's what I just answered.
Looks like those were all the questions for now. All right, everybody, welcome back. I will continue with a presentation from Dr. Stark, Diagnosis and Treatment of Pediatric TB.
Delphina, thanks. I just want to make sure you can hear me okay and that my screen sharing is okay.
Perfect, yes.
Okay, well, welcome back, everybody. And thank you for coming back. I'm honored that you wolfed down lunch in a pretty short period of time. So thank you. So now we're going to talk about diagnosis and management of childhood TB. It's an awful lot of material to cover in an hour, and I'm probably going to go a bit fast, and I apologize for that. So I have no conflicts to declare. So we're going to review the methods of diagnosis, including epidemiology, clinical presentation, laboratory, and a little bit on radiology, to review available drugs and regimens for childhood TB and consider the role of some of the newer drugs in diagnostic modalities as well. So I showed this in my last talk, and just to remind you again about transitions in TB, and this time we're going to be concentrating on the fourth and fifth box down, the diseased and the sick, and then the second to last box on the treatment as well. So I think it's important to remember, and you've heard a lot about this, so I'm going to do it quickly, stages of TB, and now we're going to talk about the disease stage, which means you have clinical and or radiographic manifestations. And again, I say it that way because clinical, much more likely with passive case finding, but radiographic only, much more likely with active case finding through contact tracing. Most kids have what's called primary disease, which means it's a complication of the initial infection. But reactivation disease does occur, particularly in teenagers, and they can get the adult style of tuberculosis with cavities and sputum production and apical disease and so on and so forth. So for most kids, the disease concentrates around the center of the lungs, the hilum, and spreading out from there. But teenagers, like adults, can get, like children can get that disease, or like adults can get more of the peripheral disease, if you will, with a relatively quiet central area without the adenopathy. I always like to remind people that the tests of TB infection are negative in at least 10% of cases. And paradoxically, the sicker that you are, the more likely that your test of infection will be negative. Tuberculosis is a very immunosuppressing disease. And the more severe it is, the more it knocks down your humoral immune system and other parts of your immune system, and the more likely you are actually to have a negative skin test and or a negative IGRA. So negative tests of infection never rule out tuberculosis disease. And that's something we really emphasize with our infectious disease colleagues and trainees. This is a really, really important slide. And this is data from the pre-chemotherapy era. We can't really replicate this now, about the natural history of TB infection to disease in children. And you can see the light blue are children that have infection but not disease, and then the darker blue are people with disease, mostly pulmonary, but the red represents kids with life-threatening disease, that is meningitis and miliary TB. And you can see, and this is pre-BCG vaccine, so BCG alters this somewhat. But you can see for kids less than a year of age, if they get infected, they have a 15% chance of developing life-threatening forms of TB and a 50% chance of developing tuberculosis disease. By far the highest risk group, even higher than adults with poorly controlled HIV infection. Between 1 and 2 years of age, the overall rate drops to 25%, still 25%. And the rate of meningeal and miliary TB drops to about 5 to 7%. And then you can see from 2 to 5 years and 5 to 10, a very small percentage of those kids, they get infected, but they don't tend to develop disease. But then when we start getting back into the adolescent years, we go back up to about 15% of the kids will develop tuberculosis disease if they don't get discovered and treated. So the pathogenesis, the organisms are contained in the very tiny microscopic droplet nuclei, which land way out in the periphery of the lung. The infectious dose is probably pretty small. It may not be any more than about 10 organisms. But the chances of even 10 organisms reaching out there in the alveoli is not all that great. That's why TB is not that contagious disease compared to some of our other diseases like measles and COVID, which are way more contagious. The organisms are then ingested by macrophages in the lungs, and they're transported to the regional lymph nodes, either the hilar, mediastinal, or cervical lymph nodes. And from there, there's lymphohematogenous dissemination all throughout the body. So, to answer the question, well, wait a minute, if you can get the infection in any part of your lung, how come adults mostly get it in the apices of their upper lobes? Well, the reason is it's during this lymphohematogenous dissemination that the organisms actually seed the apices of the two lungs. It's not by direct extension necessarily, but it's by going through the blood and the lymphatic system. They tend to land there because those areas of the lung are so rich in blood supply. And then those areas of the lungs have really good oxygenation. And TB germs love oxygen. So that's where they tend to grow. It was originally hoped that BCG vaccine, even if it didn't prevent infection, might prevent this lymphohematogenous dissemination from occurring, which would then limit the amount of adult type tuberculosis, which is the contagious form, and therefore would knock down the rates of TB. Unfortunately, that's not really what the BCG vaccines do. So that's why they haven't been as effective as what was originally hoped. So this is from Gray's Anatomy, and this is the anatomy of the sort of central part of the lungs and the chest. And those green things are the lymph nodes. And as Dr. John showed you and told you, that's where the action is in childhood tuberculosis. And when you get inflammation of those lymph nodes, because there's so many and because they're so packed in with the air tubes or the bronchi, they start to enlarge. And when they enlarge, something else has to get smaller. And what gets smaller is the diameter of the breathing tubes or the bronchioles, and they start to get obstructed. If you get partial obstruction, you can get air in, but you can't get air out, like with asthma. In that case, it's a mucus plug from within the bronchiole. This is inflammation of the lymph node from outside the bronchiole, but in both cases, the bronchiole gets narrowed and air can't get back in, so you get air trapping. So early in childhood TB, you may actually have hyperinflation of a segment or even an entire lobe of the lung. If the inflammation of the lymph nodes continues, then you start to get even more obstruction, and eventually you get complete obstruction of one of the air tubes. So the air is actually absorbed out of that part of the lung, and you get atelectasis or collapse. And most often this occurs in a segment of one of the lobes, or sometimes in an entire lobe, very rarely in an entire lung, but much more often a segment or whatever. And for many years, this was referred to as segmental tuberculosis because it was a segment of the lung that was actually involved with this. I'm going to show you some x-rays, and Dr. John, I can't do what Dr. John does, but I'm going to talk to you as a clinician, sort of when I'm managing kids, what I'm thinking about and how it affects what I do and so forth. So this is a chest x-ray of a child whose mother had pulmonary tuberculosis. And I hope you can see my pointer. That's an artifact. That bright white thing is an artifact, but this is the enlarged lymph node. And so this is a typical child who has a positive test of infection, no symptoms at all, wouldn't have sought health care, but when we do the chest x-ray, has obvious hilar adenopathy, and we call this tuberculosis disease, and we treat accordingly. This is a little different thing, and this is actually atelectasis of the upper lobe, pretty much the entire upper lobe. You can see the horizontal fissure here that's actually being pulled up by the atelectasis. And this is again, because the lymph node is so swollen, so enlarged, it's blocked air from flowing into that upper lobe. And so you get atelectasis. We have a saying in childhood TB, the x-ray is sicker than the patient. And what I mean by that is if this was bacterial pneumonia or even something like respiratory syncytial virus, RSV, this kid would be really sick, would have fever and coughing and acting sick, maybe even some air hunger. But when it's TB, most of the time, these kids have relatively few symptoms, maybe cough, but often not a whole lot else. The timetable of childhood TB is very important. The most severe forms of TB, miliary and meningeal, tend to occur the fastest. that has a real implication for public health. This is why we want you to do very timely contact investigations of adults with tuberculosis, especially if there's little children who are in the household, because they can go from being perfectly well to dying with miliary TB or TB meningitis literally within a matter of just a couple months, even weeks. And that's if they're otherwise normal, healthy children as well. Pulmonary TB, somewhere between 2 and 12 months. Lymph nodes, same thing, pleural effusion. Skeletal and renal are the two forms of childhood TB that have much longer incubation periods. That is the period of time between which you actually breathe in the organism and you actually develop the disease. But the truth is, for most of the first 4 forms, the majority of disease occurs within 6 to 9 months after the infection has first occurred. So timeliness is everything for kids. So how do we diagnose TB disease? Well, even in the United States, because we have such a difficult time with microbiologic confirmation, the gold standard is often the triad of a positive test of infection, an abnormal chest x-ray and or physical exam for extrapulmonary TB, and then history of a recent contact to an infectious adult case. And again, as I said, that increases the positive predictive value of everything else that we do. It means that given the same chest x-ray findings, if we know the child has been exposed to tuberculosis recently, it makes it way more likely that that child has tuberculosis than another child with an identical looking chest x-ray who does not have contact with someone who's had tuberculosis. That's really, really important. Hard concept for people to understand sometimes, but that's why we put so much stock in the history of contact. And in fact, of all the tools for diagnosing TB disease in children, history of recent contact and chest radiograph are the 2 most important things, by far the 2 most important things. So if we contrast pulmonary TB in adults and children, in adults, it tends to occur in the apices of the upper lobes, but in children, it can occur in any lobe, any part, and about 10 to 15% of children will have disease in multiple lobes. Adults tend to have cough, fever, and night sweats. Kids will have dry cough. They have kind of plus minus fever, and night sweats are completely non-specific in children. Children get night sweats for all kinds of different reasons. They don't really impress me much, to be honest. Sputum production is common in adults and rare in children. Weight loss is common in adults and less common in children. It can occur, certainly, but it's less common, partly because things progress so rapidly in children. Adults tend to have long duration of symptoms, children shorter durations. Adults have cavities, infiltrates, and nodules, whereas children have lymph nodes and atelectasis. Completely different mechanism of causing disease in children compared to adults. The x-ray looks like the patient in adults, and in children, the x-ray looks sicker than the patient. Good rule of thumb. And then adults present by symptoms, and children, we hope, at least half of them actually present by contact investigation. So this is a Gone complex, and I am going to show you some x-rays only because, again, I have to, because you can't talk about diagnosis of TB in children without x-rays, but to give you a little bit of flavor of sort of how we use them. So this is a classic Gone complex with the parenchymal lesion in the lung and then the lymph node here. And the reason we can see these is both of these are calcified. It takes at least several months and maybe as long as 6 months for calcification to occur. So this implies that this infection didn't, just occur recently, but may have occurred in the past. We treat this as TB infection. Normally, this chest x-ray is normal. We can't see it because it isn't calcified, but the same kind of process is going on in a recently infected child who has a, quote, normal chest x-ray. We just can't see it because it hasn't been calcified. And then we start to see lesions that look like this, where what we're seeing is enlarged lymph nodes. Now, you can't tell on an x-ray that they're lymph nodes because lymph nodes have the same density as the heart and atelectatic tissue and even infiltrate. So you don't actually see a discrete node here, but the node is enlarging and you can see you're starting to see some atelectasis in the middle lobe there. And then this is what happens. This is a child, again, whose mother had pulmonary TB. And this child has pretty massive adenopathy. And then you can see the horizontal fissure that's being pulled down because this process is mostly atelectasis and some infiltrate as well, but atelectasis. And this is the classic chest x-ray of childhood tuberculosis. Lymphadenopathy, obstruction, atelectasis, and maybe some infiltrate as well. This child also had a little bit of cough, but hadn't sought any medical care and was picked up through contact tracing with the mother with tuberculosis. I've shown you this x-ray already. And then sometimes we see this. This is actually a bowing of the horizontal fissure. And this is a kid who has two things going on, has TB, but has a secondary bacterial pneumonia. And these are the kids that often come in sick. They have high fever, cough. They look like they've got community-acquired pneumonia. They do have community-acquired pneumonia because they have material and organisms that get through this obstruction, but then can't get cleared, can't get out again. So they go on to develop. And these kids will respond to regular antibiotics. And it's easy to get fooled and say, oh, well, this kid had community-acquired pneumonia because he got better. Yes, but also had underlying tuberculosis. So that's why it's always important to take a history for tuberculosis risk factors in any kind of pulmonary pathology, including this. This is an interesting kid who came in and had respiratory distress, air hunger, and had this x-ray. And this is one we used to always show the medical students, say, which is the abnormal side? And most of the time they don't like whiteness on a chest x-ray, but really it's the right side that's abnormal. There's emphysema of this lung, particularly the lower lobe, that's really hyperinflated. And this kid was breathing really hard at this x-ray. We didn't know why. And about 15 minutes later, the child all of a sudden started breathing normally. And we repeated the x-ray and it looked like this. We caught this child with complete collapse of the lower lobe of the lung. And what was happening was there was an enlarged lymph node, and here was the hyperinflation, getting air in and not being able to get it out. But we literally caught the kid in the process of clamping down that entire bronchus, so it had complete obstruction and therefore complete collapse of the lower lobe. This was due to tuberculosis, and we later found out this child's father had undiagnosed pulmonary tuberculosis, and that was the source of the tuberculosis in this particular child. So there are complications of childhood tuberculosis. We, of course, can see progressive local disease, and that can also cause cavitation, but that's a different form of cavitation than adults get. It tends to be sort of these thick-walled cavities, almost look more like lung abscesses. We occasionally will see obstructive emphysema. You can actually get pericardial or esophageal perforation. The subcarinal lymph nodes are sitting right next to the pericardium and near the esophagus. I've actually seen 3 children with tracheoesophageal fistulas that were not congenital, but they were actually caused by tuberculosis from the lymph nodes eroding and causing a connection between the trachea and between the esophagus. Sudden death in children with TB is actually extraordinarily rare, really, really rare. And it can be from asphyxia or it can be from massive bleeding, mostly in a teenager, but it's really, really, thankfully, uncommon. We do see bronchiectasis, however, in poorly treated and poorly controlled. It's usually cylindrical as opposed to saccular bronchiectasis, but you can see either form in the lungs. And then we talked a little bit about calcification. This is an interesting child who came in. This is obstructive emphysema, and this is an infant who came in, and again, it was the left chest in this case that was so obstructed. And it turned out that this kid's father had TB, and we did an emergency bronchoscopy. We thought this child had a foreign body or something. And you could see that there was caseous material that was completely blocking the left mainstem bronchus. So this child had this emphysema of the entire, it actually wasn't completely blocking, pardon me, it was partially blocking. So this child had horrible emphysema. And when they were able to relieve some of that obstruction, they were able to lower the expansion of the lung and make it more functional again. But until we did the bronchoscopy, we had no idea that this child actually had tuberculosis. This is just one of those x-rays that shows a little bit of everything that I like to teach about in clinic. The red arrows point, this is a kid, the red arrows point to cavities. And you can see 2 in the right lung and then 1 in the left lung that's sort of hidden behind the heart. Notice how thick the one, surrounding the thickness of the cavity on the left side. The green represents subcarinal lymph nodes, and you can tell the takeoff point of the 2 mainstem bronchus is wider than normal. And the reason it's wider is because something is spreading those 2 bronchi, mainstem bronchi apart, and what's spreading them apart is the subcarinal nodes. And then finally, the blue area is pointing to the mainstem bronchus on the left, and you can see how narrow it looks. How, you see the trachea come down, and then the left side, almost disappears. You can just barely see it. And that's because it's being squeezed by both these subcarinal and then probably also hilar lymph nodes, causing the narrowing. So, I mean, this is one of those lucky chest x-rays that shows just about every single potential manifestation of tuberculosis of the lung in children. This is bronchiectasis. This is a cylindrical bronchiectasis. This is a child who came to us from California with TB and he was not on DOT and had very poor adherence to therapy. And unfortunately, this child ultimately went on to have a lobe of the lung actually removed because although I think we cured the TB, this child was having recurrent bacterial infections because of all the damage to the lung. Some patients will actually auto amputate. That is, they'll almost cut off, if you will, this lung from other circulation. But that didn't happen in this child's case, and it had to be surgically removed. Reactivation TB, or so-called adult type TB, does occur again mostly in adolescence. And it causes the same kind of features as adult disease, a cavity or an upper lobe infiltrate. They have cough, fever, weight loss, and then eventually hemoptysis. And of course, these folks may be contagious, so we need to make sure we isolate them appropriately. And sputum or gastric aspirates to isolate the organism. And occasionally you need bronchoscopy with these, but most of the time you don't actually. And this is a girl who came to us from Nigeria. And her sister was graduating from high school in the United States, so she came from the graduation. And she came to the clinic at Benton because she had a cough and she wanted to get some cough syrup. And when we listened to her, we didn't hear any breath sounds over the left lung, and we got this particular chest x-ray. And what was really difficult, this actually turned out to be multi-drug resistant TB. And this girl ended up spending 2 years with us and spent some time, she was 17, actually spent some time in San Antonio at the State Chest Hospital, and ultimately did very, very well. This is the more classical, you can see particularly on the left side, but also the right up in the apices, there's evidence of infiltrate. This is a massive disease on the left side and with bronchogenic spread over to the right side as well. You know, if this is drug susceptible TB, usually this can be cured, but if this is multi-drug resistant TB, where sometimes surgery is actually required to effect a cure, this patient would be in real trouble. Fortunately, this was fully drug susceptible disease. And then we see disease like this, and this is what I referred to before, where the hilar region is pretty quiet. You don't see any nodes here, everything looks normal, but then you have these peripheral 1, 2, and probably a third cavity out here in the periphery with so-called adult type T that could occur in a teenage boy. Pleural effusions occur in kids, but they're much less common than in adults, primarily adolescents. They're uncommon before age 5 and rare before age 2, but they do occur. They're usually unilateral, but they're occasionally bilateral. They're almost never associated with a segmental lesion, interestingly, and are really rare in miliary tuberculosis. Usually, their presentation clinically is very similar to other causes of pleural effusions. Pretty abrupt onset, fever, chest pain, shortness of breath are actually quite common. And then the thoracentesis has usually several hundred white cells, mostly monos. The glucose is low and the proteins are often very, very high. The trick though, this is a hypersensitivity phenomenon, so it's not always so easy to find the organism in the pleural fluid. The AFB stain is frequently negative and the culture is positive, usually less than half the time. If you can get a pleural biopsy, that's a better way and you have a better likelihood, at least you can see caseating granulomas and you may also be able to get the organism. But sometimes convincing our colleagues who do those kinds of procedures can be difficult, to say a lot. And this is a girl, we had an outbreak of TB in an elementary school when a janitor had tuberculosis. And this girl, believe it or not, hadn't sought medical care and she had a cough and a little bit maybe of low-grade fever, but that's all she had. And she had a pleural effusion all the way up to the apex. I mean, imagine if this were Staph aureus or something like that, how sick this person would be. Yet she was relatively mildly sick. But you know, this is typical. This is the same kind of pleural effusion that you could see with a host of bacterial infections or all kinds of other things. It just so happens that TB is the cause of this particular one. Miliary TB is more common in children, particularly young kids, than it is in adults. And it occurs, remember again, very recently after infection. The manifestations are protean, and everybody fixates on the miliary part, the chest x-ray, called miliary because to somebody in the old days it looked like millet seeds. But I think it's really important to remember that the pulmonary x-ray changes in disseminated TB are actually quite late. these kids will usually have other symptoms before they have those changes in their chest x-ray. They'll have hepatosplenomegaly and lymphadenopathy, sometimes skin lesions and fever. And if an eye doctor takes a look, choroid tubercles. Again, the sicker they get, the more likely that the tests of infection will be negative. And to diagnose this microbiologically is really hard. The culture yield from even bronchoscopy is not very high in these particular kids. It is important to look at other tissues as well, including the possibility of lymph node biopsies, looking at the bone marrow. We always get urine and blood cultures. Occasionally you will get a positive in kids who have disseminated TB. So we all call it miliary TB, but I really think disseminated TB should be the preferred term. And then some of these kids develop miliary manifestations in the chest x-ray. This is a kid who came to Ben Taub Hospital, died 16 hours after this x-ray was taken. He'd been seen by 4 different clinicians in the previous 10 days. Nobody did a chest x-ray because the family didn't have health insurance, and he just got sicker and sicker and tragically died with just horrible, awful tuberculosis. This is a little bit more commonly what we see, these widely disseminated small little tubercles that are occurring all over the lungs. And then occasionally it looks like this with some pretty significant adenopathy over on the left-hand side. Lymphadenitis, again, most often unilateral, but it can be bilateral in some kids, but usually it's unilateral. The chest x-ray is often normal, although you may see hilar or mediastinal lymph nodes as well if the infection extends down. And someone asked earlier about bovis. If you do see lymph nodes going down into the chest, you really ought to ask some questions about the possibility of exposure to bovis as well. Usually it's pretty indolent with onset of enlarged, fixed and matted nodes most often in the anterior cervical chains and submandibular regions, but they can be in other places, submental, rarely occipital, axillary. The hardest ones are the ones that are preauricular, right in front of the ear. They're difficult, and they can leave some difficult scarring as well. Supraclavicular nodes do occur, but usually in association with positive chest x-ray findings as well, because the drainage to the supraclavicular nodes is mostly from the thorax, not from the neck. Usually we don't see much in the way of systemic findings. And these nodes are usually not particularly tender. They can get superinfected. We've seen a few superinfected with Staph aureus, and then they look just like staph nodes, but they again have underlying tuberculosis. If they're not treated, they often progress and break down, and they suppurate and then eventually develop sinus tracts as well. So this is an extreme example of cervical adenopathy from tuberculosis. And this is how this girl presented to us, with that open lesion on her neck with caseous material literally extruding out of her neck. The problem with this is there's so much necrosis and dead tissue in there that it's very difficult to deliver the antibiotics for TB to the place where the organisms reside. And this girl actually ultimately required very extensive neck surgery, almost like a radical neck dissection, to take out all of the diseased material so that the antibiotics could be effective against the organisms that were there. This was very advanced disease. Now, this is in contradistinction to this child who does not even have tuberculosis. This child has infection with a non-tuberculous mycobacterium, Mycobacterium avium intracellulare, but you can't tell the difference just by looking at the nodes. The difference is in the epidemiology, the age of the patient, whether or not they likely have been exposed to tuberculosis or not, skin test and IGRA and chest x-ray and all kinds of things to help. But sometimes it's really difficult until you get culture information back to distinguish between TB and non-tuberculous mycobacteria, because they tend to do the same things in terms of their clinical presentation. And then TB meningitis, which Dr. John talked about some, and I'm not going to talk about it too much. I've seen about 75 cases of CNS TB. Each one is different, frankly. I don't think I've seen 2 that were really the same. Most common in infants and young children, and it, again, occurs pretty rapidly after infection. And there are 3 clinical stages. The first one's non-specific signs and symptoms, which really can be recognized as TB meningitis only in retrospect. In other words, there's nothing distinctive about it where you see the child and you go, aha, this must be TB, unless you take a good exposure history and find out that Uncle Eddie was just diagnosed with TB a couple weeks ago, and that this child likely has been recently infected with TB. So the search for the source case is a really important part of trying to diagnose TB meningitis. When they start developing focal neurological findings, that's an increased intracranial pressure. That's the second stage. And then the third stage is when things really get bad and they have coma, paralysis, posturing, and then ultimately death without any further intervention. And the prognosis is directly related to the stage at which therapy is actually started. CSF findings, I won't spend too much time on this, but there's viral, bacterial, and then TB. And TB is kind of right in between viral and bacteria in terms of the cell counts. The types of cells, you tend to see polys early, but then you see mononuclear cells. But the proteins in TB meningitis can be extraordinarily high. And the glucoses are low, but they're not as low usually as they are with bacterial meningitis, although they can be quite low as well. So the actual features of TB meningitis are represented in imaging, CT scan or MRI. The inflammation is not over the cerebral cortex, it's at the base of the brain. And so first of all, you can see that inflammation at the base of the brain, particularly with MRI. And then what comes out of the base of the brain? Well, some of the cranial nerves come out, so they tend to have cranial nerve involvement. It affects the communication of the ventricles, particularly between the fourth ventricle and the lumbar space at what are called the foramina of Lujski and Magendie. So you tend to see hydrocephalus in large chambers. It's all four of the chambers are enlarged, not just the first three like you would see with aqueductal stenosis. They also get vasculitis, which affects the circle of Willis, so they tend to get strokes. And they particularly get strokes in the lower part of the brain, like the brainstem, basal ganglia, thalamus. That's where they tend to get the worst strokes, not again up in the cortex of the brain. And then we also see so-called, we used to call these paradoxical tuberculomas. Now we call it iris. But the concept of paradoxical tuberculomas has been known for a very, very, very long time, where you'll put people on therapy for TB meningitis, they seem to do well, and then a month into therapy, they come in with a generalized seizure, and you do another image, and all of a sudden, you, excuse me, you can see masses of tuberculomas that weren't there during the initial diagnosis, and that's an iris phenomenon. It's not a failure to kill the organisms, quite the opposite, you're killing the organisms, so you have an enhanced inflammatory response, and that's what tends to cause the mischief. So like I said, this was well known before the whole concept of iris in association with HIV infection was ever even developed. Speaking of TB in HIV-infected kids or children living with HIV, I prefer to say it now, clinical radiographic presentation in children with preserved immunocompetence, it tends to look just like TB does in any other child. The most common symptoms remain malnutrition, fevers, night sweats, and so forth. Extrapulmonary disease is more common in children with poorly controlled HIV infection, meningitis, tuberculomas, and abdominal TB in particular. When they do get TB meningitis, it tends to look the same as TB meningitis in terms of clinical and radiographic and CSF findings, but they do tend to be sicker, and they more often develop into cerebral masses. The chest x-ray findings also are pretty typical, but they're usually more extensive, and there's unfortunately a broader differential diagnosis as well. And this is the problem, the impact of HIV on the diagnosis of pulmonary TB. Chronic symptoms are less specific because lots of other things can do the same symptoms. Having positive TB contact if it's apparent is also less specific. Malnutrition is less specific. Having a positive test of infection is less sensitive because their immune systems are knocked down by HIV. The typical chest x-ray findings are less specific because, again, with HIV infection, other diseases and infections, fungal infections, for instance, can cause findings very similar to TB. And then finally, satisfactory response to TB treatment may be less sensitive because it takes these kids often, they ultimately seem to respond pretty well to standard therapy, but it often takes longer. So you're wondering whether or not they're actually getting better. And it takes a long time for chest x-rays to get better as well. So how do we diagnose TB disease in kids? Well, a cheap, easy, non-invasive, and accurate, especially sensitive test is absolutely the holy grail. Anybody who works in childhood TB, if you ask them, if I could give you one thing, what would it be? This is it, a really good diagnostic test. Because as we said in the last lecture, the rates of positive stains, expert culture, and so forth are all very, very low and much lower than they are in adults. So again, epidemiology, radiology, clinical all become very, very important. So how do we evaluate a child that we suspect might have TB disease? Well, we evaluate other family members, because if you find Uncle Eddie, then that really raises the stakes that Johnny has tuberculosis. So that's important. So doing a really timely contact tracing, if you will, an associate investigation of reverse contact tracing, is really important when we're trying to figure out. So if you're working in a health department, a clinician calls you and says, I think this guy might have TB, I really need the household checked out, that's really an urgent thing to do. It's really important to do. TB skin test, and of course now IGRAs as well, appropriate radiographs, sputum if it's available, and in many places now they're inducing sputum in kids as young as 18 months of age. More often than not, though, we're doing gastric aspirates, and there is some evidence that really early morning gastric aspirates are better than during the day aspirates. The reason is the child is asleep and during the night is bringing up respiratory secretions and swallowing them. But when we're asleep, peristalsis is pretty quiet. So those secretions tend to stay in the stomach. So the whole point is you want to sample those secretions before the child is up and running around and has moved everything through. If a child has TB disease, not TB infection, but pulmonary TB disease less than a year of age, we always recommend doing a spinal tap. You can't talk me out of it. Have we found cases of TB meningitis that way? Yes, we absolutely have. Between 1 and 2 years of age, you have to think about it. 2 years of age and above, it's based purely on clinical grounds. Does this child have neurological signs and symptoms that are consistent with TB meningitis? We don't do many bronchoscopies. We do it mostly if we don't have a diagnosis and the anatomy is in doubt, like the little child I told you about who came in with the hyperinflation of the left side and we didn't know what was causing it. But it's not a better way of getting culture. In fact, sputum induction and gastric aspirates has, if anything, a higher culture yield than bronchoscopy does in children. And then, of course, we remind everybody to report the suspicion of disease, not confirmation, but suspicion, because it's that suspicion that launches the contact tracing that may actually help you correctly diagnose the child with tuberculosis. Gastric aspirates, unfortunately, are still our best culture source. People are working on other things. People are looking at nasogastric aspirate, which actually with extensive disease has a pretty high yield of culture, although not quite as high as gastric aspirates. With minimal pulmonary disease, it really isn't very good. And people are trying to find indirect tests and all kinds of different things, again, because of the difficulty in culture confirmation. Again, induced sputum, the most important thing about induced sputum is the person who's doing it, because if you think about it, you're irritating the child's lungs and you're trying to get the child to cough and cough up mucus. Well, if a child coughs up mucus, what's the first thing they're going to do? They're going to try to swallow it. So the really important person is the usually respiratory therapist who's sitting there with the child and a suction catheter. And as soon as the child starts to cough and sounds like they're bringing up something, having that suction catheter in their mouth so that you can try to actually obtain the mucus in the trap. It's a pretty invasive thing to do, actually. And it's another reason why people are trying to really study non-invasive methods of microbiologically confirming kids, because it's pretty nasty stuff we do to them with both gastric aspirates and induced sputum, especially in the really little kids. Expert, of course, has been a big help. Expert does not replace culture. In children, Expert is not as sensitive as culture, but it is more sensitive than microscopy, than acid-fast smear. And so what Expert really has replaced is acid-fast smear. And then, of course, if it's positive, it does give you information about rifampin susceptibility. So that's another added benefit. And so Expert is widely being used in places to take care of kids with tuberculosis. And this is just one study. I'm not going to spend a lot of time on it. 450 kids using Expert and showed pretty good results. And interestingly, it was even better for kids with living with HIV than for kids who didn't have HIV infection. And those kids did tend to have a higher burden of disease, and so therefore probably a little bit easier to detect the organism. In fact, culture results tend to be a little bit more positive in kids with living with HIV than kids without, for probably exactly the same reason. They tend to have more advanced disease. So we're looking at these indirect methods, and this is just one study that was in New England Journal a few years ago, where they looked at 3,000 kids. And what people are trying to do is look at genomes and look at RNA expression and other things and see, is there a combination of these things called transcripts that can accurately tell us if a child is likely to have TB infection or TB disease. I'm not going to spend any time on this because none of these things are available right now. And there is some work being done on developing these new diagnostic methods. I wish there were more work being done, and I wish it would be done faster, but it is occurring. And people are also using so-called biomarkers and even looking at certain cytokines and certain other things, so-called mRNA signatures, not to be confused with COVID vaccine and so forth. So people are really, really trying to come up with things that could really help tell us if a child has TB disease, especially if it's a child who comes in with, a pulmonary problem and we don't know what's causing it, but if they have this certain signature, we know it's tuberculosis. So this will probably help more in passive case finding than it will in active case finding through contact tracing. So let's talk about treatment again. So this is one of my favorite slides. The development of the development of drug resistance in TB is the result of a conspiracy among the organism, the patient, the doctor, and the healthcare system. So what do I mean by that? Well, given the nature of the organism, if the patient messes up and doesn't take the medicines properly, or the doctor messes up and doesn't prescribe them properly, or the health system messes up and doesn't provide them the right way, then it will inevitably lead to the development of drug resistance in that particular patient. So let's go through this a little bit. We know that there is a genetic locus on the chromosome, one of the chromosomes of TB, that certain mutations confer resistance to every known TB drug so far. These are on chromosomes, not plasmids. That's important. Plasmids is how organisms can transfer resistance one to the other. This doesn't happen in TB. This is just on the chromosome. So it's not passed from one bacteria to another, but it can occur simultaneously in a lot of different mycobacteria under certain conditions. So these genetic loci are known, and importantly, they're independent of each other. So that means the mutations occur independently, they don't travel together in packs like they do with plasmids. With plasmid resistance, usually you get resistance to multiple drugs traveling together. But with TB, it's just one drug at a time. We know what the frequency of mutations is in these certain genes that confer resistance. So if you know the size of the bacterial population and you know how often the mutation occurs, you can actually estimate the number of germs that have this mutation. It also means the larger the population, the more likely that these resistant organisms are going to occur. Well, we already know that children have many fewer organisms in their bodies than adults do. So right away, we would say, well, then development of resistance is probably much less common in children than it is in adults. And it turns out that it is. The majority of drug resistance that occurs in adults is drug resistance that was already present when the child got infected. Whereas adults can develop resistance either because they breathe in a resistant organism or because the resistance develops while they are on therapy. The first is called primary resistance, where it's already there when you breathe in the organism. And secondary resistance is what occurs while you are on treatment. So children are much more likely to have primary resistance than secondary resistance. So let's see how this happens. Let's say we have a cavity that has 10 to the 9th organisms, which is probably a pretty good estimate. Well, we know that the resistance gene, the mutation that confers INH resistance in general occurs every 10 to the 6th replications. And for rifampin, it's every 10 to the 7th replications. So what that means is, by definition, if you have a cavity with 10 to the 9th organisms, you'll have 1,000 organisms that are INH resistant and 100 organisms that are rifampin resistant. That always occurs. Now, the laboratory will call this drug-susceptible TB because it cannot detect resistance levels that are that low. Regular testing doesn't detect that. So this is drug-susceptible TB, but there will be organisms in there that are resistant to either INH and rifampin. So remember, the resistance to those two is independent. So if you treat with INH alone, then all the organisms that are resistant to rifampin will be killed. But 1,000 organisms that are resistant to isoniazid will survive and grow. And that person will ultimately, they'll get better for a while, but they'll ultimately relapse again with 10 to the 9th organisms. But this time, all of them are resistant to isoniazid. And again, 100 of them are resistant to rifampin because you've expanded the population back up to 10 to the 9th organism. This is how serial resistance develops in TB. And this is ultimately how multi-drug resistant TB develops, because one by one, you knock off the effectiveness of the medications by selecting out for the resistant organisms, okay? Now, in contradistinction, if we treat that person with INH and rifampin, well, the INH will kill all the rifampin-resistant germs. The rifampin will kill all the INH-resistant germs. The likelihood of having even one germ that's resistant to both is 10 to the minus 13th. Well, if you only have 10 to the 9th organisms in the cavity, the chance of having even one organism that starts out resistant to both medications is not quite zero, but it's really, 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 really low. So INH kills rifampin-resistant germs, rifampin kills INH-resistant germs, and the patient is cured. And this is the basic reason why multi-drug therapy is required to cure tuberculosis disease. This is it. Now, we take people who have TB infection and we treat them with a single drug, either INH and rifampin, and it works. Why does it work? Well, probably it's because if you're only infected with 10 to the 4th or 10 to the 5th organisms, you might not have any organisms that are resistant either to INH or to rifampin. And so treating with a single medicine will cure you. And remember, 90% of the people who have TB infection that goes untreated will never develop the disease anyway. So right off the top, the risk is so much lower as well. So does that mean occasionally a person who's treated with INH will develop tuberculosis? Yes, occasionally, but at a very, very low rate, like a very, very low rate. So this is why you can treat TB disease. You have to use multiple drugs. And this is why you can use single drugs to treat TB infection. Of course, now we're using multiple drugs as well, like INH and rifapentine, because it increases effectiveness. So the adage that goes with this is more bugs, more drugs. And so the question that I ask trainees that are working with me is, when a person has a positive test of infection, either skin test or chest x-ray, why do you get it? I'm sorry, either skin test or IGRA. I'm not talking well after lunch, I apologize. A person has either a positive skin test or IGRA. Why are we getting a chest x-ray? And the answer is, we're estimating the number of mycobacteria that are in that person's body. If the x-ray is abnormal, we estimate a large number of mycobacteria. We call that disease, whether they're symptomatic or not, and we treat them with multiple drugs. If the x-ray is normal and they're asymptomatic, we estimate a small number of organisms. We arbitrarily call that infection or latent infection, and we treat with a single drug or an appropriate regimen. So that begs the question, well, when does infection turn into disease? And the answer is, well, from the same argument, it's when the number of organisms in the body crosses that threshold where you need to give 2 drugs in order to prevent the emergence of resistance. So the question then is, well, what are the clinical correlates of that? And my answer is, I don't know, I have no idea. The convention is, if you can see it with your eyes, abnormal chest x-ray, or feel it with your fingers, physical exam, pulmonary, extrapulmonary TB, we call that disease and we treat accordingly. And that is sort of this rough scientific basis for why we treat TB infection and treat TB disease the way that we do. And then everything else beyond that is kind of fine tuning. Maybe someday we'll have a drug that no resistance occurs and we can cure TB disease with a single drug, but that certainly hasn't happened so far. So what are the roles of the 4 major TB drugs? Well, INH and rifampin are bactericidal. They're the killing, they really kill the organism. And they also prevent replication of the organism, so they prevent emergence of resistance to the other drugs. They do both of those 2 things. Ethambutol is more bacteriostatic than bactericidal. It may be bactericidal. It may kill the organism at high concentrations, but really what it mostly does is prevent the replication of the organism, so it helps to prevent emergence of resistance to other drugs. That's its place in the regimen. And PZA, it's hard to know exactly what PZA does because it's hard to show that it does anything in the test tube. But we do know that when you give it to people, you can treat them for a much shorter period of time. So it does something to make INH and rifampin more effective in terms of their ability to kill the organisms. So we have two killing drugs. We have a drug that prevents emergence of resistance, and then we have a drug that shortens the amount of time that's required. And then, of course, now I'm talking about the treatment of drugs susceptible to tuberculosis. So what are the current recommended regimens? Well, first of all, there was a big change in 2018, and now I put 2021 because this is what the next Red Book's going to say in rifampin dosing. We've known for a very long time in both adults and children that we've been underdiagnosing people with rifampin. And it's funny, we've known for a long time, but haven't really done very much about it, to be honest with you. So we upped the dose that was recommended for standard treatment from 10 to 20 up to at least 15 to 20. But for toddlers and infants and anybody with severe TB, we really now recommend 20 to 30 milligrams per kilogram per day. And in fact, even higher sometimes. Studies in adults have shown that even treating with like 2,400 milligrams per day, which is 4 times the usual recommended dose, the incidence of adverse effects doesn't seem to go up, but the drug levels certainly go up and the area under the curve certainly goes up, and likely the effectiveness goes up as well. So we've learned that we have to use larger doses of rifampin than we had used in the past to really do better job, I think, with these kids. And this is absolutely what we do. So the 4-drug, in the United States, we call this RIPE therapy. It would be HRPE in most of the world. And all 4 drugs are still the backbone of therapy. We use PZA only for the first couple of months. And again, this is for drug susceptibility TB. So this is the same as in adults. And ethambutol, once we know that the child has drug susceptible TB, either from their own cultures or from the source cases cultures, then frankly, ethambutol doesn't do any good anymore. So if you already have the source case and you already know the source case has drug susceptible TB, you don't even have to give ethambutol. You can turn it into 3-drug therapy with just rifampin, isoniazid, and pyrazinamide. We're still anticipating 6 months of therapy, but as I mentioned in the previous lecture, some of the data coming out of the SHINE study are showing that with minimal disease or lesser disease, 4 months of therapy is probably adequate. We're not doing that now. I don't want anybody saying that I'm recommending that, and we haven't figured out exactly what we mean yet by minimal or less severe disease, but I think those things are coming. And I think in the not too distant future, we're going to be treating a lot of kids, particularly those picked up in contact tracing, with 4 months of therapy for TB disease rather than 6 months of therapy. And of course, we always use directly observed therapy for TB disease. You should not be afraid of ethambutol in children. There is literally no data that it causes optic neuritis or any eye toxicity at all. We do not have our kids routinely seen by ophthalmologists at all. And in the doses that we're using, if their kidneys are normal, which fortunately most children's are, then they should have no trouble handling ethambutol at all. WHO recommends it for TB meningitis, but most of us who do TB think that's kind of crazy because it doesn't cross the blood-brain barrier very well. So we don't tend to use it for TB meningitis. We use ethambutol or a fluoroquinolone or some other drug like that as the 4th drug for TB meningitis specifically. Medication tolerance, about 5% of the time kids will have side effects. Most of them are minor, and they'll have a little bit of abdominal pain, which is really gastric irritation more than it is actually hepatitis. There's about a 3% incidence of elevated liver function tests, but they go back to normal spontaneously and rarely cause symptoms. And to be honest with you, we don't follow liver enzymes. If the child is asymptomatic, I'll be honest, I don't want to know what their liver enzymes are doing, because if they are mildly elevated, then I have to follow them and I have to stick the kid with needles again and get that. And it causes more harm than good, in my opinion. So we follow them clinically and we beat it into the parents. If your child is having abdominal pain, vomiting, particularly jaundice, the first thing you do is stop the medicine. And the second thing you do is call us so we can evaluate your child and make sure we understand what's going on. Peripheral neuropathy is really pretty rare before adolescence. It happens, but it's kind of rare. And a lot of these kids also on pyrazinamide will get elevated uric acids, but they're usually not of any clinical consequence. So we don't give everybody B6. We just give kids pregnant teenagers, breastfeeding babies, kids with poor nutrition, and children living with HIV, we would always give pyridoxine supplementation to. Corticosteroids. So a lot of the mischief that's caused by TB in children is actually a result of the inflammatory response, not the organisms. And while we're killing off the organisms, we sometimes need to cool down the inflammatory response. I went to a meeting at NIH a few years ago about TB meningitis. This was experts from all over the world. 40% of the meeting was about killing the organism, and 60% of the meeting was about handling the inflammation. It's really a huge, huge topic right now, and we're learning all kinds of things about the genetic predisposition to inflammation. It's quite interesting. But for pretty much all cases of TB meningitis, some of the kids with endobronchial TB that have obstruction because of enlarged lymph nodes, if they have miliary TB that's so bad that they're not exchanging oxygen well, pericardial TB with constriction, or if they have vertebral Pott's disease with evidence of nerve involvement, those are the kids that we will always put on corticosteroids, usually for 4 to 6 weeks. And you can use either prednisone or dexamethasone. I don't think it's really been well shown that there's a difference. The impact of drug resistance in kids. Again, the only way we're ever going to know it in most of these kids is to link the child with their source case. Adults with drug-resistant TB are just as contagious or infectious as those with susceptible disease. I was taught early in my career that they're less contagious, and we now know that's absolutely not true. Drug resistance disease expression in children is really the same as it is with susceptible strains. And the good news is children tend to tolerate and respond well to the second-line drugs. We have an interesting dilemma coming up because, as you know, there's the new regimen that's being used all over the world with bedaquiline, linezolid, and protamidine for treating drug-resistant TB. We have no data whatsoever for protamidine in children, and so how we're going to use this kind of a regimen in children is going to be very problematic for us indeed. Some of the issues in the management of drug-resistant TB in kids, we have very little clinical trial data. The optimal drug combinations are not really known, nor are the durations of therapy. We don't have even basic pharmacokinetic data on a lot of these drugs. There's no child-friendly dosing forms for the secondary drugs at all. Adverse drug effects are more difficult to assess, although they do tolerate it better. And kids have more intercurrent illnesses. So during a long stretch of therapy, they're going to have other symptoms, and deciding whether those symptoms have anything to do with the medicines or TB, or whether they're due to some kind of intercurrent illness is also a real challenge. So treatment of drug-resistant TB in kids all depends on what it is. And again, I'm not going to spend too much time on this. In fact, I'm going to rifle through the rest of these slides pretty quickly because they're mostly for your, just for you to have as reference. Simon Scoff in South Africa has talked about a lot of the new drugs, and I have several slides here. And again, I'm not going to spend time on this, but drugs like linezolid and clofazimine, fluoroquinolones are being used increasingly in children who either can't tolerate other TB meds or who have a drug-resistant tuberculosis as well. And again, it's turned out it's a really good drug for TB meningitis because they tolerate levofloxacin and moxifloxacin go into the CNS really, really well. And then we have the new drugs, bedaquiline. Now, bedaquiline came up through the United States, so there was initially no pediatric data because it's not required. It's an orphan drug in the United States, which means it can be approved with no pediatric data. So we've been trying to learn how to use bedaquiline in children. We certainly use it in adolescents now, but the younger children, there's still a lot of problems. And there's no pediatric dosage form yet, as opposed to delamanid that actually came up through the European system. So it was required to have pediatric data, and it was required to have pediatric dosage forms for delamanid. And so those are now available, and we're learning more and more about this use of this drug in children. So follow-up evaluations, finally, is the last slide for kids with TB, remembering that the skin test, and again, that the, or IGRAs probably, we know skin tests stay positive, we think IGRAs do too. Frequent chest x-rays are unnecessary. We usually get them at diagnosis. A couple months into therapy, because when we're going to stop the PZA, we just kind of want to know where we are. We don't expect the chest x-ray to be all that much better. We just don't want it to be worse. And then we get it at the end of therapy. But 30 to 50% of the kids still have an abnormal chest x-ray at the end of therapy. It's better, but it's abnormal. I remind our trainees, the only thing TB meds do is kill germs. That's it. They kill germs. They don't shrink lymph nodes. They don't get rid of infiltrates. They don't do any of that. The body has to do that. And it takes longer for the body to do that than it does for us to effectively kill the organisms. We follow growth and development very, very closely. And if kids start to fall off their growth curves, we're really concerned and really look into what's going on. And therefore, these kids really need adequate nutrition and nutritional support while they're being managed for tuberculosis. Again, routine liver enzyme monitoring is not necessary unless they're on other liver toxic drugs like anticonvulsants, or they have a history of some kind of liver disease. And again, routine pyridoxine isn't usually necessary except under the certain conditions that we've already mentioned. And I am going to stop there and see if anybody has any questions. I really appreciate your time and attention. Thank you so much.
Thank you, Dr. Stark. So again, if you have any questions for Dr. Stark, please use the Q&A pod. And we do have a few questions. Let's see. Do you recommend doing splenic biopsy to diagnose TB if all other differentials rule out? Patient has multiple lesions on spleen and is asymptomatic.
Well, I don't normally recommend splenic biopsy. Actually, there's some very good studies showing the use of abdominal ultrasound in diagnosing tuberculosis in children, particularly children with HIV infection. The studies from Africa have shown kids with HIV infection are more likely to have abdominal nodes and more likely to have splenic lesions. So that's kind of interesting that you're asking about that. I have no personal experience with splenic biopsies. I'm not sure that I would go that far unless I was uncertain of the diagnosis. Splenic biopsy has, appreciable complications, particularly hemorrhage. So no, that's not something that we have. I don't think I've ever done a splenic biopsy. And even in South Africa, my friends and colleagues down there rarely do it, but they do ultrasound. If I had a child with a positive test of infection, who, especially if it was recent infection, who had splenic lesions, I would absolutely consider that disseminated TB disease and I would treat accordingly. The question is something else causing those splenic lesions?
Let's see, and another question. I'm curious as to why that higher dose for rifampin wasn't standard in the Red Book, as we largely recognize rifampin is underdosed. Concern is, at what point do you recommend for extensive disease? Please define that.
Why wasn't it done earlier? It just wasn't, and it was a mistake. I mean, it wasn't done earlier in any of the guidelines, even from the CDC and the American Thoracic Society. And it is true that more data became available, but we were slow. To be perfectly blunt, we were just slow. And because patients seemed to do pretty well in general on the doses we were using, we kind of got complacent. But now we're sort of saying, the whole approach to treatment now and looking at it more like an infection, we're saying, look, you should look at the right stuff and what does it really take to kill this organism, and we should make sure that we provide that. So, TB meningitis is the one for sure that we know those higher doses should be used. I never go below 20 milligrams per kilogram on rifampin now, really on almost any patient. Now, this is for TB disease, and I'm also talking about oral rifampin too, not IV rifampin. That's a little bit different. For TB infection, we might use rifampin 15 per kilo, but at disease now, we're always using at least 20 per kilo. And if they have, I don't know how to define extensive disease, but if they have hard to treat forms like bone and joint TB, meningitis, I would always use 30 per kilo.
Okay, let's see, another question. Do you recommend always getting an end of treatment chest x-ray?
Yeah, I pretty much always do. I want to know where it is at the end of treatment, especially with kids who are predisposed to getting other pulmonary infections. And so if you don't have it, then if they do develop another issue later on, you don't know where you were, kind of. So yeah, we always get one. Now, the only exception, if after, if we get one at 2 months of therapy and it's pretty much normal by then we don't do one at the end of therapy. But if that's not the case, and usually it's not, of course, then yeah, we always do it.
Okay, let's see. I don't see any other questions in the chat box. There are no more in the Q&A pod.
If you don't mind, I'm just going to tell everybody my email address. Just like Dr. John said, I don't ever mind getting emailed with questions or anything. It's jrstarke, JRSTARKE at Texas Children's, all one word, TEXANCHILDRENS.org, ORG.
Hey, Jeff, this is Kim. Can you hear me?
Yes, ma'am.
I think the speakers can't put in anything in the Q&A box. So I have a question, or
Yeah.
maybe I could be technology challenge. That's also possible. My question is, are you using Gene Expert on AFB smear samples? Because I've had problems getting that because of FDA restrictions.
So your question is incredibly pertinent because I got a new answer just yesterday. We were not doing any Gene Expert at our hospital, but after years of us cajoling them, they have now gone through the testing process and it will be available. And for us anyway, they will be doing it directly on samples, including non-respiratory samples, if they can be processed correctly. We had to talk to the place where we send our cultures to sort of get them to do them on non-traditional samples. I mean, people don't even consider gastric aspirates to be respiratory samples, which just cracks me up. But so yeah, we have had problem, and I think in some communities in particular where maybe you only have one lab available to you, that can be an issue, and you need to be an advocate. And you need to go to the lab and say, why they need to do something different. But yes, that has been a problem, Kim.
Thank you.
Let's see, there was another question in the chat box, Dr. Stark. Why is it that the TB bacteria is so different that one can have a very abnormal chest X-ray, CT, and minimal sign symptoms, unlike other bacteria, and where it can wax and wane for decades?
Boy, if I could answer that question, I think I'd probably have a Nobel Prize. It's an intracellular organism, and so that may be one of the reasons why. I mean, this is going to sound funny. I mean, this infection's been around for millennia, and it has learned how to adapt, how to sort of hide. The last thing an organism wants to do is kill its host, because then it dies too. And so it's smart that it's developed this chronicity that other bacteria haven't been able to do. I'm not sure I can tell you exactly what the mechanisms are, but for instance, when a neutrophil or a macrophage ingests the organism even actually has ways of walling itself off within the cell so that the chemicals that normally would kill the organism can't get to it. And again, these are things that have evolved over a long, long, long period of time. It's just the nature of this particular beast, and it's why it's been around for so long and why it's so darn hard to get rid of. And frankly, why vaccination is such a challenge. It's not going to be easy to develop a truly effective vaccine. It can be done if we have the willpower and put the money into it. But if we're lacking either of those two things, then it's going to be really tough to develop a good vaccine. It kind of chaps me sometimes. Here we have this miracle of a COVID vaccine in a year, and this damn thing's been around for all this time, and we're no closer to a good vaccine than we've ever been. So.
Let's see, there's another question. What diseases other than active TB causes night sweats?
I'm sorry, what about night sweats and TB?
No, it says what diseases other than active TB causes night sweats?
Oh gosh, in Houston, Texas, every time the weather changes, every time people turn on or off their air conditioner, people get night sweats. I had night sweats last night. And kids can get it with viral infections, I mean, anything. So it's non-specific in adults too, but it's very non-specific in children. So it's just not useful. If it's in combination with other signs and symptoms and other epidemiology, okay, that's fine. But as an isolated finding, it doesn't point me toward TB at all.
All right. Since we're running into the next presentation time, if you have any further questions for Dr. Stark, please use the Q&A pod.
Yeah, the last thing I want to do is get Dr. Cruz angry at me, so thank you for that. So thanks to everybody for listening. I appreciate it.
Thank you, Dr. Stark.
Thanks, Jeff.
So our next speaker is Dr. Andrea Cruz. Dr. Cruz is an associate professor of pediatrics at the Baylor College of Medicine and the director of the Children's Tuberculosis Clinic at Texas Children's Hospital, the largest pediatric TB clinic in the United States. Dr. Cruz also serves as a pediatric consultant for the Heartland National TB Center and has been a consultant for the World Health Organization. Please welcome Dr. Cruz.
Hi, folks. Can you see my full slide screen?
I can, Dr. Cruz, but wait, there we go. Perfect.
Yeah. Excellent. After a mere 15 months, I've actually finally managed to master Zoom. Good afternoon, and thank you so much for the kind introduction. I have no relevant disclosures, although I do sit on an editorial board and a data safety and monitoring board. So in the course of the next, it's not actually going to take the whole hour because I want to make sure that we leave time for questions. We'll talk a little bit about the epi of TB infection, both globally and nationally. We'll talk about what are the barriers that our healthcare system and our patients and their families face to the accurate identification of TB infection, and then to going on to receive appropriate therapy. And then we'll review the updated guidelines on the pediatric side. So for this group, I think it's, when we talk about the terminology of tuberculosis, it's very much innate in what we do. I put this slide up here mostly because the terminology that we use is not readily transferable to other infectious diseases. We don't talk about somebody being infected with syphilis versus having syphilis disease. We just refer to it as syphilis. And I do think that some of the nomenclature that we use does cause confusion among our colleagues who don't do TB for a living. And this is, I think, particularly the case. I know you had a wonderful talk this morning from Kim about TB exposure, but I think that's one of those idiosyncrasies that is quite specific to TB that does often cause quite a bit of befuddlement among our community colleagues. So when we talk about the epidemiology of TB infection, I was very interested when I first started working on TB years ago to figure out, people would often toss around the number of somewhere between a quarter and a third of the global population was infected with M. tuberculosis. And I went back and tried to find the original reference and found myself completely unable to do so. However, in more recent years, we've had some very nice modeling studies done by James Seddon and colleagues that sort of used the 25% of the global population as being infected as a jumping off point to modeling what does a situation look like for children with tuberculosis around the globe. And what they did was they actually looked at 22 countries that form the countries that are the highest risk for TB disease, that account for about 80% of all cases globally. And sort of modeling the population structure of those countries and the epidemiology of TB in those 22 countries, they estimated that about 15 million children shared a household with a person with infectious TB. And this is defining a child not in sort of the more expansive way we often define it in the US, but defining a child as less than 15 years of age. And what this worked out to was they estimate that about 7.5 million children are newly infected with TB annually, with a prevalence of over 50 million children who are infected. Now, what does this look like in the US? And I think this is far more challenging. There are some countries that require mandatory reporting of TB infection to the state and to national public health authorities, but there is quite a bit of variation from state to state. So the most recent data I could find were actually from a couple years ago, where it's estimated that about 3% of the US population actually has TB infection. Some of the numbers from prior years might not be quite as accurate because it was based on tuberculin skin testing data rather than the more specific IGRAs. So when we think about, why do we treat TB infection? And this is a conundrum we often face with families. A family has been, there's a child who's been around a family member who has suspected or confirmed TB. We see the child in clinic. We do a chest x-ray that looks great. The child is asymptomatic. The child has a normal physical examination and has a positive skin test or IGRA. And now we talk to the family about why the child needs therapy in the wake of just having told them that everything is normal that we have back so far. And so, the way I normally explain it, just in case the wording is helpful when you're explaining things to families, is that the risk of developing tuberculosis from untreated TB infection is highest in infants in the first year of life. We often think about the person living with HIV. We think about the adult patient who's on TNF-alpha antagonists as being the highest risk patient. But in reality, there's nobody who's at higher risk than a young baby. And we know that if untreated, almost 50% of those kids will go on to develop disease. And about 20% of them will actually develop CNS tuberculosis. that risk wanes throughout childhood. And in the early elementary school years, that risk is lower than it is in any other time point. And then it increases again during adolescence. And for reasons that we don't understand particularly well, that rise is actually somewhat more common in adolescent girls than it is in adolescent males. We know furthermore that the identification of TB infection in a child is a sentinel event because it's a sign of recent transmission to community. And the example I use with my patients is my grandmother's 92 years old and grew up in Cuba. If we do a skin test tomorrow and I go tomorrow and she's positive, we have no idea was she infected as a young kid in Latin America or was she infected last week. And so certainly in kids, because they've had less time on Earth and they have more decades to benefit from preventive treatment, the decision to treat a child, I think, and I'm speaking purely as a pediatrician here, I think is a lot easier than the decision to treat an adult. And we know about half of that lifetime risk occurs in the first couple years after infection. And we know furthermore that therapy is both very safe and very efficacious in children. And so when we think about how did a high incidence country become a low incidence country, I think looking at US history dating back 120 years is actually very helpful. So back in the 1930s, at the start of the Great Depression, the United States had an incidence rate of about 100 per 100,000. So when we look at that red line that's drawn on the graph, actually is indicative of how CDC and WHO actually define low incidence countries from a TB standpoint at less than 20 per 100,000. And how did this work? Well, we noticed decreases in incidence rates even before the advent of any effective chemotherapy for TB. And this was thought primarily to be due to improvements in nutritional status, potentially less crowding. And then you had an uptick in the early 1940s. And this uptick was very much related to the fact that when men tried to join the US military following Pearl Harbor, they had mandatory chest x-rays that were done. So there was surveillance bias and you had a big bump in the number of cases. Streptomycin became available in the early 1940s, but really the first oral well-tolerated medicine was INH in the 50s. And it was really through some of the US Public Health Service trials and the widespread use of INH that it really dropped our rate below 20 per 100,000, really for the first time in the late 1960s. So why don't we do a better job for this, both in certain populations in the United States and certainly globally? And I think that to think about this, we need to think about, where are all the places that things can go wrong? So we often talk about the cascade of HIV care and, the number of people who drop off between getting tested and getting the results of those tests and getting started on treatment. And really TB is not all that much different. So when you think about one barrier is failure to identify who needs testing, right? So with the move toward targeted testing, it was a wonderful move in terms of getting rid of false positives. However, it's predicated on a really important assumption, and that assumption is that kids have a medical home, or frankly, that adults have a medical home where they can, be screened for risk factors and then tested if appropriate. And we know, certainly practicing in Houston, we have one of the largest populations of uninsured children of any county in the United States. So the assumption of a medical home is a really poor assumption without subsequently verifying it in our population. The second is that there's an American Academy of Pediatrics risk questionnaire that has been derived and validated that is very useful. However, there's slowness and uptake to that. And when you think about all the things that pediatricians have to do at an annual well-child visit, you can see where it would be easy for things to slide by the wayside. So what would a potential solution to this be? It would be thinking about screening in non-traditional settings, school-based screening, community-based screening. So take the test to the kids, don't make the kids go to the tests. A second barrier is a failure to test appropriately. Jeff and I did a survey of North American infectious disease providers a few years ago and actually queried ID providers about use of interferon gamma release assays. And it included both providers in the US and Canada. So it wasn't like we were doing the survey in places that IGRAs might be unavailable. And the uptake was incredibly low. So if the uptake is that low among specialists, one can only imagine what the uptake would be among general pediatric providers who really should be the ones who are driving the majority of these tests. Also, the failure to test appropriately means that tuberculin skin tests continue to be, frankly, overused in the pediatric population, and overused in part because of all the ways that a tuberculin skin test can be misinterpreted. And obviously, a potential solution here would simply be a wide-scale shift to use of and replacement of tuberculin skin tests by IGRAs. So even once you get a diagnosis done, there's sometimes reasons that families might not say yes to treatment. And I think that we underestimate often our power as healthcare workers in terms of convincing parents or not convincing parents to do something. And the reality is we can spin any TB medication in a way that there's no way a family would say no. And there's also ways that we can really perseverate on side effects that are incredibly rare in children, such that any reasonable parent would say no to preventive treatment. I think among our children who are foreign born, failure to talk about impact of the BCG vaccine is very much to the detriment of good decision making on the part of our families. Many of our families have had the fixed belief that because my child got the BCG vaccine, he or she will be positive for TB tests at any point in the future. And because IGRs haven't had as much uptake into countries that use BCG, that conversation really hasn't changed with the advent of IGRs. So really talking up the importance of IGRs in terms of being more specific, the tuberculin skin test is really important. And furthermore, the lack of treatment of LTBI internationally means that you're really sort of swimming upstream in a family that's recently come across to the US, because again, that's a paradigm change for that family. So we spent a lot of time at the first visits really focusing on caregiver and provider education, giving them materials that are in their appropriate language at their appropriate reading levels and are very pediatric focused. And I will routinely tell families, if you get on your phone and you Google isoniazid, you're going to find a whole bunch of stuff about the fact that INH might not be well tolerated if you're a 95-year-old alcoholic with Hep B. And it's important to sort of counterbalance that with the fact that we're talking about an otherwise healthy 2-year-old who presumably has minimal to no alcohol consumption. And lastly, I think that we sometimes fail to anticipate barriers to therapy. So I try to think about what can go wrong between me giving a family a prescription and then being able to fill that prescription and the pill getting in the kid's mouth. So what does a prescription mean? It means a family in Houston, since we have no public transport to speak of, it means they have to have a car. They have to get to a pharmacy. They have to understand the concept of refills, which are very much an American concept, so that they know that at the end of one bottle, they have to go back to that same pharmacy to refill medications. They need to be able to afford the medicine. They need to have a stable enough social environment that the medicine is being given as needed. And they need to have systems in place to talk to us in the event that those kids have problems tolerating the medication. So it's all those stars really have to align for things to go well with therapy, even for a motivated family. So that's one of the reasons that in our clinic, if at all possible, we really do prefer to have children receive therapy via the health departments because it takes so many of those barriers off the table for our families. And so when we think about this, there are so many ways that we can help our families that have nothing to do with the regimen selected, but have a lot to do with all the other variables that factor into this. So we'll start with the mechanisms of testing for TB infection. So who does the American Academy of Pediatrics recommend testing? So obviously universal skin testing or universal IGRA testing for that matter is no longer recommended and hasn't for probably 2 decades now. Similar to adults, we do recommend that PPDs, and used synonymously with IGRAs in this slide, should be done before initiation of any immunosuppressive therapy. And this includes prolonged systemic corticosteroid usage, not inhalational steroids, and specifically TNF-alpha antagonists, where the risks are the same in children than they are for adults. Annual test of infection should be performed in those who are HIV infected or have contact with the criminal justice system. Q2 to 3 year testing should be considered in children who are high risk. So that would include, for example, children who might return to either their country of origin, their family's country of origin, and that happens to be a high risk country. And then obviously immediate test of infection should be performed as part of contact tracing if there's a concern for a clinical concern or radiographic concern for TB. As part of immigration, where now we've pivoted really to moving to using IGRAs in this setting, or children with other risk factors. So I had alluded to the American Academy of Pediatrics risk factor questionnaire on an earlier slide, and it's really a nice 4-question screen. And there is some collinearity between the variables. So if a child's received the BCG vaccine, odds are greater than not that they were probably born outside the US. But usually I ask this question in terms of, was your kid born outside the US, received BCG vaccine, or have they had a family member with TB? And that really gets all these risk factors. And any one of these being positive should really prompt you to offer that family a test of infection. Obviously, the more factors you have that are positive, the specificity of any positive result goes up, whether it's a skin test or an IGRA, but you also, of course, take a hit in terms of your sensitivity. Skin tests, I'll be honest with you, drive me a little bit crazy. And in part, it's because of the variation in how they're reported. I cannot tell you how many children are referred to our clinic, not by health departments, but by others in the community, and the test of infection is simply listed as positive. This is problematic for IGRS as well, where sometimes having a sense of the magnitude of the positivity might be helpful to us, but is particularly problematic when it comes to TB skin testing, given the sliding scale that we use for positivity. So I have small strokes when I see a skin test reported as positive or negative, because sometimes as you dig more into the history, what you thought might be a negative skin test based on the numerical value might in fact be positive once you get additional information on what's going on with the family. I do tell families, if I'm reading the skin test at 48 hours, that any induration that occurs after that also counts toward the total. Remembering that tuberculin skin tests measure delayed type hypersensitivity reactions, and some people simply have a very delayed type hypersensitivity reaction. I do tell my colleagues in the community that if the child blisters to one skin test, it's not that you had a sort of expired tuberculin solution, and if you put it on the other arm, it's pretty much guaranteed to also blister in that setting. And the reality is that as the TB incidence goes down, it's illogical to think that comfort with placement and interpretation of skin tests would somehow increase in a provider pool that is doing these tests with less frequency, or certainly seeing positive results with less frequency. Furthermore, even if you know how to read the skin test, there can sometimes be gaps between accurately reading a skin test and then knowing what to interpret about this. So when you think about it, there are not a lot of tests in medicine that the results of the test are considered positive or negative, not as a standalone feature of the test, right? But that you have to integrate this into, medical comorbidities as risk factors and epidemiological risk factors to help sort of modulate how you interpret that test. And when you think about it in that context, then it becomes a little bit, I think, easier to understand why people who don't do this all the time might be a little bit befuddled by skin test interpretation. So, what I tell my learners when I'm talking to them is what we do is we shift the cutoff of the test so that if you have no risk factors, we want the test to be incredibly specific. So we set the cutoff quite high. If you have a lot of risk factors or you think you might have TB disease, which we know makes you allergic to TB skin testing, then we set the cutoff very low because what we want to do is we want to optimize the sensitivity of that test. The middle category really relates to a lot of the children we see here in Houston, and it might very well relate to a lot of the children that you take care of in your clinical practices. And this includes younger children, children from high-risk countries, and it's frankly easy to remember low-risk countries. So low-risk countries are US, Canada, Northern Europe, Western Europe, and Australia, New Zealand. That's it. Everywhere else is considered high risk. And again, kind of having to go through this multi-step process for skin test interpretation can be confusing to folks who don't do it all the time. We also know that there are limitations that are intrinsic to the TB skin test that have nothing to do with provider variability. And this includes the false positives that we see from non-tuberculous mycobacterial infections and from the BCG vaccine, and false negatives that we see in our immunocompromised patients, either kids with primary immunodeficiencies or those children who we make immunosuppressed in order to treat their underlying disease. Furthermore, there are studies from places where children have quite stable medical homes, indicating that up to 20% of children do not return for skin test interpretation. So what does this lead to? This leads to a situation where a child might have a skin test replaced repetitively because they did not come back in that 48 to 72-hour window. And there, you do potentially increase, at least the theoretical risk of boosting for that population. And frankly, until about 15 years ago, we lacked any confirmatory tests. So I wrote this editorial with a friend of mine several years ago about sort of, why should we think about retiring the TB skin test and moving sort of wholesale over to the use of interferon gamma release assays. And I bring this up mostly because I think that this provides a wonderful opportunity for us to be able to improve our practice and standardize our care. So IGRAs are blood tests that detect a host response to TB-specific antigens. The two that are commercially available include the T-spot and the quantiferon, and they offer several potential advantages over the tuberculin skin test. One disadvantage is that it assumes that it's easy to get blood from a child. So for those of us who have practiced at facilities where we as physicians are responsible for the blood draw, I will say that it tends to go far more smoothly when it's not a physician behind the butterfly needle, especially if it's kind of a chunker of a child like we see on the bottom left of this slide. Now, that need for getting blood aside, there are a lot of advantages to IGRA usage. So what are some of these advantages? Number one, IGRAs have fewer antigens that are included in the test. So when we talk about tuberculin skin test as purified protein derivatives, it's important to remember we talk about it being purified in terms of you're not getting an infection from getting tuberculin solution injected intradermally. We're not talking that it's purified in terms of it contains antigens that are purely found in Mycobacterium tuberculosis. So what does this mean in terms of IGRAs? What it means is that it probably, it doesn't, and I apologize, there's, I apologize, I thought that had to up on the slide and I did not. What it means is that you don't so much see a bump in your sensitivity, but you do see a dramatic rise in your specificity because you're offloading a lot of false positives that you would be seeing in children who've received the BCG vaccine and children who've been sensitized to non-tuberculous mycobacterial infections. One of the ways that children are commonly sensitized to non-tuberculous species is through eating, I'm just going to say non-food items. So we know that all children go through developmental stages where they put a lot of stuff in their mouth that just happens to be around, and it's a way they explore their environment. And I'll never forget the first time I babysat one of my nephews. I turned around one moment to answer a phone call. I turned back around. He had crawled over the dog food bowl and was eating kibbles and bits. And all I remember thinking was, oh my God, thank God my sister's not here. She would kill me. But I think it goes to reflect the fact that this is not an uncommon occurrence. And I'm sure that your children have never put anything that's not food into their mouths, but other people's children do with some frequency. So this really kind of helps increase the specificity, particularly in kids. The other thing that's nice is because this is a blood draw, the kid doesn't have to return for the results of the test. You need to have a good way to contact the family, but it's not, the interpretation of the test is not predicated on them coming back to your clinic. So one of the questions that comes up is, what about indeterminate IGRAs? When these tests first came out, some of the case reports indicated that as many as 30% of the IGRAs were indeterminate. And really drawing blood in a child, because it's not as easy a proposition as in adults, if a third of the time you can't get an interpretable test, that would really change how you think about using these tests. However, in more modern tests that have been done, and as we standardize specimen handling, particularly for quantiferons, the gentle shaking and inversion of those tubes, so you're mixing blood with the antigens that are built into the wall of those reagent tubes, has led to well under 4% indeterminate rates being documented in more recent pediatric studies. And for T-spots, actually the rate is well under 2% of uninterpretable findings. So how do we know how to interpret these tests? Sort of the easy scenario is what those of you who take care of adults might deal with more often, which is that you compare the skin test results and an IGRA result in a patient with microbiologically confirmed TB disease. And the reality is those studies are hard to do in children, in part because most kids have negative cultures, and because it really only lets you look at the performance in those with disease and not in those children who just have risk factors. So there's a mechanism, or there's a statistical methodology called latent class analysis that lets you really look at how do you determine a gold standard where a gold standard does not currently exist. And what they did for this was they used this modality to look at what's the positive predictive value of the different kinds of tests based on the children's epidemiological risk factors. So what they found was that a positive, so positive predictive value is true positives over true positives plus false positives. And what they found was for the tuberculin skin test, the positive predictive value was about 58% in HIV negative children who were foreign born. And the quantiferon and the T-spot were both in the high 90s. If you look instead at children who had received the BCG vaccine, you can see that the positive predictive value is about 10% in that population, because almost all of your positives in young children will be driven by the false positives caused by the BCG vaccine itself. So, this is sort of some early data from a couple years ago, really showing the added value to IGRA usage. So what does this data mean kind of in summary? It means that, for foreign-born kids who are greater than 5, skin test had about the same performance as a coin flip for predicting latent TB infection, but both the IGRAs actually performed quite well. For foreign-born kids who are less than 5 years of age, where you might anticipate that the BCG response might be much more prominent, that almost all positives on the TB skin test were deemed to be false positives. So, what would be an approach to testing that one could think about using? And again, I think this is a helpful graphic, because when I think about what my colleagues in community pediatrics do, I realize that there's no way I could ever do what they do. They have to screen for so many different things in a crunched amount of time when they're seeing children in clinic. So an algorithmic approach, I think, for folks who don't do TB evaluations all the time, is actually quite helpful. So first thing, ask about TB risk factors. If they have no TB risk factors, either medical or epidemiologic, and that's in box 1 on the slide, then you can just stop there. Epi risk factors really relate to what is the likelihood that you've been around somebody with TB disease. And then your medical risk factors really relate to, if you're infected, who is at high risk of rapidly progressing, right? So the risk factors kind of fall into those 2 buckets. So if they have positive risk factors on your screening questionnaire, do a test for TB infection. More and more, again, we are trying to urge people to use IGRAs rather than tuberculin skin test for this. If the test of infection is positive, you need to go ahead and obtain a chest x-ray. And I would say that if the chest x-ray is abnormal, or there are other symptoms that are concerning for TB disease, such as lymphadenopathy or other, pleural effusion or something like that in children, that's when I think you really need to reach out to folks for help. Please recognize that in the US, only about 6% of all cases of TB disease actually occur in children. So outside of large centers, such as Houston or Los Angeles and places like that, even the infectious disease expertise, those folks are not going to see as many cases as people would in high incidence countries. So it's not silly to reach out and ask for help at any point in this course. If the chest x-ray is negative, the child has no symptoms and has a normal exam, then you can discuss therapeutic options with families, and we'll talk about sort of what that looks like. So in terms of just IGRA usage, I caught the tail end of Jeff's talk when somebody was asking questions about the Red Book recommendations for IGRAs. So for those of you who are not primarily in the pediatric domain, the Red Book is sort of our Bible of pediatric infectious diseases. And the 2021 Red Book came out at the end of last month. And it says that the tuberculin skin test is recommended for children down to 2 years or under 2 years of age, but IGRA use is acceptable. So the guidelines for IGRA usage by age have actually become far more permissive in subsequent generations of the Red Book. IGRAs remain the preferred test for children who are BCG immunized. And for children who are immunocompromised, it's just important to recognize the limitation of both tests in a child who is profoundly immunosuppressed. And namely that a test can be trusted if it's positive in a profoundly immunosuppressed child, but that a negative test in that same child should not offer you any sort of false hope that the child is uninfected. So what about, so you've now finally gotten to the standpoint of you've gotten the family in a clinic, you've gotten a test of infection, you have that test of infection result back, and it's positive and you want to talk to parents about treatment. This is, again, going to very much focus on the pediatric realm because the risk-benefit relationship might very well be different for those of you who take care, especially of older adults. So what do we do in our clinic? We have very much sort of absorbed the concept that adherence is very proportional or inversely proportional to the duration of therapy. So we have loved using isoniazid and rifapentine once a week for 12 weeks. We can only use this down to 2 years of age, in part because there's no pharmacokinetic data for younger children in IGRA usage, or excuse me, and rifapentine dosing. It does require DOPT. For our next dose, or our next preferred regimen is 4 months of rifampin. This is an expensive medicine if kids are uninsured. So in the Houston area, it would cost a family about $200 a month out of pocket if they're uninsured, even though it's an old drug. And obviously we need to be very cautious about drug interactions with this regimen. We have not had a lot of operational experience using daily INH and rifampin in our center for a 3-month course. That said, there's incredible amounts of operational experience on using this regimen in the UK. And it is one of the CDC endorsed regimens in the newest guidelines. And lastly, we pretty much use INH as a last resort these days, and it's usually a last resort because of drug interactions that the kids are on, because we know if given by the families to the child, adherence is less than 50%. So then the question is, just because you've always done it that way in terms of INH doesn't mean it's not incredibly dumb. And when we had no other options, then sometimes you're left with suboptimal alternatives, but now we have options. And just so you guys are aware of the data behind those other options, the study on which the first pediatric endorsements were made for INH and rifapentine were actually based on a study, the PREVENT RCT study, which included 900 kids from a host of different countries. It was a multi-continental study. And what they found was that treatment completion was substantially higher for 3-HP than for 9 months of INH. I will point out that if I could get 81% completion with 9 months of INH in our setting, I would be thrilled. And it's also important to remember that adherence is usually higher in studies than it is in real world populations, because you provide families a lot of support in the context of a clinical trial. Also important to recognize that drug-related hepatotoxicity was not seen in this study. It's incredibly rare. They enrolled 900 kids. With such a rare outcome, it's not uncommon that it wasn't seen. So really the reason for picking the regimen is not so much a question of toxicity. It's a question of regimens are more effective if they're actually taken. What about in more real world practice? So we wrote this up with our first 80 kids that we took care of. 99, we only had one kid who didn't complete therapy. And side effects were uncommon, and most of the most common side effect was nausea and vomiting with normal liver function tests. While a flu-like illness and rash has been reported commonly in adults who take INH and rifapentine, this has actually not been our experience on the pediatric side at all. And in something that completely panicked me, we actually had an adolescent who developed cavitary TB 7 months after completing 3-HP. However, upon talking to her, she admitted to cheeking the pills and not taking them, because I was really worried, since we had a small sample size at the beginning, if we already had a child fail on this. And again, this gets back to the idea that no regimen works if you don't actually take the pills. What about looking at this, the safety of 4 months of rifampin, for example, compared to 9 months of INH? And this study included about 830 children. This is one of Dick Menzies' studies. It actually showed the completion rate was higher for rifampin. Again, not surprising given the shorter treatment duration. And no hepatotoxicity was seen in either arm of the study. So again, these regimens are very safe in children. The reason to pick one regimen over another is not secondary to safety, it's secondary to adherence. And this was one, we did a retrospective cohort study looking at our experience in clinic with about 400 kids. This data was collected several years ago, where we were very reliant upon isoniazid still, and about 80% of kids in our cohort got INH. And what we did was, when we compared rifampin administered by the family to INH administered by the family, kids were 8 times more likely to finish rifampin than they were INH, unless you got the health department involved, right? And so sometimes I think, we underestimate, or I certainly, I don't underestimate, I probably have no true perception of the cost of DOT that is administered by my health department colleagues. So if DOT is not an option, certainly I would move to shorter course regimens. And what we found was, when we looked at different regimens and we looked at what was associated with completing therapy, the only thing that was associated with completing therapy was administration of medicines via our health department colleagues. So, this was a very pivotal moment for us in terms of saying, why, if the health departments can do this service for our kids, why on earth wouldn't we avail ourselves and have our families, more importantly, avail themselves of that resource? And again, when we looked at our experience, looking at all 3 of the regimens head to head, again, this was not randomized, and we found that despite extensive education, and we probably chat with families for 30 minutes in clinic before we start them on LTVI therapy, no matter what regimen we select. And I'll be honest, I looked at these results and I was incredibly disheartened to think that despite are really trying to emphasize to families why this was important and why this was safe. That about half of families who were given self-administered INH completed therapy. And look at the numbers that we had for any other regimen. And this has really led to a shift for us in terms of both the test that we use, and we're much more reliant upon IGRAs now than we were 5 years ago. And it also has really dramatically changed what we use in terms of our regimens that we select. And what I do is I talk to families about all of this, and I talk to them about all the regimens that are available. I tell them what I would recommend if I were taking medication, and then I leave it up to them. So we do shared decision making. Now, that said, I have yet to have a family who tells me, I'd really like my kid to be on a 9-month regimen compared to 12 doses. And usually the way I talk to families about this, I say one regimen has 270 doses, one regimen has 120 doses, and one regimen has 12 doses. And I no longer am any good at any kind of higher order math, but you don't need higher order math to understand those calculations. And I think this is particularly important when you're talking to families about 3HP, because the pill burden from 3HP can be significant. And what I would say is this, and this is what I tell, I really try to emphasize with our residents when we work with them in clinic, because those are the folks who are on the front lines and might be selecting regimens with families in their clinic in most settings. That if you're reaching for INH as your first line treatment, the question you should be asking yourself is why? Why am I reaching for this? Because the reason of, well, this is what I learned in med school is a horrible reason, especially when we have regimens that are shorter and just as well tolerated and just as efficacious. So what are the reasons I use INH now? The most common reason I use it is because the kid is on medications already that would interact with rifampin. And this includes some anti-seizure medications. It includes a lot of psychotropic drugs, includes many immunosuppressive agents. Working at a quaternary care children's hospital, we get a lot of referrals internally for children who test positive, who are being seen by the renal service or the GI service or some other service. And these kids are often on a host of medications. So that's probably the most common reason we reach for INH, is because drug interactions really prevent us from using rifamycin. And the second is if the parents don't want DOT, and this is happening less and less often with more health departments doing VDOT, and they cannot afford rifampin. We have not yet done as much in terms of self-administered 3HP. And I admit to sort of my own concerns about this, even though there's a nice study that was published in adults showing that adherence with this was still better than it was for INH. And my concern with this is just that we're unaccustomed to taking medicine once a week. And it's that dosing schedule, while it's easy in terms of the number of doses, the frequency of the dosing poses a challenge to families remembering the doses. And the pill burden is so high that it would certainly be nice to have another set of eyes to make sure the kid didn't spit out those medications. Because if they have spit up doses or missed doses, and you miss one dose, you're out 8% of your total treatment course. What are some caveats? So often when a child has problems with a medication, the issue is often with the parents. And what I mean by this is that if a parent understands the reason that a child needs the medication, they might go to further lengths to make sure that the medicine gets into their child. If they never believed that the kid needed the medicine in the first place, and the kid makes a face the first time you give them a dose of INH or rifampin or anything, it's easy for parents to be like, maybe Johnny doesn't actually need this medication. Second is isoniazid, whether you're using it as monotherapy or part of 3HP. The suspension is sorbitol based. And this is certainly the one that's available in commercial pharmacies in this area. So what's the problem with sorbitol? Well, sorbitol has a lovely taste, and the sweetness to it makes it easy to get it into the kids. The problem is getting it out of the kids. And by that, I mean that when it hits the intestines, it draws in water and the kids are just pooping their brains out. So you can get around this by giving the kids crushed tablets, but it is important to explain to parents why you're writing for a tablet for a 9-month-old child who clearly cannot swallow pills. But once you explain that you're really trying to attempt blowout diarrhea on the part of the child, the parents become very, very amenable to crushing the tablets. Jeff talked about for children with TB disease, the fact that it's not necessary to obtain baseline and zero LFTs. And that's the same thing for latent TB infection. Probably the most common reason I obtain LFTs in the LTBI children I see is in either children who are on other hepatically metabolized medications or children with obesity. We know that children who have non-alcoholic hepatic steatosis can often have bumps in their LFTs up to sometimes about 100. That doesn't change my decision to start them on meds, but it is important to know what that baseline is. Because let's say that child comes in with abdominal pain and you think it's probably constipation, but it's abdominal pain in a kid who's on a potentially hepatotoxic drug. So you stop medicines and you check LFTs, and those LFTs are 100. If you don't know that their baseline was also 100, then you're kind of in a bit of a conundrum because those LFTs are 2 to 3 times the upper limit of normal for a child, and they're having symptoms, even if you don't think those symptoms are actually being caused by the medication. So that's why I obtain baseline LFTs in my obese kids. And then I tell the families, if there's a problem with the medication, you stop the medicine and then you call me. Because the last thing you want is for, you're heading into a Friday of Memorial Day weekend, the kid starts puking, and you don't want the family to continue giving whatever medication over the holiday weekend until somebody has a chance to return their call. So in conclusion, we know that IGRAs can identify the children who would receive most benefit from treatment, again, by eliminating those false positives due to BCG and non-tuberculous mycobacterial exposures. And this is one of the reasons that we've really, as we become more comfortable with IGRA usage and we go to younger and younger ages with IGRA testing, and as we change immigration guidelines to integrate IGRAs, I think this is going to offer us a lot of benefit and is going to not expose children to TB medications who would not benefit from treatment. Right, so that might seem a bit antithetical to what I just said, because I just said about how safe TB drugs are. But when you're weighing risks and benefits, if a child never had TB infection and you're treating him for what's potentially a falsely positive TST, if they have no benefit from treatment, all they're seeing is the potential risk. Important to educate families, educate the providers in our community about shorter course options. Pull in resources to help families succeed. And I will say, as a blatant plug to our local health departments in the greater Houston area, they do an amazing job of working with our families. They bend over backwards to work with family schedules, and really the use of VDOT has, I think, been instrumental. And I'm going to give the talk on adolescents momentarily, but our adolescents love VDOT. They no longer have to wake up at 5 o'clock in the morning and try to get a little bit of food in their mouths before they swallow pills. It enables us to, VDOT or in-person DOT enables us to not only help with medication adherence, but enables us to, make sure the kid's doing okay on the medications. And then there are all those indirect ramifications to being able to see a kid in terms of safety, particularly in pandemic times. And, similar to Jeff, please feel free to reach out to me with any questions or concerns. I put all my numbers there. If you guys could not send me text messages at 2 o'clock in the morning Central Standard Time, I'd be highly appreciative. But please do feel free to reach out with any questions or concerns that you might have. With that, I will stop. I know I'm running a little bit early, Delphina, but I wanted to make sure to leave time for questions.
Yep. So just a quick note, we're going to switch with Dr. Armitage's talk. So Dr. Cruz will continue with adolescent TB after this talk. But if you have any questions for this presentation, please use the Q&A pod. So
I'm going to start. So Sandy had asked about difficulties with getting little kids to take medications. So I am a firm believer that the key to getting toddlers to take medicines is a combination of bribery and trickery. So what I like doing is I like mixing medicines out of the sight of the child. If you are going to be using a rifamycin-based regimen, especially if you're unscrewing rifampin capsules and you're mixing it into food, recognizing that will cause discoloration of the food item. So if you mix it, instead of mixing it with vanilla ice cream, if you mix it with chocolate or with strawberry ice cream, you camouflage things a lot better.
Oh, gee.
Yeah. I love chocolate syrup for administering medications. That might simply reflect my own absolute love of things chocolate. But the strong taste of chocolate actually masks a lot of flavors. You will occasionally have the oddball child who does not like chocolate. And while I can't actually understand this, I have had good success with Nutella because a lot of kids who don't like chocolate do like hazelnut. And this part of the presentation is clearly not being endorsed by any kind of nutritional organization that's out there. But mixing it out of the sight of the kids, mixing with something sweet. And then if the families do want to mix with some liquid, I just say don't mix it with a whole sippy cup of liquid, because then you have to sit there waiting for the kid to drain the sippy cup. But I leave it very open to families. You want them to mix it with something the child likes. If the kid is not a vegetable fan, deciding to sprinkle rifampin granules over a piece of broccoli is going to be completely doomed to failure. And there is another question regarding the youngest age for T-spots and IGRAs. And so, what I will say is this: there's no age where it's too young to do an IGRA, whether it's a T-spot or a QFT. The issue becomes very much the same as the issue of tuberculin skin tests. So if you have a 1-month-old and you do any test of infection, again, I consider 1-month-old to be a functionally immunocompromised patient because their immune response is not that of an older child. So those tests are helpful if they're positive, and they're not helpful if they're negative. So there's no age where I would disregard a positive IGRA. But there are, usually people say somewhere between 4 and 6 months, you can start trusting the tuberculin skin test. We actually don't have additional different data on IGRA usage. Just when the first studies came out, and we did this in collaboration with Kim Smith over at UT. One of the things that we realized was that parents were very, very willing to let you stick their older children for blood. And frankly, once they hit the teenage years, you could use that kid as a pincushion. A lot of times the parents would be like, you go have at it. But they were relatively reluctant to enroll younger children. So a lot of the hesitancy to use it in the younger kids is not so much because we have data that it doesn't work. It's just we don't have as much data as we do for older kids. And I hope that helps answer the question. And I do apologize for my dogs who attempted to interject themselves into the Zoom call.
If you have any further questions for Dr. Cruz, just go ahead and use the Q&A box, and we'll go ahead and continue with the next presentation.
All right. Hey, Delphina, are we taking a 5-minute break, or are we continuing straight through? Because I know that there was originally a 5-minute break on the schedule that I was given. I'm happy to do that.
And you are correct. Yes.
Okay.
Are you okay with just a short 5-minute break, Dr. Cruz? I know you had to.
Yeah, no, I'm totally fine with it.
Okay.
Absolutely.
All right, everybody, then let's meet back in 5 minutes. So 2:41.
Okay. And what I'll do, Delphine, is I'll just share my screen for the next talk.
Okay, sounds good.
Well, I'll try to share my screen for the next talk. Let's see how that goes.
All right, everybody, we're going to go ahead and continue with our next presentation, which is also presented by Dr. Cruz on adolescent tuberculosis.
Awesome. Thank you, guys. I have developed no interim disclosures since 5 minutes ago when you last saw me. So in the course of the next probably half hour or so, we're going to talk about what are some of the differences between adolescents and younger children, also between adolescents and adults when it comes to TB issues. We'll talk about sort of how do these kids present and what are some strategies that for those of you who take care of adults and those of you who predominantly take care of younger kids that we need to carve out specifically for adolescents when it comes to TB care. So what is the adolescent conundrum? So the conundrum in part is because a lot of times adolescents present with many of the radiographic and microbiologic features of TB in adults. But when you go to treat them, you have a lot of social considerations in terms of, some issues regarding potentially lack of thinking things through to their full conclusions and substance abuse issues and things like that that might be very different from both the younger child and the adult patient. So you kind of have to straddle a line between taking care of these kids. And the reality is that, depending on the age of the adolescent and how old your clinic takes patients until your hospital, the age cutoff for what is defined as a child in your hospital, these kids are taken care of by both adult and pediatric providers. So I think this is a population that is relevant really for anybody who does TB that's a bit more agnostic to the usual age population that you might care for. So what do we know about the epidemiology of childhood TB in the US? And I'm sure Jeff went through some of this when it came to TB disease. But some of the most recent data from Texas from 2020, there were about 900 cases of TB. And of these, about 3% occurred in young children, 3% in sort of primary and secondary or primary and middle school children, and about 11% in the high school population plus early adults. And when we think about this, this very much, it's a bit overrepresented compared to the percent of the population. And why is this particularly important? We know that as kids get older, it is harder and harder for them to qualify for Medicaid. So more and more of these children lack a medical home. We know that the percentage of children of adolescents who live in poverty and the federal poverty line this year is less than $26,500 for a family of 4. We know that adolescents are more likely to be impoverished than younger children. And again, they're more likely to be uninsured. So when you combine lack of access to care with the fact that oftentimes, these children are quite contagious, it does lead to a really different conundrum than what we deal with younger children. We talked a little bit in the last talk about, the risk of progression to TB from infection to disease by age. And we talked about how that risk is highest in infancy and then sort of slowly dwindles until you hit puberty. And then the rates go up a lot higher and they go up higher in boys than in girls. And the risk of developing, and it's almost exclusively pulmonary TB in adolescents, is somewhere between 10 and 20%. So substantially higher than it is for young adults. The picture I have on the right side of the slide is actually an adolescent with diabetes who actually had very, very prolonged cough and weight loss. And the weight loss was attributed to the very poor glycemic control that this patient had. And the cough had actually been attributed to fairly significant smoking of both tobacco products and marijuana. And so, both those symptoms were chalked up to other etiologies. And it actually took a while before this kid was diagnosed and had, obviously a grossly abnormal chest radiograph. So what do we see in terms of chest x-rays in adolescent TB? So certainly compared to younger children, we're far more likely to see cavitary lesions. We're more likely to see pleural effusions. And these pleural effusions are usually, they easily layer out. They're not septated. So they look very different on ultrasound CT and frankly on a decubitus x-ray than what you would see with a pneumococcal or staphylococcal empyema. And you are more likely to see fairly extensive parenchymal disease. So, often in the young kids that we see in our clinic who we diagnose with pulmonary involvement or interthoracic involvement, the kids are pretty asymptomatic. They might have some bulky lymph nodes, and that's pretty much all they have. And the older kids, and whether that's, an issue of more rapid progression, whether it's an issue of delays in diagnosis or delays in accessing care, it's hard to say. But compared to our younger children, many of our older children actually have substantially more parenchymal lung disease. Again, compared to younger children, they're less likely to have intrathoracic or hilar lymph nodes, and they're less likely to have miliary disease as well. And the paper that I've referenced at the bottom of the slide is out of Rio de Janeiro. However, this very much mimics what we see in TB in the United States. What about microbiologic yield? So I will admit that as a pediatrician, I am pleasantly surprised when cultures come back positive on my patients. And this is because in younger kids, if we get 20 to 30% positive culture yield, we're pretty thrilled. And we very rarely get positive smears in our children. If you're an adult provider, you're definitely going to look at this as a glass half empty, and you might say, well, I'm used to 80% of my patients having microbiologic confirmation. So again, teenagers sort of fall in the middle. Up to a third of them in some studies have actually been smear positive, and about half have culture positivity. There was a question toward the end of Jeff's talk about the use of Gene Expert, which has clearly been much more widely deployed, at least among children internationally, as compared with what's happened domestically. But there are fewer data on the sensitivity of Expert in this population, particularly in populations that might more closely mimic what we see in the US. So what do I mean by that? So, when I think about where are studies done that have high prevalence of tuberculosis, I just referenced the Brazilian study. That's a wonderful study. And there's a host of data coming out of South Africa. It is somewhat difficult as an American healthcare worker to know exactly how to integrate the South African data into our practice, because so many of those children are HIV infected and malnourished. And that's really, it makes it very difficult to generalize those findings to the population that we take care of in the United States. What about, what else has been seen in other studies? This is a French study, again, a population that more closely replicates what we might see in the United States compared to other studies. And what they found was the chest x-rays were positive in the vast majority of these children. They actually did notice quite a bit of lymphadenopathy in the study, although a lot of these kids got CTs as well as chest x-rays, where the sensitivity is such that you're going to notice little lymph nodes on a CT that you could never appreciate on a plain radiograph. And then parenchymal infiltrates were also quite common. Skin tests were positive in the majority of children. And again, almost a third were smear positive, about half were culture positive. So, I present these data from different places, mostly to show that the data are actually quite consistent from place to place. So what were some predictors of having positive smears? So this was a study out of Taiwan that included almost 80 adolescents, and having a more prolonged cough, defined as at least a month, the presence of hemoptysis, having either multilobar or interestingly lower lobe rather than apical involvement was more common in children who were smear positive, as was things that were a bit more obvious, such as the presence of cavities, and then the presence of pleural effusions, because often these pleural effusions were not seen in isolation, but were also seen with parenchymal lung disease. So I'm not going to focus much on the treatment of in terms of the regimens and the dosing, because it's very similar to the ATS and the CDC guidelines for adults. We have some adolescents who are very adult-sized, and in that case, one should definitely use the CDC dosing guidelines. We do not recommend, in general, that children go above the maximum dose recommended for adults. We do often use B6 in our adolescents, and I would say in addition to this, we would use B6 in children who are living with HIV, children who might have risk factors for being malnourished, and this includes kids with inflammatory bowel disease, and pregnant or postmenarchal females. Now, I want to spend most of this time actually talking about challenges that we face with our adolescent population and what are some potential solutions to these. And I kind of broke these up into more, to some degree, more purely medical, although a lot of these are sociological as well, and then things that are much more social constructs. And so we'll start by talking about infection control. Some of the questions that I've dealt with some of my patients is that the health department calls and they say, Andrea, do we need to do a contact investigation for this kid, this adolescent who's in a high school? And Usually I say, well, if you would do a contact investigation for an adult under the same situations based on their smear status and based on, tests of infection positivity in their close contacts, then you should do the same thing for that adolescent. And really the same principles would apply in all the settings in which we usually do contact tracing. Infection control can be more challenging at pediatric facilities. So when I think about our TB clinic, we don't have any negative pressure rooms in our TB clinic. Most children's hospitals don't have very many negative pressure rooms at all. And we've all sort of faced the conundrum of what to do with an absence of negative pressure rooms in the era of COVID. But it's been a longstanding issue in children's hospitals in general. And then in part, one of the things that we often talk to our trainees about is that most children are not contagious. And what you don't want to do is have complacency and then have people extrapolate that to thinking that all children are non-contagious. And the reality is that the vast majority of prepubertal children are not contagious. However, the moment you have a cavity, you got to treat that kid as contagious. The moment that child is able to expectorate sputum, I would then, treat that child as potentially contagious until you know otherwise. Another issue that comes up relates to that of medication tolerance. I often tell our families that nobody's liver works better than that of a otherwise healthy little baby because they haven't had a time to ding up their liver by doing all the stuff that we do to our livers as adults. It is important because we know that adolescents, when we think about how do children metabolize drugs, it's not sort of this continual linear relationship between age and drug metabolism. We know, for example, that adolescents metabolize INH and ethambutol more slowly than young children, but faster than adults. And the reality is, when Jeff was talking about pharmacokinetic data, there's really a paucity of pharmacokinetic data for adolescents, in part because a lot of times if adolescents are enrolled in studies, unless the age data are disaggregated, for some of the younger adolescents, they might actually be counted among the younger kids. And for some of the older adolescents might be counted among adult data. So for that reason, there's not as much data on optimal drug dosing for adolescents. In general, adolescents, by virtue, if nothing else, about being far more verbal than some of our younger children, are more apt to express their symptoms than a younger child would be. And that said, serious side effects of the medications remain uncommon in adolescents. It is important to discuss birth control options with all postmenarchal girls. And one way that I found to phrase this in a way that is less likely, although not impossible to annoy a family, would be to say simply that girls take birth control pills for a number of reasons, including control of their menses. And just to point out that rifampin might alter the abilities of those drugs to work. And then it becomes clear that you're not asking specifically because you think that their child is the sexually active child, but is something that we discuss with all adolescents once they're menarchal. And this would be a population under which, particularly if they're receiving multi-drug therapy, you might think about getting baseline transaminases. And again, we talked about the obese child, but this would be really more reflective of the fact that some of these children might have more social risk factors than we realize, and their liver might have taken hits from polysubstance abuse. We know that some of our adolescents are at higher risk for developing immune reconstitution inflammatory syndrome as compared with younger children. And while iris is often associated with HIV infection, we know that it occurs with some frequency in children who are HIV uninfected. And in this series by Ian Katai and colleagues at Sick Kids Hospital in Toronto, they noted that among the adolescent population, deteriorations actually occurred, or iris symptoms occurred in about 14% of the population, and were more common in children who were underweight, those who had multi-site involvement. And actually the most common site was airway compression from enlarging lymph nodes. Now that said, this was, that remained uncommon, but it was still something that was seen. And it usually occurred within about 3 months of starting therapy. Many of our adolescents lack a medical home. I will be honest with you, when I ask some of my patients, who's your pediatrician? And they say, you're our pediatrician. And I'm like, no, I'm your child's TB doctor. I am not your child's pediatrician. I have zero desire to attempt to supplant a general pediatrician who will do a much better job of looking out for other aspects of that kid's health than I am, because I'm focused predominantly on the TB piece of things. But the lack of a medical home certainly changes opportunities where children might have been, screened for risk factors and tested for TB infection and offered therapy for infection to progress or to decrease their risk of progression to disease. It changes the venues where children present to care. These children are more likely to present to an urgent care and emergency department than they are to their pediatrician. And really the fragmentation of that care, where they go to sequential emergency departments or they go to the same emergency department on different days, and they're being seen by different providers, often itself will lead to diagnostic delays. Now, that said, while I don't want to be anyone's pediatrician, general pediatrician, it does give us an opportunity when we're seeing these children or these adolescents to provide them with some primary healthcare services. We try to provide catch-up vaccines in our clinic so that those kids get those on board. Now we're offering COVID vaccines in clinic. We can screen for other diseases. Obviously, if they have TB disease, we're going to be screening for HIV. But it's an opportunity to kick the parent out of the room and talk to them about risk factors for other sexually transmitted infections, because we know that those go up highest in the 15 to 24-year-old age group than in any other age demographic. And then refer them for contraceptive help. And whether that's talking to them about an IUD or talking to them about Depo. And often it's sort of startling that you have a 17-year-old girl who's been sexually active for years. And when I talk to her about an IUD, is the first time anybody's talked to her about contraceptive options. So it really illustrates sort of, the way the system is broken and how easy it is for some of our kids to fall through the cracks. So the next thing relates to sort of polysubstance abuse and things that your kids might or might not actually allude to them taking. So I will say this is probably my favorite email I've ever received in 20 years of being a physician. And I had harped on this kid about making sure that he did not drink alcohol because he was a copious drinker and a copious binge drinker. And he remembered that. And I was very proud of him because he Googled my email address and sent me an email. And grammatical idiosyncrasies aside, he remembered that he could not drink alcohol, but wanted to know about his, ability to smoke pot. I did not respond to this email in written form. I instead said, why don't you give me a call and we can chat? So, I think, and I put this up there, number one, because it amuses me. But number two, I put this up there because it's important to have honest conversations with your patients about what they can and can't use. So if I have a kid who's taking benzodiazepines and is drinking alcohol and is smoking pot, while I'd prefer that they not do any of those things, what is most likely to hurt them in the immediate time while they're also taking other hepatically metabolized medications? Right? And the thing that's going to hurt them most is the alcohol. So it's important to have a conversation with them about, yes, I'm happy to, I would love to refer you to substance abuse counseling. But it's also important in the kid who has zero desire to stop using that you educate them about what would be most harmful for them to use if they're a polysubstance abuser. And my patients often provide me an opportunity to learn about things that I don't know about because I apparently led a very naive, sheltered childhood in Miami. And so this is a text message I got from one of my patients saying, what happened if you were taking pills for the TB and you do drugs like lean and dro just once? Which led me to say, I have no idea what lean and dro are, and which prompted a Google search. And lean is, at least in this part of Texas, is the street name for mixing promethazine, codeine, Sprite, plus or minus Jolly Ranchers, which is a significantly nauseating combination that you can see why they would have actually thrown some promethazine into the mix. And then dro is hydroponically grown marijuana. So again, this was another opportunity for education and to talk to the kid about, his polysubstance abuse and what would be most harmful for him to do while he's taking TB medications. When we think about substance use, it's interesting that the systematic screening for this doesn't occur with nearly the frequency that you would think. Some of the best studies actually occurred almost a decade ago, where they found that about 80% of high school seniors had tried alcohol, and about 15% already met the criteria for lifetime abuse. Over 40% had used any illicit drugs, with about the same percentage meeting criteria for drug abuse as did for alcohol abuse. And kind of going all the way down to prescription drugs that are certainly one of the population of substance abuses that is increasing most rapidly among adolescents. Please note that the study is sufficiently old that it did not talk about vaping. And so, vaping, whether it's nicotine-based products or other products, has absolutely skyrocketed in recent years. And the data during the pandemic indicate that in general, substance abuse, no matter what substance on this list you pick, has actually increased quite dramatically during the pandemic. And this is the case both for adults and also for adolescents in the data that are out there. And this very much mirrors the increase in visits for mental health concerns that have been documented during the pandemic among adolescents. So I think that to not take the bull by the horns and address this with your patients, when you know that 4 out of the 5 adolescents that you deal with will have drunk alcohol during their time in high school, is really doing your patients a disservice. This is another study that actually looked at use over time. It's sort of amazing to me that alcohol use was 5% among 6-year-olds in terms of the age of onset. That's frankly terrifying. And you can see that there's a slow, steady climb in terms of both overall alcohol use, frequent alcohol usage, and then abuse and dependence for alcohol. What are other considerations among adolescents? So certainly a lot of stigma. There's guilt over potentially infecting others, especially if contact investigations have to occur at their school. There's fears about the ramifications of contact investigation, and are they going to be shamed because they were the ones who were there, and then fear of classmates recognizing that all of a sudden this contact investigation is happening and the only person who's not in class is Johnny, so it must be Johnny. I do try to be proactive about addressing social media considerations. I'm amazed at some of the stuff that my patients tell me they post on their social media feeds. And this is usually after they tell me that only people my age use something like Facebook. Yes. So I talk to them about Instagram and different, modalities that might be more common in the generation below me. And talk to them about sort of, yes, you can unpost something that you post, but if somebody's already seen it and taken a screenshot of it, you can't take that back. And really talk to them about what is their own health information versus stuff that should be readily shared. And again, I'm really amazed that oftentimes I have this conversation. It's very clear that that's the first time anybody's ever talked to them about privacy considerations. This is important for multiple reasons. We know that stigma leads to increased risk of depression. Depression leads to increased risk of medication non-adherence and use of and medication of that depression by using other substances. So it's very much a vicious cycle. So the degree to which we can try to break that cycle up front with the kids, the better. I think we need to do a better job, certainly, and I'm not speaking for the community at large, but often we deal with the considerations that are in front of us in terms of treating the medical parts of a child's TB. And we know that up to a third or 40% of adults are actually clinically depressed when they have pulmonary TB. And it's unlikely that that number is far lower among adolescents. What about missing school? So I will say that some of my patients think that missing school is like the only silver lining to their diagnosis of pulmonary TB. I will also say that the children who have that belief are usually the kids who are not exactly stellar academic achievers at baseline. So, I think our health departments do a great job of doing very frequent sputum smears in the field so that we can return those kids to usual activities. We don't want those kids missing school for vast amounts of time. That's, we know, and I think this last year of a lot of people doing education remotely has very much driven home the point that in-person school is really important for kids to do, both from a social and an academic perspective. I tell them just because they're not in school doesn't mean they get out of schoolwork, and they got to coordinate with, I tell the parent to coordinate with their school to get schoolwork sent home. And then we do try to work with our adolescents to schedule them at, during spring break week, right after they let out for the winter holidays, et cetera, or sneaking in visits at the start or end of the summer so that they're not missing school needlessly, especially around those critical times like finals and the orientation to the school year. So in conclusion, we know that adolescents very much fall into that sort of the intersection of the Venn diagram between kids and adults in terms of how they present with TB, the yield of diagnostic tests, and medicine tolerability. We are currently working on adolescent-specific guidelines, and Sylvia Chang at Brown University is helping spearhead that effort. That's an international effort to sort of think about considerations that we have to have specifically for this age group, because so often they are either subsumed in the younger adolescents into the purely pediatric data and the older adolescents into adult data. And we really need data specifically on this population so we could target interventions that fit best with them. And lastly, in contrast to the younger child, an adolescent needs to be an active participant in their care. So these are the kids where I'm kind of like, okay, I just spent a while talking to you. I need you to tell me what you understood from that conversation. And to that end, that means that the earbuds need to come out, the cell phone needs to be put in a different part of the room, and they need to be making eye contact. And if they can't, and I tell them up front, I said, I'm going to go through this stuff with you. And at the end, I'm going to need you to explain back to me what you understood. And then you at least give them a heads up that you're anticipating them being an active participant in their own care. And again, for some of our younger adolescents, and for some of our older ones as well, unfortunately, that's really the first time that somebody has spoken directly to them as opposed to speaking to their parent. With that, I will stop and see and open the Q&A chat and see what questions we have. Are you guys like just zoomed out after a whole day on Zoom calls? Because that sometimes happens to me. So Sandy, no. So we actually, it's a great question about adolescence and depression. We don't, they're not studies that specifically address that. One of my colleagues, Sylvia Chang, is actually looking at that among adolescents diagnosed with TB in Lima, Peru. There's really a paucity of data on this. And again, I think it's because the adolescent data are often split between kids and adults. The data we have no data for younger kids, and the data in adults indicate somewhere between 30 and 40% of adults have depression. And, and it might vary. And, I think it's hard because the manifestations of TB are so heterogeneous that a child who all they have is a lymph node and they otherwise feel pretty good, maybe their life isn't as impacted as much except cosmetically by that lymph node, as opposed to a child who has multiple cavities, who's kept out of school for a while, waiting for those sputum smears to clear. But, I think it's one of those things that there are several questionnaires now that have been validated for adolescents that there's I think the tool is called a CRAFT tool, C-R-A-F-F-T or C-R-A-F-T-T, one of the two of them, that is actually a very short questionnaire that is very good in terms of predicting depressive symptoms. And then there's some 2-question questionnaires that have been also validated in adults, screening for ethanol and other substance abuse. So, if possible, that would be something to think about. Can you actually integrate this into your practice so that we can not just take care of the TB that we know we're dealing with, but we can try to see if we can link the kid in with other services. Again, because so many of these kids just don't have any other venues for care. If you guys have questions, oh wait, sorry, I have to scroll down. So in terms of the adolescents and the parent interaction, usually what I say is, and again, especially if a kid hasn't been receiving routine health maintenance, and the last time they got routine health maintenance was when they were 5, the parents aren't used to anybody talking to their child. I will often do this in the only 2 languages in which I speak. So if the parent is more comfortable in Spanish and the kid's totally fluent, we'll do it in Spanish. If the kid's like, fluent, then we'll do it in Spanish first so the mom can interact, and then we'll do it in English. And usually what I say is, as kids get older, at some point, he or she is going to be going to visits and you're not going to be there to provide really important pieces of the history. And for that reason, it's really, really important that he or she understands what's going on. So I'm going to ask you a bunch of background questions about his medical history from when he was little that he probably doesn't know anything about. And then we're going to talk in generalities about TB. Then I'm going to ask him if he has any questions. Then I'm going to ask you if you have any questions. And we're going to get everybody's questions resolved before you go away from here. But it is really important that your kid understand what's going on. And I have never gotten pushback from a family when I've asked that. The other thing is to make it clear that this is what we do with all adolescents, that it's not that you think their adolescent is totally squirrely, and that's why you need to talk to the adolescent by themselves, but that part of routine healthcare visits is that at every visit with a teenager, you talk to the family together, and then you talk to the teen separately. And then you make that the expectation of every visit. I hope that helps, Jill.
Dr. Cruz, there's some questions in the chat box. How do you handle school classmate contact tracing balanced with teens' privacy?
Yeah, so fortunately, I think our health departments do an amazing job with that. So when they go into schools to do contact tracing, they will say it is possible that somebody at the school has TB, and they are very careful to not say, is that a student, a faculty, or a staff member? They are careful not to reference gender and things of that nature. It is hard, like the parents, come up with all these ways that they think they're being all devious to figure out who the kid is who's sick. And they're like, well, if you tell me, I promise I won't tell anyone, but then I can tell you if my kid's been around so and so. And I was like, well, if it were your kid, would you want me to tell them, like be all up in your business and tell them who the person is who's sick? And they're like, no. And then it takes them a second to click in that we really would prefer not to practice like an inherent double standard. I'm sorry, I was only looking at the Q&A box. Let me look at the chat box. What resources, Tanya, thank you for this, are available to adolescents to help them realize they're not in this alone? This has been really challenging. So, I try to talk to them about this. This is, we don't have peer support groups in this area that are TB specific. It's hard because it sort of falls into the category of a subchronic disease almost. So I think it's a little bit different than thinking about how do you handle, the diabetic adolescent, where we know adherence tanks during adolescence. But it is important to say, a lot of people who have TB have feelings where they're sad. If you are also having feelings where you feel sad, either about your diagnosis or, sometimes it's not due to their diagnosis specifically, it's because they got TB from their grandma and their grandma just died or something like that, we can refer you somebody, we can have somebody who can chat with you and, talk to you about your feelings. I am probably not the person who's best equipped to have those conversations, but but if we're at least aware of those, then we can refer those kids appropriately. Delphina, did I miss other questions in the chat box?
Let's see. No, nope. Those were the last two.
Okay. All right. Well, thank you guys so much. I really appreciate your time. And Lisa, thank you so much for your flexibility and swapping with me on the schedule. I appreciate that.
But just like I said, remember, in exchange for tacos or French fries.
I love the fact that you come cheap.
Yes, I do.
A lot of love in the TV world.
Oh, yeah. Thanks so much.
Thank you, guys. Bye-bye.
All right. Delphina, can you hear me? Can you see my slides?
Yes, perfectly.
All right. We are hitting the home stretch. I want to thank everybody for staying on with us. We're going to finish up with TB meningitis. And while I don't have anything exciting like the definition of DRO to share with you, we're going to get at least a little bit more information about one of the worst things that we treat in TB. So a little bit about the epidemiology. TB meningitis rates are most affected by age and HIV prevalence, worse in the very young and worse in patients with HIV. That's just across all age ranges of the HIV. Outcomes tend to be worse, but really there's just some specific studies, and there are several who have looked at just kind of overall and pooling the data, but the one that specifically looked at seven-year study in Germany just shows that 0.9% of TB patients had TB meningitis, and that children less than 5 had an odds ratio of 4.9, so almost 5 times greater likelihood. Brazilian study looking at 57,000 patients showed 6% of theirs were TB meningitis. So if we extrapolate what is known about the current global data, it suggests that there could be up to 100,000 cases of TB meningitis per year. Neonatal BCG, very important, and you keep hearing about vaccinations, and one thing that BCG does, it does not protect people from getting TB, since the highest rates are in countries where BCG is given, but what it does is protect against disseminated disease in small children. And basically, it is thought to be 64 to 73% effective in preventing TB meningitis, which averts about 30,000 extra cases of TB per year. So these are the pie graphs that you saw from earlier when I was speaking about the epidemiology. And again, what we're looking at is the little mustard color or yellow pie piece. And for children less than a year of age, 11.2%, this is just in the US, and this is the data in 2017. The 2019 data, very similar. In children less than a year of age, the meningitis cases were 11.2% by 1 to 4. So after they passed that first birthday, we're down to now 6.4%, and then it gets smaller again, 2.9% in children 5 to 9, and then 2.6% in children 10 to 14. And miliary disease again is similarly very small. So TB meningitis tends to be associated more with disseminated disease. Pathogenesis, Rich and McCordock. So always be the first one to discover something, you can name it after you. But they published an autopsy study of TB meningitis patients. And what they observed was that there were granulomas that ruptured into the subarachnoid space. And this basically spilled organisms and infectious particles into the subarachnoid space in just about every single case. So they refer to this as the rich focus. And so like you have the Gone complex in the lungs that you see in children, this is pretty much the lesion that you find in patients who have TB meningitis. So the most common finding exudate at the base of the brain. So basilar meningitis. So this is the meninges at the base. So when you use the word basilar, just base. Histologically, shows a lot of erythrocytes, mononuclear cells, neutrophils, and bacilli, all kind of in the goo around there. Most concerning, vasculitis. The middle cerebral arteries and the circle of Willis vessels are the most commonly affected. And you can see cerebral infarct or basically strokes in 1 out of 3 patients with TB meningitis. And this is across from infants all the way up to adults. The most recent meningitis case I had was here in Texas, Corpus Christi. A little girl had a stroke, and luckily enough, isn't showing any signs of deficit, but we know it's there. So TNF alpha levels show some correlation with disease severity. And this is just, I thought it was a really nice kind of graphic representation. So you start at A with inhalation of the droplet nuclei. And this sets up primary TB disease, or in small children and also patients with HIV who have a harder time containing the organism, you get hematogenous spread. So if you get spread to the brain, then you have a representation here. Here's your blood in your blood vessel running along your brain barrier. So just along the line here, you have migration of cells that are infected with organisms, but there's a thought that some organisms themselves can actually cross the blood-brain barrier. But infected cells then migrate across, and you get infection of astrocytes, and then infected microglial cells, and these are secreting cytokines that draw other cells in. So you get basically an amplification of this process. And here's some of the cytokines that have been associated with TB meningitis. So then you get development of basically your rich focus, which is a ring of cells around your infected organisms. And these are all, again, being called in by the cytokines. And when that focus ruptures into the arachnoid space, now you have a spill of bacilli into the meninges and the cerebral spinal fluid and associated inflammation that leads to hydrocephalus, increased intracranial pressure, and can give you ischemia and infarcts. So clinical presentation. When you are diagnosed matters, more so than how well you are treated, more so than whether you get the steroids on, more so than if you get, we're going to talk about getting drugs into the right place. But right now, our capabilities with regard to treatment and outcomes are really driven still by when you are diagnosed. And stage 1, individuals who are diagnosed in stage 1 are have the best outcomes. Every study that you show, that is the best outcome. But it is notoriously nonspecific. And frequently, because it may originate in the lungs, you get cough, low-grade fever, vomiting, general listlessness. This sounds like every kid with a viral infection and a low-grade fever, and they just feel kind of crappy, and they're kind of fussy. But just generally, the most valuable findings, though, are persistence of nonspecific symptoms and signs. That is the most valuable thing. And I mentioned earlier when I was speaking that if you had one opportunity to teach the people in your ERs that a kid that keeps coming back, you need to think about other things. Like, it's a good time to kind of revisit things and not just assume that this is a partially treated something, but really the persistence of signs and of symptoms and signs of weight loss or recent contact with an active case of TB. Start asking about in the house. Who's in the house? And if somebody else is in the house, do they have rhinorrhea? Have they just had a cough? How long have they been coughing? Start kind of expanding your questions a little bit. So by stage 2, now you're getting meningeal irritation. And you're seeing other neurologic signs, sometimes loss of consciousness, but signs of raised intracranial pressure and paralysis if you're getting strokes and things like that. But stage 3, deep coma, progressive motor paralysis, cranial nerve palsies, because remember, the base part of the brain where the cranial nerves are coming out is where you're getting most of the inflammation. So nerve palsies and the third and sixth nerves and decerebration. But really, this is the point at which kids will have a seizure, and then people start taking things seriously. And it's hard to get some attention paid to this sometimes until the kid seizes. When the kid seizes, then they get a full workup. So in children, TB meningitis tends to develop within 3 months of infection. Within a year of infection, so now this is not a year of disease, but this is within 1 year of inhaling that organism and having that organism set up an infection in the body. So you may have TB infection for a period, but generally in children, within 3 months of being infected, then you will see a child progress. By a year of infection, 75% will progress to will have progressed to TB meningitis, and the pace of infection is quick. So instead of a few things progressing over a few months, sometimes it can be within weeks that the child is decompensated. Important point to note: children have headache less frequently than adults. This is not something that they generally describe. In small children, TB meningitis appears to be closely related with disseminated disease. So that is why we would recommend doing an LP on all children less than 12 months of age. So if you have a child with active disease that is less than a year of age, they tend to, number one, be more likely to have disseminated disease, but number two, to have meningitis associated with it. So the clinical presentation and diagnosis, again, I'm just going to hammer that point, is the strongest predictor of outcome. And hyponatremia, which is generally due to either SIADH or cerebral salt wasting, is very common in patients who have TB meningitis, actually both adults and children. So diagnosis. AFB staining, you have a sensitivity of about 10 to 20%. And that is if you have large volumes that you have spun down and a 30-minute exam by an experienced microscopist. This can increase your detection up to 80%. But I don't know how many microscopists have 30 minutes to sit down and scan that slide. It has to be a grid, up and down, until they've covered the entire slide. Then you only get up to 80%. Culture is more sensitive, but not nearly timely enough to make an effective decision. There have been some studies with GeneXpert, and I list one reference, the one at the very bottom, looked at a meta-analysis of 30 studies, and they found that in retrospect, when you had either probable or definitive TB meningitis, this is culture proven or pretty strong evidence of response to treatment. The expert was about 85% sensitive. If you had just had probable but not definitive, just as a subgroup, then you got to about 81%. but this was again enhanced by large volume taps and centrifugation. So important to note, and this is always a point that we have made, patients with disseminated disease or who are very sick frequently have a negative TB screening test. So this is not the lone test. If you frequently, I will recommend getting 2 tests if it will convince someone to keep to the course with this potentially being TB. But you should never rule out whether a patient has TB meningitis based solely on the TB screening test. So diagnosis, clinical suspicion, that is the first thing you have to have. That is the most important thing that you can have. Typical CSF findings, you heard Jeff mention this in his talk earlier. Lymphocytes tend to be a little bit higher than you see with viral and a little bit lower than you see with other bacterial infections. So kind of about 100 to 1,000 cells. The first day, usually lymphocytes, but the first 10 days, you may see a predominance of polymorphonucleocytes. So just keep in mind that if you get it early enough and you see PBMCs, this may actually be the early stages and you just got lucky to catch it. I would not, say, well, that's not lymphocytes, and rule it out. So elevated protein, these are the 2 hallmarks, elevated protein and decreased glucose over time. You will see that they will have decreased glucose, but a lot of times it's just the elevation in protein, and that's up over 100 to 300 that you see. That should signal you that this is something that you want to consider. Leukocytosis, the laboratory findings, when they look back, children had elevated white counts. CSF lymphocytosis was found in 98% of cases. Fever was a very high indicator. Hydrocephalus, 86%, and then AFP smear positivity in this particular cohort of patients. And it's a one review with a meta-analysis was only about 9%. So that was what I mentioned earlier. The slide before said 10 to 20%. Some studies can get up to that amount, but again, if you're doing a grid search on your slides, you may get there. But culture positivity is about 35%. This was just another reference that looked at some of the same things. In this group of papers that they looked at, AFB smear sensitivity still around 10 to this one got as high as 34%, culture about 50% probably on the average, and expert was about 40 to 70%. The new expert ultra is supposed to be able to get a stronger signal with a smaller number of organisms. It's not available in the US, but you did see a modest increase in sensitivity. But there are other things that, like doing an adenosine deaminase on the CSF or doing an IRA on the CSF, these are all things that require some lab infrastructure. These tend to be in-house tests, and you lose a little bit of specificity in getting more false positives with these tests. There's some other molecules that they have been looking at as potential for future testing. But right now, the diagnostic tests that we have for TB are not great for TB, and they're even worse for TB meningitis. Radiographic findings, as I said, either on the CT or MRI with contrast, always with contrast. You see basal meningeal enhancement, hydrocephalus, again, in children. Look at the contrast between children and adults. 87% of children with TB meningitis will have hydrocephalus, whereas only about 12% of adults. Infarcts, 28% of patients overall, 83% in the middle cerebral artery distribution. And then tuberculomas. Contrast will highlight the ring enhancement of the lesions. So the findings may worsen initially, and this is usually immune mediated. So once you start killing organisms and you get another influx of cells trying to drag the carcasses out, that just kind of packs the area, and you'll see worsening of the inflammation. And this has responded to corticosteroids and thalidomide, and I will show some actual studies on those. So as far as the neuroimaging, this is from a series that the references are below, but This is an example of a child who has now had a stroke, and you see some areas of hyperintense signal basically in the basal ganglia, showing that she has some infarct in her basal ganglia. This is a child, 13-year-old child, who has these like hypodense regions that are associated with the ventricles. And in enhancement, when you give her contrast in the circle of Willis, so the area down at the base of the brain is it shows some enhancement. And then when you look at her cerebellum, you see all of these little lesions here that are almost, they're not quite miliary. If there were more of them and more spread out, but you see these small lesions that have deposited within her brain. This was a child I had, I'll tell her story a little bit later, but most notably here on the left, you see very distinct, pattern of the brain and the CSF. Here it's just her brain was so swollen that you lost all of the structural integrity of the rugae in the brain. And this is just the same MRI slice with contrast. And then you see basilar enhancement down at the base of the brain. You see increased enhancement with the IV contrast. So this was early on, and you see they actually tried putting in a shunt, but she had just increased swelling of the brain and loss of architecture, and also just basically infarcts all over her little head. This is a patient who had congenital TB. It took a while. He started off in the valley, and then he got transferred to a larger medical center. And they were working him up for GI causes because they thought something was going on with his liver. Well, it turned out that his liver was infected with TB, as was the rest of him. But this is a resolving stroke in his little brain. This was at day of life number 30. So treatment. The World Health Organization recommends basically 10 months of INH and rifampin with 2 months of PZA and ethambutol added to that. And so you get 2 months of all 4 drugs, and then another 10 months of isoniazid and rifampin to give you a year of treatment. And the rifampin dose recommended there is 20 milligrams per kilogram, and that is an increase. So the AAP Red Book, and I had to scramble when I first finished my slides to go make sure it still said it, but basically I recommend 2 months of rifampin, isoniazid, and PZA, and then you add either an aminoglycoside or ethionamide. And as Jeff mentioned, the rifampin dose recommended is 20 to 30 milligrams per kilogram. Interestingly, in South Africa, all of the children are treated for, so this is, again, with the AAP Rex, tend to be for 12 months. In South Africa, they treat children for 6. They treat them with high-dose isoniazid, and that's 20 milligrams per kilogram of isoniazid. So when we think high-dose isoniazid, I don't know what we're thinking, but they're thinking twice what we normally treat with. High-dose rifampin, which they consider to be 20 milligrams per kilogram, standard dose of PZA, which is 40 milligrams per kilogram, and then ethionamide in place of ethambutol because it does get across the blood-brain barrier. They do that at 20 milligrams per kilogram. They give all 4 drugs for the entire course, and I'll show some outcomes from their studies. But first, the important thing is if you can't get the drug to where the bug is, then you're just not going to make any headway at all. And so this is an older paper, 1992. It's still in med school. Don't judge me. But just looking at the CSF after, and they did time studies. So doing a draw, 0 to 1 hour, 1 to 2, 2 to 3, etc. And so in the first hour, basically the highest concentration is in the plasma of isoniazid, and this is after taking an oral dose. And then you get to at hour 2, you're starting to see representation in the CSF. But more importantly, by 2 to 3 hours, you have almost equivalent amount of isoniazid in both the plasma and the CSF. So this is an excellent drug at getting into just about every place you're trying to get it into. And even once you get to 4 to 5 hours, it's actually a little higher, 4 to 6 hours in the CSF, because it's kind of running that way and it's not leaking back out. So an excellent, this is kind of our workhorse drug in making sure that we're getting in and getting to where the bug is and getting something dealt with. So they looked at the influence of dosing, on the range of 2 to 4 hours. And again, you see that very similar when you look at just the 2 to 4 hour time range, either dosed at 10 milligrams per kilogram or 20, which is what they use in South Africa, very much the same. So when you increase the dose, you just get increased drug crossing the blood-brain barrier. This ethambutol, not so much. Patients 1 through 4 are healthy controls, and you see I'm not sure why you would agree to let somebody do an LP on you, but they did. And if you look at the serum concentration of ethambutol versus the CSF concentration, very different and very low. And then if you look at, so patients 11, 12, and 13 are all patients who have TB meningitis, and you look at the serum concentration versus the CSF concentration is again very, very low. This is over time. So they're drawing, these were all just one dose. So these were normal healthy controls, and this was the group in the middle were people who had meningitis but not TB meningitis. But when you look at patients with TB meningitis and measure on days going forward, again, the levels are all really low. So this drug, ethambutol, is adding nothing to the treatment of your patient. You're not getting the drug in there. This one I thought was interesting. This is a look at the pharmacokinetics of PZA, isoniazid, and rifampin. So we're going to start with the, and this one, I like this study because it was actually done in children. And so Asian patients tend to be slow acetylators. So they divided the isoniazid into rapid acetylation and slow acetylation, but they also looked at children who were less than 4, which is our group that we're most concerned with being most vulnerable, and then the children greater than 4. So starting over on the left, the important thing to note is that the open circles are serum, are basically serum data points, and the shaded squares, those are CSF data points. So right on cue, you see the CSF data points start to increase. After a couple of hours, you start seeing representation of the drug in the CSF, and that's all nice. Here's the wild type MIC. So this is what you need the minimum inhibitory concentration to knock the bug down. We're very, well above that, which is nice. In both patients who are less than 4 and patients who are greater than 4. And then the fast acetylators basically just break down the drug a little bit faster. So you see them start to kind of peak up and drop off pretty quick. But again, you're getting good representation of the shaded squares with, they're matching up with the serum concentration. So that's a good thing. And then you look at PZA, more of the same. So the wild type MIC for PZA is a little bit higher, but you still seem to be getting most of your data points after about 4 hours well above that. And we're getting a lot of the shaded squares very close to the open circle. So basically the levels in the CSF are matching what you see in the serum. And if you're trying to get something into somewhere something is to kill it, that's a good thing. Now, rifampin. We all know how important rifampin is. If you do not have rifampin in a regimen, then basically you have essentially rifampin resistance disease has been elevated to very similar to MDR treatment, because it is probably singularly the most important drug in regimen in the standard drug susceptible regimen. And when you look at this one, here we have all of our open circles, which represent our serum drug levels. And then down here, all of our CSF levels are bunched up way, way below the wild type MIC. And this is at the standard dose of about 10 milligrams per kilogram. So the standard drug dose we know is not adequate. And so that's one of the reasons that the World Health Organization and the AAP has recommended higher dosing. And if you have a child that you suspect has disseminated disease or who has TB meningitis, your starting dose for rifampin is always going to be 20, but likely, as we're seeing here, should be higher. So this was, I added this in more so just kind of a repeat of same. This is another study where they showed very similar data. And you look at here's the dose of isoniazid, somewhere, close to 10. So somewhere between 5 and 10 milligrams per kilogram. And you look at the serum doses over time, and the CSF doses after about 4 hours are matching up pretty nicely. And so it starts off a little higher, of course, in the serum, and then starts to escalate in level in the CSF, which is a beautiful thing to see. But then we're over here with rifampin, and you see that the serum drug levels are far higher. This is at 10 milligrams per kilogram, which is the standard dose that we were treating kids with forever. And this is really kind of our dose for adults if they weigh 60 kilos or less. I don't have too many of those, but anyhow, so you look at the serum drug levels and compared to the CSF levels, and they're really, really low. And just at the bottom, just for comparator, so this is comparing every drug across here to PGA. So when you say predicted CSF penetration relative to PGA, PGA is relatively 1 against each other. But when you look at ethionamide, it's greater than 1. So even better than PGA getting into the CSF is ethionamide, which is one of the reasons why that drug is used, especially overseas. But this drug, double-edged sword. So getting a high enough dose to get for it to be effective without causing GI upset, that's a really fine line. But compared to PGA and their studies, isoniazid was, only 1/10 of what you got in for PGA. But I get the ethambutol at 0.009, strep 0.005, and rifampin coming in lowest at 0.002. So we know we need this drug, so we're working with that one. But I would not expect that an injectable or a ethambutol are adding anything to your patient's care if they have TB meningitis. Just some more recent studies. This is a paper by Kelly Dooley. Rifampicin, about 10 to 20% CNS penetration compared to the serum, and the biggest reason is it's highly protein bound. Ethambutol, 20 to 30%. But when you look at the fluoroquinolones, they're all very similar, 70-80% for both levofloxacin and moxifloxacin, just behind ethionamide and cycloserine. So, and then linezolid, again, 70%. So all of these, show a lot of promise for getting into the CSF. This was a study I promised to go back to look at. This is the regimen that I had spoken of earlier with high-dose rifampin, high-dose isoniazid, standard PGA, and standard ethionamide, all given, all 4 drugs for 6 months. And this was their outcomes. So they just wanted to point out that there are some instances where the treatment needed to be extended. And in HIV patients, HIV positive patients or patients with INH resistance, they did extend the treatment to 9 months. And then they had prolonged treatment, and this stands for anti-tuberculosis drug-induced hepatotoxicity. So patients who had hepatotoxicity and had to have drug interruptions had some extension of the treatment. There were a lot of them had TB mass lesions that had tuberculomas. They were concerned that doing the short course treatment was not going to adequately address that. And I think the study is interesting, but like I said, we have never on the U.S. side given isoniazid doses that high. 20 milligrams per kilogram gives me a little riddle reflux, but it apparently it does work. So they have been using it, and by extending the treatment in the patients who need it, they were just showing that they had very similar outcomes across the 3 groups. Now, so looking at intensified regimens for TB meningitis, we do not have a study in children. We have studies in adults, and particularly the one on the left looked at standard 10 milligrams per kilogram of rifampin versus increasing rifampin to 15 milligrams per kilogram, which I felt like is way conservative. If you were going to do the study, I'm thinking they could have jacked it up a little bit higher than that. But they also looked at adding 20 milligrams per kilogram of levofloxacin to that kind of wimpy dose of rifampin and didn't see a significant difference, which was kind of, it's kind of disappointing because I didn't feel like they either addressed whether the fluoroquinolone added anything to the regimen, and they didn't really look at whether increasing the dose of rifampin did. But if you look at the study on the right, they essentially 450 milligrams PO of rifampin was compared to 600 milligrams IV, which is pretty much double the dose. So if you 600 milligrams IV is pretty well equivalent to 900 PO. And when you double up the dose, you see a significant improvement in survival in patients who are treated with high dose rifampin. So there does seem to be some good outcomes with that. The fluoroquinolone, so they have looked at replacing ethambutol with a fluoroquinolone, replacing rifampin with a fluoroquinolone, and the studies that have been done to date just don't seem to answer the questions, I don't think, effectively. Plus, they haven't been done in children at all. This was one looking at linezolid, and so this was on the left, the characteristics of the linezolid group and the control group, and then these were the regimens that they used, and these are the dosing. You see the standard dose of isoniazid, rifampin, little on the lower end compared to what we would use now. PGA, that one was also a little low. We're closer to 40 milligrams per kilogram in children. And then they did a linezolid 10 milligrams per kilogram every 8 hours if they were 12 years, 0 to 12 years, and then 600 every 12 hours for if they were over 12 years old. So this is closer to the standard dose of treatment rather than what we normally use for MDR TB, which is 600 milligrams once daily. But what they found was when they looked at poor outcomes, you were far more likely to have poor outcomes in the control group. You were far more likely to have persisting fever. It took longer for you to clear your fever if you were in the control group. It took you longer stays in the hospital. Greater than 2 months was associated with being in the control group, and then adverse effects overall were about the same. So you seem to have some benefit in outcomes, fever clearance, and then shortened like hospital stay. All seem to respond well to being given linezolid in your regimen. So now rifampin. Back to the one drug that we know that is probably the most important for most of the things that we're trying to do. And when I put in this slide, this is a study in adults, and they're looking at, they've gotten as high as 35 milligrams per kilogram of rifampin, feeling like this is important, and just driving the dose as high as possible. I went with Dr. Seaworth to a meeting, and I think when they first started talking about this and at the international conference a couple of years, like maybe 3 years ago, and they have gone up to 50 milligrams per kilogram in adults. of rifampin and 70 milligrams per kilogram of rifampin in children, and they're still not seeing significant toxicity. And so that was the top table 2, basically showing adverse effects. You don't really see grade 3 or higher effects. Most of the related effects to the increased doses were associated with basically just GI upset. When you got the doses that high, you were basically having the kids drink a sludge, and that was upsetting their stomach. But you never saw hepatotoxicity, for example. The magic number, what you're looking for, is an area under the curve of about 100. And if you look at the graph on the left, especially the one looking at area under the curve, the magic sweet spot at 100 is about 20 milligrams per kilogram. And so that's where it starts. But efficacy just keeps increasing with the increasing dose. So we are just still scratching at the surface with rifampin. We're not even close to there yet. Adjunctive therapies, steroids decrease mortality. That is just the most important point to remember. Steroids decrease mortality, but they don't affect morbidity. So your outcome, this is important in kids because you have a child who's developing and suddenly the course of development has now been skewed. And then if they have some significant underlying brain damage associated with TB meningitis, then you have now altered the course of their lives from a very young age. So this is not a trivial thing. Aspirin does show clear benefit in adult patients, and we're always looking at when you have a patient who has vasculitis, that is a setup for some kind of bleed or some kind of bleeding incident, and aspirin is generally the answer for vasculitis. And it's shown clear benefit in adults, but when they did the same study in children, did not show an effect on either morbidity or mortality. So right now they're trying to ask a different question. So we don't know that the children didn't respond to it or that they need a different dose. So I said earlier that children are not just small adults. Children are children. How they metabolize is as children. How they, how they clear a drug, all of that is very different than you see in an adult. And I'm going to show some information. I'm going to show a study where they actually looked at thalidomide, pulled out an old drug and dusted that off. So this is the study where we really first started looking at seeing that dexamethasone will save a life, but it does not really impact the outcome. So these were looking at all patients, and these were basically the proportion that were surviving. And clearly you see a huge difference when you give dexamethasone. You see an improvement in outcome in patients who are alive over time. And then this is out to 300 days. So this was a 9-month follow-up. You had a significantly higher number of patients who were still alive at the 9-month reevaluation. But when they divided it into patients not infected with HIV and those with HIV, you see that HIV does create more problems for the patients. If you look out at the 9-month point, essentially it was unchanged. But if you look at the total number of patients that they randomized, good outcomes seem to kind of lean toward being on steroids, but it was not statistically significant. Not the same for intermediate. Almost looked a little worse if they were severely disabled, but you looked at the difference in death and with the placebo, which is higher, and with it being on steroids, and there was a significant. These numbers here were significant. Thalidomide. I remember the horror of thalidomide babies. Women were given thalidomide for nausea early in pregnancy until they figure out that it was highly teratogenic. And this is the poster child for things you don't want to give a pregnant lady. But they looked at thalidomide and for its anti-inflammatory properties and using it in complicated CNS TB in children, and basically published an observational cohort. So you see the lesion in the child in figure 1, basically getting down here toward the base toward the base of the brain, but a little bit over to the left side. And this is the baseline lesion before administering the drug, and you see very complex lesion here presented, and you see a lot of kind of ventricular enhancement here. And this is 4 months after giving the drug. You see that the ring enhancing lesion is a much smaller on both the sagittal and the coronal, not coronal, the sagittal. I'm blanking on the other view, but also you see a significant decrease in the amount of paraventricular inflammation. This child here on the 20-month-old presented with blindness and a significant amount of disease at the base of the brain. And after 3 months, after 3 weeks of treatment, the child's sight returned. And after 4 months, you see a significant decrease in the size and the complexity of the lesion. So this is something that's where it's another one of the things that's being looked at. Treatment trials. Oh, do we need treatment trials? We figured out that just kind of the outcomes, and I'll talk about the outcomes. I saw one meta-analysis that showed the outcomes probably over the last 20 years have not changed. I think that is bad. I have no words. We have had if you had TB meningitis as a child 20 years ago, the chances that your outcomes were going to be the same as they are to this day, with all of the advances that we have and everything that we know, we still haven't made a dent. So there are some studies that are looking at trying to optimize the treatment. First one you see at the top, the OptiRIF dosing. This includes meningitis, but really it's just in all children with severe disease. And they're starting with escalating the rifampin dose up to 35 milligrams per kilogram to see if you can improve the outcomes of children just by getting the rifampin doses higher and getting more effective treatment that way. You heard Jeff talk about the SHINE trial, which really is exciting because now we have a 4-month regimen for adults, having a 4-month regimen for children, and knowing that we're treating, especially if we're over-treating, would be awesome. The TBM, which stands for TB meningitis kids, the third regimen down, is looking at both high-dose rifampin and levofloxacin. So we're looking at adding the fluoroquinolone in with isoniazid and PZA. So you have high-dose RIF, a fluoroquinolone in place of ethambutol, and then isoniazid and PZA at the standard dosing, which sounds like some of the things that we do here when we get we have kids with meningitis, and it would be nice to know that this is actually showing some efficacy. The SURE trial was another trial that is looking at high-dose isoniazid and high-dose rifampin, basically spinning off the study of the treatment in South Africa, but replacing ethionamide with levofloxacin, and then doing the standard dose of PZA, and then doing that for 6 months, basically replicating what they're doing in South Africa with levofloxacin in place of ethionamide, and then comparing that to the standard 12-month regimen. Stay tuned. Hopefully we will have something that we know a little bit better soon. So outcomes, again, I present this case. I presented this baby before just because it bothers me, but we had a 20-month-old female that immigrated from Afghanistan. She had immigrated 3 days prior to presenting to an acute care clinic for the first time. So in her first visit, the complaint that they got, and they spoke Pashto. They did not speak English, which I don't know that would have changed things, knowing the other kids that we've gotten that had TB meningitis, but the mom's chief complaint was that she had fever, she was fussy for 2 days, she had a runny nose, some congestion, cough. On exam, she did have clear rhinorrhea. She had a right her tympanic membrane was dull on exam. So she was given the diagnosis of acute otitis media, and she was given amoxicillin. And to their credit, they had her return. So that they didn't just cut her loose, they had her return. So 6 days later, she comes back for a follow-up visit. She's had subjective fevers now for 2 days. She had fevers before and didn't say if it responded, but what they documented was now subjective fever for 2 days, nausea and vomiting now for 5 days. Every time she eats something, she had vomited 3 times that day. So on exam, she had exudate in both ear canals, and she was given a diagnosis of acute suppurative otitis media bilaterally. She was given 1 shot of Recefin IM. She was given Septanir and Zofran for the nausea, and she was discharged home. So 3 days after this, she's still vomiting. So again, they shortened the time for her to return. So instead of just cutting her loose, they shortened the time. Instead of 6 days, now she's got a 3-day turnaround, and they want to see her again. She's still vomiting 3 times a day, despite the Zofran, fever for 7 days now, cough, congestion, no rhinorrhea. So her exam showed exudate in bilateral ear canals. She was fussy throughout the exam. They couldn't tell if it was distress over just the medical personnel, her being around somebody she didn't know. She's a 20-month-old, and they will let you know, these little ones, if they don't like you. But this time they gave her IM Zofran, and they sent her to the hospital for admission. So during the hospital admission, her CMP came back with a sodium of 130, which is low, high white blood cell count. Remember, I talked about leukocytosis in children. She had evidence of like basically chronic anemia of chronic disease. Hemoglobin's 9.9, hematocrit's 32.3, and very high platelets, which we frequently see in patients with TB disease. Her respiratory viral panel was negative. Her abdominal ultrasound was normal. She's been vomiting, so they checked to make sure she didn't have some kind of obstruction or ileus. They treated her with ceftriaxone fluids for dehydration, as they said, and more Zofran. And then they discharged her home after they corrected her complete metabolic panel showed a sodium of 139. So now they have fixed, the hyponatremia, and off she went. But now she shows up at refugee clinic. So 2 days after that hospital visit, now they're in to refugee clinic for the family to be evaluated for TB. She's still vomiting 3 times since the night before, fever off and on, still taking the antibiotic that they gave her on the last visit. The right ear is still discharged, discharging. The left tympanic membrane is dull. HIV, Hep B core, and surface antibody were non-reactive. The surface antigen were non-reactive. Her surface antibody indicating that she had been vaccinated against Hep B was high. White count still high, still anemic, still high platelets, sodium 131, and 3 days after that, she ceased. After that, she was admitted to the PICU for evaluation. So unfortunately, despite shunt placement, the patient's brain swelling worsened. Testing did reveal brain death, and support was withdrawn on hospital day 5. And unfortunately, the patient's family was in our clinic that day, and we had to let them go back so they could withdraw care from their child. But treatment outcomes, again, are based on when you are diagnosed. So looking at 19 studies, all comers and diagnosis at all stages 1, 2, and 3, the risk of death is almost 20%. So 1 in 5 children with TB meningitis will die. The probability of survival without neurologic sequelae, about 36%, 37%. So the chances once you have TB meningitis that you will survive without some deficit is only about 35%. Risk of neurologic sequelae, over half children will have some long-term disability or some long-term neurologic issues concerned with having had TB. And if you're diagnosed at stage 3, that's 47%. So that's the worst prognosis, that's associated with worse prognosis than the earlier diagnosis. So 47% likely death. So this was the looking at death or severe disability. This is the British Medical Research Council came up with clinical criteria for severity of TB meningitis. And so I told you earlier about stage 1, 2, and 3. And so this is a kind of a mashup of 2 different things that I just then made the table since they didn't add one. If you're diagnosed at stage 1, or then your chances if you're HIV negative of death or severe disability are as low as 15%. Whereas if you're diagnosed at stage 3, that goes all the way up to 50%. And then if you're HIV infected, you start, even under the best circumstances, with a 25% chance of death or severe disability, and then that goes all the way up to 80% if you're diagnosed at stage 3. This was a child this was one of the babies I mentioned earlier. It was a congenital infection. It took a while for them to finally they did an aggressive workup on his abdomen and finding nothing. Interestingly, the PDID doc walked in and the first thing she said was TB. And of course, they had CSF that was AFB smear positive. The acidic fluid was AFB smear positive. The tracheal aspirate also AFB positive. So I sent this to a friend of mine, and I told her I'd never seen anything like this before, and I'm not sure what I'm looking at. And what she told me was that every area here, that this is basically brain matter that has been replaced by CSF. So she said, everywhere that this child should have brain matter, basically he has CSF replacement. And this was his day of life, 61, after 2 months in the hospital when they were sending him home. He has remnants of brain, and she told me essentially he has an intact brain stem, but the rest of this is where his brain should have. So some take-home points. TB meningitis is unique in children in that the brain is still in the process of developing. So if you have a devastating infection, then you have devastating consequences long-term. So you can save the child. You can give the child treatment. You can give the child steroids, and you can preserve that child's life. But really, the outcomes for that child's life long-term, if they're not diagnosed early, are bad. So early diagnosis is critical. It's critical to prevent morbidity, but unfortunately, most diagnoses are made late. And this needs to change. We went back, and I actually, the child that I presented, Dr. Seaworth went back and spoke with the chair of pediatrics and talked him through what we had found and what the outcomes were with the child. And he had to I went over and gave a grand rounds to them, focusing more on early diagnosis and involving the health department if you have any questions. And so I have not seen another case of TB meningitis since this child, I don't think. I think about it, but I'm not. We've had some we've been consulted on, but I don't think we have seen another case here. More studies are needed in children to maximize outcomes. We have got to do better. Everything from diagnosis to treatment, we need to do better, because if 20 years of no improvement is just not acceptable. Rifampin dosing, so important, so poorly done, and so little data. So I showed you 2 studies at least where they're looking at higher dose rifampin. So hopefully we will get to some answers there. And then the PK/PD data just needs to be pursued with all aggression. We need to know what's getting into there, what's killing things, what's working. Need to answer the questions with the fluoroquinolones once and for all, because there is data that shows that there may be some improvement in outcomes, but there's some data that suggests that there's really not much change. And so I want to just say to everyone, thank you so much for hanging out with us. It's been a long day. Thank you for joining the webinar. Obviously, we're here at Heartland. If you have any questions, feel free to email me directly, call us on the 800 number, or hop on our website and contact us. Thank you, and I'm going to hand it back over to Delphina.